So, good afternoon, everyone, and welcome to Asia Diabetes Forum Masterclass in Diabetes. A ray of light is a ray of hope. Let's leave the darkness and step towards the bright path. Now we'll have a traditional lamp lighting ceremony, a tribute to Goddess of Knowledge, Ma Saraswati. May I request all the dignitaries for lamp lighting and symbolically inaugurate today's event. Mother, we pray for your blessings with our humanity. Give us blessings to make the world a better place. So with these words, I want to call upon our dynamic organizing chairperson for this event, none other than Dr. Bharat Sabu, to please take the proceedings.
Shubham kurutvam kalyanam arogyam dhanasampadah. Shubham kurutvam kalyanam arogyam dhanasampadah. Shatru buddhi vinashaya deepajyotir namostute. Deepajyotir namostute. Deepajyotir parabrahma. Deepajyotir janardanah. Deepajyotir parabrahma. Deepajyotir janardanah. Deepo hartu me papam. Sandhya deepa namostute.
Thank you.
Thank you, Dr. Sonika, and I welcome you all for being here for inauguration ceremony of this Masterclass in Diabetes, which is being co-organized by Asia Diabetes Forum and Prayas for Care of Diabetes Society. So today I just want to quote one thing, that is a one small step for mankind, but a giant leap for mankind, because this was the word which was told by Neil Armstrong, and these are the small steps which we need to take towards our fight against diabetes. So on this day, I can say that diabetes. Can I ask you to mute yourself, please? So diabetes management is going through, we all know, through a shifting period where we are changing our ways from traditional ways of treatment towards prevention and evolution of more focus towards lifestyle and diet. And now it is equally concerning that in spite of all our efforts, the disease is treading at an enormous pace and we are seeing complications day by day. So the idea of this Asia Diabetes Forum, because we Asians are having a unique genotype and phenotype, we all know, and that is how we are differentiated from rest of the world in terms of our metabolic health and metabolic needs. So it is a platform where we all will incorporate together to promote research, to share data collaboration, and emphasize on the teachings and the various ways which we can help each other. So we will all be having all the best brains who are dealing with the beta cells, and we will be targeting diabetes. This is the motto of this platform. And this year, I am actually humbled by the presence of our esteemed speakers who are there with us. Along with that, I would like to thank Dr. V. Mohan sir for being here, Dr. Banshi Sabu sir, Dr. Jyoti Dev sir, all the other esteemed, my dear friends, Dr. Noshe Yusuf from Egypt, Dr. Deena from Nepal, Dr. Indu from Saudi Arabia, she is there, Dr. Farooq from Bangladesh, Dr. Amanat, he is there from UK, Dr. Puneet, he is my very good friend from UK again, and Dr. Alexander is from Indonesia. All these have formulated this program, and now we are able to give it in front of you. So I am actually humbled again by presence of our three guests, which I would like to introduce to you. Our first guest today is Padma Shri, Mrs. Janak Palta. Janak Palta is a Padma Shri awardee and director of the Jimmy McGillan Center for Sustainable Development. And she is the co-founder of Jaivik Setu and national coordinator for the Solar Food Processing Network India. She has been awarded Padma Shri, Rajmata Vijayarata Sindhya Social Service Mano Seva Award, Bhavna Samman, and Paryavaran Mitra Puraskar. So we give a floral welcome to ma'am. The next chief guest which we have today with us is Mr. Bhalchandra Dattatreya Monde, who is commonly known as Bhalu Monde in Indore. He is an Indian artist, photographer, sculptor, and painter from Madhya Pradesh. In 2016, he was bestowed Padma Shri by President of India for his lifetime work in photography. And he has authored 2 books regarding the birds of Sirpur. So he co-founded the Nature Volunteer Club. So we welcome you, sir, with this floral welcome. Our third guest today, which we have, is Mr. Ajay Vishnoi, a former health minister from MP state government. And we also welcome you, sir, with this floral bouquet. With this, I again hand over the session to Dr. Sonika. Dr. Sonika, please unmute yourself.
Thank you, Dr. Bharat. A good teacher is like a candle. It consumes itself to light the way for others. Thank you for your sweet words, Dr. Bharat. May I request our chief guest to say a few words? May I request the first chief guest?
Dr. Bhalu Monde, sir, please, if you can.
Good afternoon, everybody.
We are honored, sir.
सबको अब मैं कुछ अभी बात करूं या बाद में करूं?
नहीं सर, आप बोलिए।
नहीं, अभी करिए सर, अभी करिए।
अच्छा अच्छा अच्छा। मैं my profession is a photography और over 50 years I am doing that now in the working. Since before that 1975 I was 15 years in Europe, America and England. I stayed there 15 years, done my professional course and many things there in photography. Then I shifted to India in 75 and since that I am doing in Indore, Madhya Pradesh, Chhattisgarh specialization in the tribal work, jungle, then environment, tiger projects in Madhya Pradesh and Chhattisgarh, then birds of सिरपुर, मतलब इंदौर में सिरपुर जो लेक है हमारा 800 एकड़ का लेक है, उसमें हमने पूरा काम किया है, उसको सर्वाइव किया है पूरा. इस वाज गॉन टू डॉग्स, मतलब इतना खराब था 80 के 85 में. तो तब से हम 30 साल से काम कर रहे हैं एक ही लेक पे. वो आज सुंदर एक 160 वेराइटीज ऑफ बर्ड स्पीशीज आता है. और आपको जब भी कॉन्फ्रेंस इंदौर में होती है आपकी सब लोगों की, तो प्लीज इन्फॉर्म मी, आई विल टेक यू देयर माई सेल्फ एंड शो यू द लाइक सुरखा फ्रॉम बाहर से, हिमालय पार से आते हैं, बार हेड गीज आते हैं और फ्लाई कैचर, इंडियन फ्लाई कैचर आता है वहाँ सब, मतलब सारे 160 वेराइटी के बर्ड्स वहाँ पे है. एंड एक तादाद में जैसे कूट है, जैसे कूट नाम का एक बर्ड डक है, उसमें 10 से 20 हजार बर्ड्स अभी शुरू हो गया आना. तो जनवरी तक 15 से 20 हजार बर्ड आपको एक साथ दिखेंगे एक तालाब में. वो इससे हुआ है कि वो गंदीवाड़ा जो था नगर निगम से हमने टाई अप किया, फिर एपको मध्य प्रदेश जो डिपार्टमेंट एनवायरनमेंट का मध्य प्रदेश का सरकार का, उनके साथ टाई अप किया. उनके साथ प्रेशर लाके हमने, वो हमारा प्रेशर ग्रुप है, वी आर मतलब गिविंग ए प्रेशर टू सरकार एंड नगर निगम एंड पीपल also that we should do this ऐसा करके हमने 30 साल से, it was a single man me for 10 years. After 1992 we have established a nature volunteer as a NGO established, and since that now that NGO also 25 years now we are already running established NGO, and we have the books like birds का book है, हमने ये लेसर फ्लोरिकन का बुक है, ये हमारा प्रोडक्शन है हमारा नेचर वॉलंटियर का. जो वैनिशिंग बर्ड्स ऑफ मध्य प्रदेश है ये अभी आया है, मतलब 1 महीना पहले ही बुक्स निकाला मध्य प्रदेश गवर्नमेंट ने. और देन बर्ड्स ऑफ इंदौर.
थैंक यू. सॉरी फॉर इंटरप्टिंग मिस्टर डॉक्टर भालू. we can have with you a chat for a long time.
Yes.
It's really pleasant to see such a big list of your work.
Actually,
and I am surely coming over to Indore to admire all your work.
What Bhalu sir is saying is next event should be in Indore and it should be digital. So that
So
is the
you can log me and Dr. Bharat.
promoting the Sirpur Lake. And just to add in 30 seconds, it was a very dirty pond which has been created to a heaven due to effort of this man who is with us. So a round of applause for him.
I think
Pond.
I'll take 1 minute more. Best remedy for your diabetic and all that for people, they should go walk in the nature, and it will release. The mindset will be perfect for the getting rid of the diabetes, and that is what I will request everybody, that they should go in the nature, close to nature, continuously in the future life. A lot of remedies will be clear with the nature. In fact, I have tried myself. I am 50 years now working. I am over 75 already. So still I can walk 15 to 20 kilometers every day. Even no problem.
Thank you, sir. Thank you.
Thank you, sir.
Right. Thank you.
So, Dr. Sonika, now move on to the awards to be given by Bhalu sir to our esteemed.
Please take the proceedings, Dr. Bharat, the awards to be given.
Nirav, can you? So our first award is from a Padma Shri to a Padma Shri. Dr. Bhalchandra Dattatreya Moge will be awarding Dr. V. Mohan sir for the Diabetes Researcher of the Millennium Award. A warm round of applause for Dr. Mohan sir. We all know his contribution in the diabetes research we have. Dr. Mohan sir, please, few words.
Yeah. Thank you, Dr. Bharat Sabu. I was pleasantly surprised when you told me that you're giving this award to me. It means a lot to be recognized by your own staff, and thank you to Balu sir for giving this award to me. Every year I've been watching your academic pursuits go from strength to strength. And more recently, I've been watching you on social media, all your motivational quotes, which I look forward to every morning. Beautifully done. And I can see that you're full of positivity. And I think what Balu said about being close to nature is very true. And also filling your mind with positive thoughts is one of the ways I think chronic diseases like diabetes and heart disease and hypertension can be controlled, because a lot of negativity, and that negativity creates a lot of hormonal imbalances and so on. So I think apart from all the other medicines and everything that we learn about in these conferences, I think integrated medicine, where holistic nature of medicine is something which the allopathic system seems to be far behind the alternative systems. And nothing prevents us from adopting all of that, whether it's yoga or pranayama or healing and diet, physical activity. All of them, I think, are extremely important. So let me congratulate you on this great conference. Some echo. Can the others mute, please?
Yes, sir. They are all muted now.
Okay. So congratulations, and keep up the great work that you're doing. I'm very privileged to be here, and thank you very much for this award. I'm very grateful to you.
Thank you, sir. We are always looking up to you when there is a word about diabetes research in India, and this is nothing.
Yes.
The understatement which I am giving.
Anything related to diabetes, we all are looking up to Dr. V. Mohan.
Thank you. And I'm also privileged to have Dr. Banshi Sabu, Dr. Jyoti Dev, and many other good friends here in this event. And congratulations to all the other awardees as well.
Thank you. And the next award which we have today with us, Nirav, can you? So the next award is for leading the diabetes awareness initiative of the millennium. I was a part of it, and I tell you, this was a mammoth task, defeat diabetes. So none other than our own Dr. Banshi.
First of all, thanks, Bharat, for awarding me. I don't know, I'm getting, so congratulations, Bharat, for this Asia Diabetes Forum, and thank you. I don't know, there is some voice, some background voice is going on.
Yes, sir, there is some humming. I don't know from where it is coming.
Hardik, can you do something for this?
It's better now, I think. Try again.
It's from Hardik.
Thanks, Bharat. First of all, thank you for recognizing me. But I believe that it is not just because I am Sabu and Sabu is giving. So, I mean, there should not be a conflict here.
Even the first
But
name
I
starts
feel
with B.
proud because, you know,
Even the
I've
first
been
name
awarded.
starts with B, and so there's a lot of confusion.
And I feel proud, you know, and privileged also that, you know, you are awarding me on the same platform where we are awarding Dr. V. Mohan sir. So it's really great pleasure for me to be with you. And you are very close, that we all know, and you are really doing great work. This time in RSSDI also, we recognized you from Central India, an upcoming researcher from central part of India. Is you could make this Asia Diabetes Forum where you could involve many doctors other than India from Asia. And that's really great because we want to collaborate more with our neighboring countries and these Asian countries from Indonesia to Middle East, and some of them are there already, like from Nepal and this. So just to tell all of you here that me and Mohan are very actively involved in Diabetes Asia Study Group. So those who are not the member, and this is the platform where I think I should talk about that, those who are not the member of Diabetes Asia Study Group, please become the member. For life membership, it's only $100. So I will again ask Hardik to send all of you a form and you can fill in. So it's like if you are really actively interested in Diabetes Asia, where me and Dr. Mohan sir, Dr. Shashank sir are involved since last so many years, and many members are there from our country, but this is a very young diabetologist group from all across the country. So I will.
Bansi sir, sorry to interrupt. Bansi sir, sorry to interrupt. Nirav, can you please mute everyone? There is some humming which is coming up.
Yes.
Is it fine now?
No, sir, there is something which is coming.
Now I think better from my side.
Someone's mobile also is logged in through this, so that is the reason why it is humming right now. There are two logins from one would be
Yes,
from.
maybe it is creating an echo. So everyone should use that which is on.
So this is one request that from my side, as well as I will put it from Dr. Mohan sir also, that those who are not the member of Diabetes Asia, they can become the member. Sir was past president of Diabetes Asia Study Group, and we have our journal, which is Journal of Diabetologists, where sir is editor-in-chief. And again, I will request all young diabetologists of our country who are there, if you want to publish anything, sir is very helpful and always welcome newcomer like me also, So for if you have anything in research, you can send it to the journal and with peer review. Not only it will be reviewed, but sir personally will see that it get published also. So I mean, that's one other request which I can tell everyone, that if you are sending or if you are doing any research, anything new, please join for that. The third thing from RSSDI, as a being immediate past president, now I am research committee chairman. So again, I will request, because now every 3 months we open the for application for grant. So if you have anything in your mind and related to research project, please do it. And in month of March, last week of March, we have research retreat meeting, a first time a unique meeting which we have, or which we are going to organize under RSSDI, which is whatever publication, whatever work which we have done in last 3 years, and if it is published somewhere through this platform, you can share your work on research retreat platform. Again, Dr. V. Mohan is the senior most member, and I think I should not say because of the virtue of immediate past president, I am the chairman of this research committee, but actually it is a baby of Dr. V. Mohan, and he is research committee chairman of RSSDI, being a patron of RSSDI. So again, my request to all of you, if you have done any work in last 3 years which is published anywhere, again, I will request you to send it for research retreat. And once again, congratulations, Bharat, and for Asia Diabetes Forum. I can see here very close friend of mine, Dr. Jyoti Dev, who is there. Thank you, Jyoti. And you can see many more friends here. Vipul, the Bichandani sir, Ishita, Dr. Raka, Abhishek, Daria, Amit, Rajneesh. So all of you, good afternoon. And once again, thank you, Bharat. Thank you.
A huge round of applause for the task of the millennium, defeat diabetes. So our third awardee we have with us is none other than Dr. Jyoti Dev sir. He is the diabetes technology man of the millennium, because everyone will agree to it. No one has done so many things, so many research, so many publications in diabetes technology than Dr. Jyoti Dev sir. Dr. Jyoti Dev sir, we welcome you here, and we are honored to give you this award.
Thank you very much, my dear Dr. Bharat Sabu. My respects to Padmasri Bhalu Monde. So all my friends, I am very excited. I am very excited because of multiple reasons. First of all, this is the first time I am receiving an award with this title, Technology Man of the Millennium. So thank you very much. And this is, of course, a recognition for almost all the doctors in India using technologies. And this is also a call. This is also a strong recommendation for all the doctors in India to use preventive diabetes technologies, because we have the evidence and we have already shown that technologies in diabetes, if we are very choosy in selecting the technologies, it will invariably bring down the cost and also the complications in diabetes. But if you review the use of technologies, including the continuous glucose monitoring devices, more than 70% of what is sold are the patients themselves procuring online. It is hardly recommended by the doctors. So this is a group of young doctors from across the country. So this is again a recognition for all of you. And this is a strong recommendation for all of us to embrace the technologies. And I am very much honored that I am put along with two stalwarts, Dr. Mohan sir and Dr. Benchi Sabu. And we are all here as diabetologists, I believe, and all of us know it for sure. It is only because of Mohan sir, because he is the one who actually started working on diabetes in India. And it is only because of Dr. Mohan sir, diabetes has become a very, very big recognized specialty, not only in India, but all over the world. And we are, of course, obliged to Mohan sir for everything. And with respect to our leader and my dear friend and brother, Dr. Benchi Sabu, he is a unique leader, because I have always realized the uniqueness in him as a leader. He is helping and supporting, irrespective of where we live, what we are, and irrespective of our age group. The peer group, the seniors, the juniors, all of them he is supporting. And I know that I am here only because of him, because we could do a lot of research and a lot of publications and studies together, only because of his support. So I remember, and this is an occasion to recognize and remember all of these facts. So thank you once again, Asia Diabetes Forum, for this honor and for this recognition, and wishing you all the best. Thank you, Bharat Sabu and the team.
A round of applause for sir. Thank you.
Yes, thank you. Thank you. We had all the three stalwarts, Dr. V. Mohan, who introduced diabetology and started so many programs on it, sir. It's real pleasure to have you here. Dr. Bansi, sir, who had, given different paths on the, aegis, under the aegis of RSSDI and Defeat Diabetes campaign and, whatnot. The words would be less in the praise of both of them. And last but not the least, Dr. Jyoti Dev also. So you all are our heroes. A hero is an ordinary individual who finds the strength to persevere and endure in spite of overwhelming circumstances. And thank you to have all the three heroes with us. Good, better, best, never let it rest till your good is better and your better is best. Thank you. And may I invite our second chief guest to please say a few words.
Ma'am is actually physically not present with us. She has a recorded message for us.
Yes.
मैं जनकपेटा मगिलीगन गांव सनावदिया में सामाजिक कार्य करता हूं। मुझे प्रयास फॉर डायबिटीज और एशिया डायबिटिक अलायंस जो है, उन लोगों ने मुझे कहा है कि मैं डायबिटीज के बारे में अपने जीवन शैली के साथ जुड़ी हुई बात करूं। डायबिटिक का सबसे बड़ा भयानक समय कोरोना काल रहा है, जिसमें सबसे ज्यादा मौत उन लोगों की हुई है जिनको डायबिटिक था। डायबिटिक जो पुश्तैनी है या जेनेटिक है वो भी हो जाए, या हमारे जीवन में भी डायग्नोज हो जाती है, तो ये एक ऐसी, मैं इसको बीमारी नहीं कहती हूँ, ये लाइफस्टाइल से जुड़ा हुआ एक बहुत बड़ा मुद्दा है। इसके साथ जीना आना चाहिए। तो इसके साथ जीने के लिए पहले हमें ये महत्व पता होना चाहिए कि हमारे जीवन का उद्देश्य क्या है। मैं ऐसा मानती हूँ कि हमारी जो हेल्थ है वो फिजिकल है, मेंटल है, सोशल है, एनवायरमेंटल है, स्पिरिचुअल है। तो बॉडी जो है, फिजिकल हेल्थ, जिसके साथ ये बीमारी की बात करते हैं लोग, डायबिटिक, शक्कर की बीमारी भी बोलते हैं, मधुमेह भी बोलते हैं। बॉडी हमारी आत्मा का रथ है, वाहन है। हमें अपने शरीर का उतना ख्याल रखना चाहिए जितना हमारी आत्मा के लिए हम परमात्मा को मानते हैं। अगर हम ये माने कि ईश्वर है और हम उसकी सर्वश्रेष्ठ रचना है, तो हमें अपना जीवन भी सर्वश्रेष्ठ जीवन शैली से बिताना चाहिए। हमें अपने साथ न्याय करना चाहिए, अपने जीवन शैली के साथ न्याय करना चाहिए। जैसे सबसे पहले बात आती है कि हमारी भोजन, भगवत गीता में लिखा है कि जैसा भोजन हम करते हैं वैसे हमारे विचार होते हैं, और जैसा विचार होते हैं वो हमारे कर्मों को प्रभावित करते हैं। और फिर हमें संयम के लिए कहा गया, संयम। मैं जनकपटा मगिलीगन गांव सनावदिया में सामाजिक कार्यकर्ता हूँ। मुझे प्रयास फॉर डायबिटीज और एशिया डायबिटिक अलायंस जो है, उन लोगों ने मुझे कहा है कि मैं डायबिटीज के बारे में
So moving on, Dr. Sonika.
Dr. Bharat, Dr. Ajay Bishnoi has joined.
Yes.
हेलो
सर प्रणाम।
हेलो जी, नमस्कार सब बंधुओं को।
सर प्रणाम, कैसे हैं सर?
जी बिल्कुल अच्छा हूँ, बढ़िया हूँ। डायबिटीज और डायबिटोलॉजिस्ट से बचा हुआ हूँ, पर दोस्ती बहुत है आप सबसे।
थैंक यू सो मच। आप बचे रहें, ईश्वर से यही कामना है। और यदि कुछ होगा भी तो घबराए नहीं, बहुत भयानक बीमारी नहीं है, चिंता नहीं करें। यहाँ पे है।
So with these words I want to thank our second chief guest, madam. With spring in our steps and curiosity in our minds, anticipation in our hearts, I would like to extend a hearty welcome to our third chief guest, and I request our third chief guest to say a few words and also honor our doctors with the words.
No, sir,
thank you. Thank you so much for allowing me to join this obvious meeting. In fact, I am not a doctor. The Abhishek is giving me the respect of a doctor, but certainly I am not a doctor, but my doctor ka baap zarur hu. Why? Because my son is a doctor. So being a father of the doctor, I can say मैं doctor का बाप हूँ. Fact is this, I am not a doctor, but anyhow connected to this profession very closely, because I am running a hospital. For last 25 years, I am running a multi-specialty hospital here in Jabalpur, known as a national hospital. So I have been dealing with the people. That is one thing. Number two, since I am a political person, public representative, social worker, so that's how I am having a very large circle and society with me. Those who come to me for the help, especially in the health sector, not only for diabetes, but for many, many other things. But whenever we discuss about diabetes, everyone, whosoever met us, he is always worried about diabetes. Why? Because once he says, if a heart attack will come, I know what to do with that. But if a diabetes is with me, I don't know whether I'll die with the heart attack or will I have a kidney disorder, or whether I'll have the liver disorder, or actually what is going to happen, whether I'll get a silent attack. Diabetes is such a frightening thing to everyone, because now everybody knows that diabetes is a silent killer. It can kill you anyway, anywhere, anytime. So that's why the people are more cautious, very cautious to deal with the diabetes. And that's how the role of your diabetologist has become very high. Now in the society, everybody wants that some diabetologist should be close to him, so he can take the advice what to eat, what to not, how to behave, how to not. Anyhow, but though Madam earlier Chief Guest Speaker was saying something, in fact, in case one can adopt the daily routine, our lifestyle in a way, so he can challenge the diabetes also. But in fact, people know it, but unfortunately, they do not adopt that lifestyle. They don't want to go into the regular exercise, walking, or whatever other exercise they can give. Even the pranayama is also helping. Because I am saying it out of my own experience. I got a stress diabetes at one time when I was operated for the bypass surgery, CABG. After that, I got the stress diabetes. I was having the blood pressure also. Later on, the blood pressure has gone, diabetes has gone. Only because I am into the regular exercise and keep my diabetologist. That's how has been
Very
great
nice,
in
sir, for enlightening. Everyone,
no,
we
I am
all
not
should
enlightening
follow.
you. I'm not
I mean,
enlightening you.
everyone should
You can
follow a
do
healthy
much better.
lifestyle. That's very true.
Yes. That is all the crux of the thing. If you can do that, certainly you can fight
Exactly,
with the
sir.
diabetes. You can deal with the diabetes. I'm happy that I am being given the chance to see all of you, to hear all of you. And as Dr. Abhishek Shrivastava was telling me that some Dr. Mizan is there. In case if I can see his photographs here on the screen, I'll be happy to see a
Yes, sir.
person who's. Yeah. You are Mr. Mizan?
No, sir.
Hello.
I am Dr. Bharat Sabu. I'm Dr. Bharat Sabu talking. The next set of awardee you are talking about, and we are honored to have you
Hello,
for
sir.
the
Yeah.
award which we have talked about. So we will be now beginning our next set of awards, which are for the 5 people we have selected from the 5 regions of India: East, West,
Great,
North,
great.
South, and Central region. We
Oh.
got 125 nominations. We created a nomination form. It was an open sort of form where people can nominate themselves or the other ones who they think they have done exemplary work. After cross-checking of the work we should admit we have done the cross-checking of their work also with various sources through peers and other means. There was a committee which decided upon the 5 names from 5 regions of India. So Mr. Ajay Vishnoi sir will be awarding those 5 people who are there with us. So the first award which sir was talking about goes to Dr. Mizan Ahmed from Golaghat, Assam. Congratulations, Dr. Mizan Ahmed, for this award. And can I have the AV for Dr. Mizan Ahmed
please.
with us? Please play the AV.
Yeah, hello. Thank you.
Hello.
Hello.
Just 20 seconds, I would taking Dr. Mizan Ahmed is practicing in Golaghat, Assam, the rural tribal area, and he has been practicing since last 10-12 years. That is the reason why we chose him, because the criteria was of choosing the diabetologists who are practicing in rural and semi-rural areas.
Dr. Abhishek, can I ask a question?
Yeah, please, sir.
In fact, what I know is the people, those who work very hard, especially the tribals or the Mazdoor class, they don't suffer with the diabetes. So how come he is successfully practicing in that area where more of the Adivasis are living? They are very hard-working people.
Dr.
Hardly,
Mizan,
I think
congratulations, and can you just answer in 1 minute? Because
Dr. Mizan, please.
Thank you, Dr. Sabu sir, Dr. Visek,
Hello.
Dr. Bansi Sabu sir, Dr. V. Mohan sir. Nice to see you on this platform. I thank one and all for selecting me to this lovely honor, which I never expected actually. So my journey, it started from the year 2009 actually, when I was in Chennai at Professor A. Ramchandran Diabetes Hospital, and then I was back in 2011. I have got a deep sentiment associated in the field of diabetes because I lost my mother while I was doing my post-graduation there in Chennai. I have come back to my own place, Assam, with a great zeal in my mind that if I could save hundreds and thousands of my mothers in this nation, then this noble work shall give some satisfaction to the soul of my lost mother. So a mother is the greatest asset of a person in one's life, and I lost my mom in diabetes only, which were being mismanaged at that time. She was not about to. We should have not lost her because of the not getting a good care. So I came back to my own place and started my journey as a diabetologist after doing my post-graduation from Chennai, and then I started this organization in the name of Northeast Diabetes Care and Research Center here in Upper Assam, the district Golaghat of Assam. And by God's grace, from 2011 onwards, I have started my journey for treating patients, may it be the patient care, education, and prevention. I have done my own education program, and by God's grace, I've been able to. I'm seeing patients from entire Northeast and people from Nagaland, Manipur, and all those places.
Dr. Mizan.
Very nice, Dr. Mizan. We are running short of time.
Thank you.
We would request the other bodies also to.
I am always. Thank you so much for this.
Thank you. Thank you.
Next awardee, please. Next awardee is Dr. Rajneesh Saxena from Kuchaman, Rajasthan. Dr. Rajneesh Saxena is very regularly going to Kuchaman. Niro, can you remove the slide from here, please? And Dr. Rajneesh Saxena is taking care of the Kuchaman village. He is going there every fortnightly, and he is taking care of all the diabetes related needs of that undeserved area, I would say, which is not more undeserved now as he has started going. And that was the first village which was adopted under the village adoption program of RSSDI, if I am correct. And that is how it has given strength to the diabetes care in that region. So we congratulate Dr. Rajneesh Saxena for this award.
Thank you very much. Thank you very much. Thank you.
Next awardee, please, Nirav. Thank you, Nirav. We all congratulate Dr. Rajneesh Saxena.
Thank you very much.
Next awardee, please. The next award goes to Dr. P. Prashanti ma'am from Tirumala. Congratulations, ma'am, for this award. Can we have the AV for Dr. Krishna Prashanti ma'am? By the time the AV plays, Dr. Krishna Prashanti ma'am is running OPD where she has over 6 lakh patient data. So here is the AV for ma'am.
Great data, great data. 6 lakhs people.
Thank you.
One more thing, Dr. Krishna Prashanti ma'am, along with her husband, who is a surgeon, and more or less she has prevented 10,000 amputations, which is highly commendable and huge, because one of the most important comorbidity is diabetic foot ulcers and amputation. So I really appreciate Dr. Krishna Prashanti ma'am for such a huge task. Thank you.
Thank you very much for giving me this award, and the credit goes to all my patients who trusted us for taking their treatment. God has given me opportunity to treat 3 generations of patients in the same family. It's only because of my parents, my teacher, my husband, my children, and all the trusted patients who still love us, and because of their affection towards us, not only as a treating doctor but as their family member, taking care of their personal issues also, and associated with all the problems in their families. Thank you very much. Thank you, Dr. Bharat Sabu sir, Mansi Sabu sir. Thank you very much.
Ma'am, congratulations.
Congratulations, madam. Congratulations.
Congratulations, ma'am.
Can we have the next awardee?
Next awardee is Dr. Amit Kumar Das from Muzaffarpur, UP. Congratulations, Dr. Amit Kumar Das.
That is
Can we have the AV for Dr. Amit Kumar Das? Congratulations, Dr. Das. Can we have the next awardee, please? Next awardee is Dr. Hiralal Dalodria from Ashta, a place in Madhya Pradesh. Can we have his AV, please? By the
time
no, it is there.
Yeah.
Sir is actually practicing medicine and serving Ashta and around 300 villages nearby since past 40 years. And he runs Prayas Education, where he educates basic medicine to the rural healthcare professional. This is a wonderful thing which actually incited us to choose him. The committee chosen him for this reason only, because he is awareing so many people. So congratulations, Dr. Hiralal Dalodria sir, for this award.
I would like to thank Ajay Vishnoy sir again for sparing his precious time and awarding all the awardees. Thanks a lot, sir. Thank you.
Thank you. Thank you very much.
And now next in the events, at last, we have a small inauguration of a magazine which we are planning. So Nirav, can we have just that slide of that magazine? The magazine is Diabetoscope, which will be coming out in next issue in say 15 days. And it is a magazine which will be covering all the issues related to diabetes from the diabetologist perspective and the patient perspective as well. So on this forum, we are launching this magazine as well.
Great, Dr. Bharat.
Over to Dr. Sonika for inviting Dr. Abhishek Srivastava to to thank everyone and to officially inaugurate the scientific sessions.
Thank you, Dr. Bharat. Learning is not mere imitation, nor is the ability to accumulate and regurgitate fixed knowledge. Learning is a constant process of discovery, a path without the end. With these words, I want to call upon Dr. Abhishek Shrivastava. Sir, he is scientific chairman. He'll come and announce the program. Before it starts, I have a good saying to say. रख हौसले वो मंजर भी आएगा, प्यासे के पास चलकर समंदर भी आएगा, थकना बैठकर ए मंजिल के मुसाफिर, मंजिल भी मिलेगी और मिलने का मजा भी आएगा. So maza will be now once Dr. Abhishek will give us a brief introduction about the program. He is the backbone behind all this with Bharat Sabu, Dr. Bharat Sabu. So may I call upon Dr. Abhishek Shrivastava to please take over the proceedings. Thank you.
Thank you, Dr. Sonagaram. Thank you for such a gesture. And I would like to thank especially Dr. Mohan sir, Dr. Banshi sir, Dr. Jyoti Dev sir, and all the dignitaries, faculties, national or international, who have given their consent to participate in one of its kind masterclass in diabetes. And it was not easy actually to inculminate such huge faculties, national or international. So it was very difficult task, and I hope I and Dr. Bharat, along with the national organizing committees, Dr. Darya, Dr. Vipul, Dr. Rutul, and those who have participated in this scientific agenda. And I hope everyone would like the sessions, because they are basically being inculminated from basic to the top. And let's hope for a very inculminative feast and educational feast, who will be delivering the national leaders, international leaders, along with the delegates. Thanks a lot. Thank you. And I
would like to thank all the knowledge imparter, our speakers. Without them, the event is not successful. So I am thankful to all of them for sparing their time for this event. I am thankful from my heart to all my international friends who are there. They are here, and all the industry partners also.
Dr. Irina, ma'am. Hello, Dr. Irina, ma'am.
Hello, I'm very happy to see you. And I only want a second. Thank you so much for your job, especially in a rural area. This is very, very important. I even cried when I saw what you did. Thank you. Thank you very much from my heart.
And I would like to thank Balu Monde sir for being here, Mr. Ajay Vishnoi sir for being here with us, and also Janak Palta ma'am for sending her blessings over the video. I would like to thank all those who are here presented in this inauguration ceremony for sparing their time and come over here. Now the scientific feast is there to take a takeoff, and kindly enjoy the sessions and do let us know how we can improve next year. Thank you.
Thanks a lot. Thank you, everyone.
Thank you, everyone. An investment in knowledge pays the best interest. So we are here to take all the interest by joining the scientific feast. Thank you all.
We have to all thank you, everyone. Banting Hall and Best Hall, because this is the centenary year of excellence. We thought none other than Banting and Best with us. And the sessions are there in the respective halls. The Banting Hall session will continue here, and for the Best Hall sessions, we have another hall. So thank you all. Thank you.
Thank you. Thank you very much, sir.
Thank you, everyone.
Really.
Thank you. Thanks a lot.
So Bharat, everybody is leaving because nobody is interested for defeating diabetes.
No, sir. No, it is not the case. Maybe they thought that this is a.
No. I mean, I'm kidding. Come on.
We are here, sir.
Also. You can miss a Shokat Thadikot oration from Dr. Bansi Sabu.
Jyoti, how are you?
Good.
Actually, message to you and.
Bansi sir, our cash prize is still awaited. That audience third prize.
क्या बात करती तेरा प्राइज नहीं है
सर ये कल से मुझे बोल रही पैसे नहीं मिलेंगे तो आऊंगी नहीं मैं
क्या बात करते सही में so you write to secretary or Hardik directly we will do it
thank you sir thank you
So Bharat, अभी आज एक circulate कर देना Asian Diabetes Forum की जगह, they can become member of Diabetes Asia.
सर सब आपका है, जो बोलोगे उसमें मेंबर बन जाएंगे क्या?
So we will be starting at 2 o'clock?
Yes, sir. In next 5 minutes.
Sure, great.
So I'm so glad that you joined. Thank you.
Good, nice. All congratulations for this wonderful conference. Yet another conference by another Sabu.
But we are all with you. All Sabus are with you.
I'm so proud of Sabus.
There is knowing also one more senior Sabu. There is one very senior Sabu physician based in Hyderabad.
Yesterday I met him. We were together.
Yes.
We had a program yesterday.
He's a very senior physician.
Sabu
His son is pulmonologist.
He's our guru.
Yes, I know. His son is pulmonologist, sir. His son is
he's a physician. Bansi, yesterday he was telling me he is 86.
He's 86.
He's strong. He's older to senior Sahai.
Acha? I don't know. I thought he was 1 year or 2 year junior.
I thought so. Okay. But then he told me that he is 3 years older to BK Sahai.
But he is fine, fit and fine.
Oh yeah, very fit and fine.
His son is, I think, pulmonologist. Na? He is practicing lung.
His son is a pulmonologist. Yeah. And nobody can be as popular as he. He has a trust hospital. He does so many things. Looks into. He's one of my trustees, API Hyderabad trustees.
Okay. I know him as soon as I became I mean, in medical practice when I came, I was knowing only he is one senior guy who is practicing there.
You remember
one more general practitioner in based at Mumbai also is House.
You also met him in Hyderabad.
Yes, I met him, sir. I met him.
I remember.
Yes, Ishita, we can start. We are fine with it.
Hello, everyone, and thank you, sir, for all of us. Dr. Bharat, Dr. Abhishek, sir, congratulations for a wonderful session and inauguration. We are all looking forward to the scientific, a beautiful scientific feast. I would like to introduce our chairpersons, Dr. Vasant Kumar, sir, from Hyderabad, and Dr. Bharat Sabu, sir, of course, from Indore. We all know he's our shining star from Central India. Sir, over to you, sir.
May I have the honor of Dr. Vasant Kumar sir to please introduce Dr. Bansi sir, because he introduces him in the most elaborate manner. Please, sir.
Thank you, Bharat. First of all, I am so pleased to be associated with this very important lecture, the keynote address by none other than my very good friend, my younger brother, Bansi Sabu. As you said, it would be very difficult for anyone to describe, I must say, Bansi Sabu. Bansi Sabu is somebody, he's unique, a different guy, a wonderful guy who could do many things. You start from the patient management, talk about the research in India, talk about training people in the field of diabetes, spreading awareness, advocacy, working for RSSDI. And during his time for the last 2 years, RSSDI had reached to such a phenomenal growth that we have achieved, which we could not have imagined earlier. So I was proud to be associated with him. And we are so happy that Dr. Bansi Sabu is today delivering this keynote address in honor of none other than Dr. Shaukat Sadikot, who is a very dear person to all of us, a highly respected person. We always miss him in any seminar or conference on diabetes. And now it is so appropriate that it is Dr. Bansi Sabu who is going to speak to us on this important topic. And I don't even want to read his biodata. I'm sure all of us know, and you read it. And I described him the way I wanted. And Dr. Bansi, it's all yours. Before Bharat wants to say anything.
Oh, sir, please, sir. Bansi, sir, we want to hear from you.
Sir,
first of all, thanks, Asia Diabetes Forum, dear Dr. Bharat, for giving me an opportunity. Thank you, sir. Thank you, Dr. Vasant Kumar, for introducing me and for your kind words. We all know Dr. Vasant Kumar, who is current president of RSSDI, my elder brother, very dynamic person. And now we are remembering Dr. Shaukat Sadikot. I was associated with Shaukat Sadikot since last almost 20 years. We lost him before 3 years, and he was very close to me. In
Sorry.
International Diabetic Forum, and then we worked with him in Diabetes India. It was founded by him, and then I took over as a Diabetes India secretary. And since long, I'm working for Diabetes India also. Since last 2 years, I was very actively involved as the president of RSSDI, but same time with Diabetes India, I was also involved actively with RSSDI too. With this word, the topic given to me by Dr. Bharat and the Scientific Committee of Asia Diabetes Forum, Defeating Diabetes, Is It a Dreamy Goal? And as we have done a campaign before some time, so I'll be touching upon that aspect also, and then something about that. Is it really a dreamy goal, or can we achieve defeating diabetes in our country? So we all know this slide, I'm sure multiple times we all had seen, but the important point is whatever diabetes estimations which are based as per International Diabetic Federation Atlas or by World Health Organization, actually the prediction which is done, we achieve that prediction before 5 years. So this is very important point out here, which I want to tell. Suppose in 2019, whatever the number which was expected, or predicted by the International Diabetic Federation. Actually, we achieved that number in 2014 or maybe in 2011 only. So this is how the diabetes is growing all over the world in this space. So that's something which is very worrying for us. If I see the India in 2019, this data where we could not have the data from Jammu and Kashmir, but other parts of India, one is that 1 in 11 adults have diabetes. 1 in 5 people with diabetes in the world actually come from Southeast Asia. And as Bharat has made this particularly Asian Diabetes Forum, because not only we are different from the Western world, but we are the one who have highest number of diabetes in the world. If we take the China, India, Indonesia, Pakistan, Bangladesh, Sri Lanka, other countries together, I think probably 4/5 population of 80% or 75% of the population of diabetes in the world comes from this area.
Sir, your screen sharing is not working. Your screen we are not able to visible.
I'm sorry. Can you see it now?
Yes, sir.
Okay. So I had shown you first slide that are talking about that whatever the prediction which we are making, actually we are achieving that prediction before 5 or 10 years. And then I was trying to talk about the prevalence of diabetes in our country. In 2019, you can see that 1 in 5 people in diabetes in the world come from Southeast Asia. 1 in 6 adults with diabetes in the world come from India. 1 in 2 people in diabetes patients, they are not knowing, they remain undiagnosed. 1.2 million deaths are because of diabetes. It is second highest number of deaths of all IDF reason. 1 in 4 live births are affected by hyperglycemia in pregnancy. And total diabetes related health expenditure, which may be very high in US, but in India, it is also not less. And this prevalence, you can see in last 25 years, how we change. I mean, this is not the data from 1990 to 2016. And that in India at that point of time, most of the places in India, it used to be less than 5% in adult population. While it has changed completely in Tamil Nadu and Kerala and some part of the country, even Punjab and Karnataka, had shown even the number of persons with diabetes is almost in adult population is increased by more than 10%. And many other parts of country is also having between the range of 6 to 9. But the problem is in our country is almost 50% of them are undiagnosed. They are not only in the urban population, but in rural population, it is slightly more. So in urban population, it may be 1/3 of them are undiagnosed, but in rural population, exactly more than 50% of them are undetected. Now, I just wanted to give you 4 slides, and this I just want to show that in 2007, from Mohan, which he has talked in 2007, the people with type 2 diabetes and glycemic control in our country, it is only 20% or less than 20% of the patients actually have good control of diabetes. The next data in 2011, this is again by the Mohan was the first author for this in the DiabCare 2011, and he had talked that current status of our patients in our in India is less than 20% of the patients who are actually having a good control of the diabetes. Now, if you see in the next slide, in 2014, even this is a paper from the Unni Krishnan, which is also talking that less than 70% of the patients in diabetes have HbA1c of more than 7. So what I mean to say, from 2007, 11 and 14, 3 papers, you could see there is hardly any difference. Most of the patients are still uncontrolled. Now, this is the paper even in 2020 also, which is talking that in our country, the number of patients who are achieving a good control of diabetes is only 22.5%. So what we had seen in 2007, it is almost less than 20% of the patients were achieving a tight glycemic control. And even after 13 years of multiple drugs which had come, we are doing so many education programs. We are reaching to the ruralmost area of our country. Still, what is the status of the control? Still, it is the same. So all 4 papers are not talking that are actually care of diabetes diabetes care in our country is really improved. No, it is almost same in last 13 or 14 years. It is remaining almost still 20% of the patient or less than that is actually achieving good control. So we have very, very high prevalence, which we know, and we have very relatively low awareness. 60% of urban Indians unaware that uncontrolled diabetes affects these many complications. I mean, this is something very important because even they don't know, even they are diabetes, they are urban living people, but still they don't know that diabetes can lead to multiple complications like heart, eye, and kidney. About 1/5 of the respondents, they regarded obesity as the primary cause of the diabetes. So other 4/5 of the people, they don't know that obesity is the major reason for them to develop diabetes. Half of the respondents, they felt they would never get it. So I mean, those who does not have the diabetes, those who do not have diabetes, they feel that they will never get the diabetes. And 80% of non-diabetics are ignorant about the blood sugar level. So this is also very important that many of the people, they don't know and they are completely ignorant about the diabetes. And that is what we have very high prevalence of diabetes. We have very high prevalence of diabetes complication, but still the awareness level in our country is very, very low. So this is very important as far as diabetes care in our country is considered. So there are distinctive features of type 2 diabetes in our country. We have nutrient abundance, high intake of refined cereals. We have urbanization is very fast, decreased physical activity, low intake of dietary fiber, fruits and vegetables. They are probably important risk factor for them to develop diabetes. We have low BMI, but we have very high waist circumference. We have very high visceral fat. We have very high increased insulin resistance. And that's the reason we have a high prevalence of atherogenic dyslipidemia. The clinical profile, if you see in our country, we are getting diabetes at a very young age. We have getting diabetes at a very low BMI, and we are having very high prevalence of coronary artery disease also. In our issues in management, as I told you, we have very low awareness in our country, high prevalence of patients with undiagnosed diabetes, unaffordability of care, and unavailability of trained medical and paramedical staff. So these are some of the very distinctive features of type 2 diabetes in our country, not only from the etiopathogenesis point of view, but as far as issues in management is concerned. This paper recently by Dr. A.K. Singh had talked about the impact of diabetes on diabetes control on severity and mortality in COVID. And what we had seen, those patients who have uncontrolled diabetes, those patients who are first time detected diabetes during hospitalization, during COVID time, we could see that poorly controlled diabetic patients associated with very poor outcome in patients with COVID-19. So during this period of COVID time, what we had seen, the persons with diabetes, which are undetected, first time detected, uncontrolled diabetes, poorly controlled diabetic were having worse outcome in compared to the patients who are having better diabetes control. So diabetes is one of the largest health emergency of 21st century. High blood glucose is the third highest risk factor for premature mortality after high blood pressure and tobacco use. I mean, the tobacco use and high blood pressure is also to be simultaneously to be controlled along with the high blood glucose level. Every 6 seconds, a person dies from diabetes, and probably tomorrow we will release the full IDF Atlas of 2021, which is talking even every 5 seconds a person is actually dying from diabetes. And every time whenever I used to listen Dr. Sokar Sadikot, he used to talk about this, because when he became IDF president-elect, at that point of time, it was every 7 seconds a person dying of diabetes. When he was as a past president of IDF, he talked about every 6 seconds a person is dying of diabetes. And now, tomorrow, we will be listening that every 5 seconds a person is dying from diabetes. So this is what is a continuously, even after the best efforts which we are doing, we clinicians, we diabetologists across the country, across the world, we are working so hard, but still the number of persons with diabetes are increasing, more complications are there, and we are having now the persons dying because of diabetes also increasing all over the world. This is the paper with, along with Dr. Jyoti Dev and Anup Mishra, we have written that now sugar should be considered, a blood glucose measurement should be considered in all hospitalized patients is a fifth vital sign. It should be considered even on outdoor patient department also, the way we are measuring other vital signs. The sugar monitoring should be considered as a fifth vital sign. We were not first to write about it. Actually, before this, There was a paper in Diabetes Care also written by in August. The glucose is a fifth vital sign, and they have done similarly for all those patients who are admitted in hospitals where sugar was not continuously monitored or not monitored, or first time detected diabetes found to have worse outcome in compared to the patients who are more better glucose monitor was done and having better outcome. So the point is here that we wanted to make that glucose monitoring should be considered as important as other vital signs, and other 4 vital signs we all know. So this should be considered as a 5th important vital sign. That is very, very important. In diabetic patients, this is very important, that rule of half is working. Actually, number of persons with diabetes, half of them are not diagnosed. Those who are having diagnosed, only 50% of them are actually receiving care. So those who are diagnosed, even those 50% of them are actually receiving care. Those who are taking care, out of them only another 50% of the patients are achieving the target. Now this is the target of glucose target. But what those who are achieving the target, the desired outcome, because the other risk factors are not taken care, and they are only other 50. So out of 100, only 6.25 are actually achieving desired outcome, which we want to have in our diabetic patients or someone who have diabetes. The desired outcome is preventing the complication. That is what we want to desire for a person with diabetes. And that happens at present only in 6.25% of the patients who are having diabetes. So this is the campaign which we have done before some time, defeating diabetes, test, track, treat in 100 days to reach in 100 million people. Our mission was very clear that test, track, and treat are 3 major pillars of defeating diabetes. And our mission is to reach 100 million people in 100 days. That was what we were having the mission. But our vision was not just to reaching the 100 million people. We want to really defeat diabetes, defeating diabetes in terms of the diabetes which is causing a lot of complications. We are seeing that a lot of people are not diagnosed with diabetes. A lot of people who are diagnosed with diabetes but not taking care of themselves, not taking medication, not achieving the targets, and not taking care of other aspects of the diabetes, which is blood pressure, the cholesterol. They all should be controlled. They all should achieve the targets. And that is what we were having the vision of defeating diabetes in our country. So our mission was not just for the 100 days for defeating campaign. It should become a movement. It should become on a long run, because for 100 days the campaign was over. But now after what? We should still continue to test who are coming to our clinic. And this should go to the IMA, all doctors. We partnered for this campaign with Indian Medical Association to screen everyone who is coming to your clinic, who is may not be a diabetologist, may not be a physician, maybe a primary care doctor, or maybe ophthalmologist, maybe a gynecologist. But still, they should screen everyone who is adult and who is at the risk of developing diabetes, or at least who is above the age of 30. So this opportunistic screening should be continued for all those people, because early and aggressive control of diabetes can only lead to complication prevention. The tracking of the people who have diabetes, those who are having diabetes, those who have uncontrolled diabetes, they should be tracked. They should be regularly monitored. They should be regularly monitored at physicians for the controlling the sugar as well as for screening of the complication too. And these people should be treated aggressively for achieving the target control. And here we should not be only glucose-centric approach. We should have an approach of a prevention complication approach. So our campaign may be over by 100 days, but this movement of testing, tracking, and treating with diabetes should continue in our country. And that's the only way by which we can defeat diabetes in our country. So that's very, very important when we are talking of defeating diabetes in our country. We were having the white paper, which was very clear that it's a decision to establish a cooperative program and a movement whereby every Indian would get tested. It's an endorsement of the use of point of care testing for every individual. What we want that everyone, they should get tested by a point of care testing, which is a glucose meter. If not by himself, at least by closest healthcare worker who should have this point of care device. It's a resolve to involve doctors from all parts. I mean, it's just not for the RSSDI member. It's just not for all the IMA member, even anyone who is working in field of health. It's a paramedical staff also. So it's a to involve every aspect of healthcare professionals in our country. It's an intention to foster the program as essential for promotion of human welfare, development, and amelioration of diabetes-related distress in our country. And that's what the Defeat Diabetes campaign is all about. And its commitment to work out to a harmonious balance between process of development and resources in terms of people, finance, and care. And we calls upon all national body. We have talked to Indian Medical Association for Defeat Diabetes campaign. We have talked with the even Rotary also to join hands, RSSDI to penetrate the lands and breast of this wonderful country, to make the glucose is a fifth vital sign that should be assessed for every individual. And let us work together to defeat diabetes. This is a dream which is there with us. We have done a campaign and now we are in the movement process, and that's what we are asking everyone to work together for this campaign, for this Defeat Diabetes movement that should continue. This program, which was launched by our Chief Justice of our country, and on other day you can see on our social media, we had seen thousands of news, thousands of Twitter, thousands of messages on our WhatsApp, on our Facebook. We all could see that how we could reach to 100 million people, and it was there from the next day itself only. We had also come out with a declaring blood sugar should be considered as a fifth vital sign. We had come out with a petition sign, and it was signed by more than 100,000 people in across the country. And then we have done multiple programs on a different social media. We have come out with a multiple creatives, which were also there all across the country on all social media platforms to reach 100 million people and to make people aware about the diabetes. And then one day we have decided that on one particular day we would like to do more than 1 million testing in one particular day, and that was our day of 29 September, which is World Heart Day. And on that day we try to do for all those who are coming to these centers, because more than 10,000 centers were decided. It was not only 5,000, because 5,000 doctors clinic along with 4,000 centers of Rotary Club and another 1,000 centers which was taking part in this campaign, and where we were doing in one day 1 million testing for all those who are adults. They should be at least tested whether they are diabetes or non-diabetes. But one thing which is very important, who should be tested? This is a Indian diabetes risk score. On that particular day we were teaching all those paramedical and non-medical persons that who should be regularly monitored or who should be screened. Those who have the waist circumference of more than half of their height. This is very simplified form. We can always calculate the risk score by calculating the age, by calculating the waist circumference, by calculating the physical activity and family history. These are the 4 points. Does not require anything to be checked. Any invasive. This is just by taking the history. Now we have come out with on RSSDI on day of inauguration with the app also to calculate the risk score for a person. But for very easy, for a simple man, if height of the person is 170 and the waist is more than 85 centimeters, it means he is at the risk of developing diabetes. So that's what they should be screened. So all those who are above the age of 30 and all those who have the waist circumference more than 90 centimeter male and more than 80 centimeter in female in our country, they should be screened for the sugar regularly. But can we change the natural history of type 2 diabetes? That's very, very important. It's an early diagnosis is the most important thing. That can change the natural history of diabetes, because otherwise a diabetic patient in next 10 to 15 years is going to have a lot of complication if we are not going to have aggressive control. And for getting aggressive control, early diagnosis is important, because we have already delayed diagnosis. We are getting the patients who is already having 5 years or 10 years of diabetes, or somebody who is coming to us with a already complication. So early diagnosis is in need of our. That is what we want, because an early diagnosis will have a tight control in the early part of the diabetes. It is much easier for a tight control, and that legacy effect will also continue throughout the lifetime, and they will have less and less complication, because early intensive therapy will add a legacy effect, which generate a legacy effect. And this legacy effect you can achieve only by early and aggressive control of diabetes. And throughout the life, we had seen these patients will have less and less complication. This is in UKPDS, those who are actively enrolled in active arm, these patients were having legacy effect throughout the lifetime, and they were having less and less complication. But our body is such a system that, if somebody was not having a very good control in first 10 to 15 years of of the diabetes, they are going to have a bad glycemic legacy. So this legacy is not just for a good control, they will have to have a good glycemic legacy, but those who have uncontrolled diabetes in first 5 or 10 years, they are going to have bad glycemic legacy. This is a VADT paper. Those who have 10 to 15 years of uncontrolled diabetes. Now, whatever best which you can do for the good control of diabetes, still we can't reduce the complication. We can't reduce the mortality for these patients. And that is what VADT trial in 2009, which was published. So a not intensifying early is going to give you the bad glycemic legacy too. It's long time to undo bad legacy. If somebody is having uncontrolled diabetes, coming to us with the late diagnosis of diabetes, with first 5 or 10 years, nothing done. And now we want to do the best control. It is very, very difficult. And even if you want to do, it's long time to do this undo for the bad glycemic, which we have for these things. So what we have at present in our country, and we are trying to do, we all under the banner of RSSDI, Diabetes India, or many organizations in our country, we want to increase the awareness for early diagnosis by increasing the awareness. That's the one way which we can do. And this is what we have done in Defeat Diabetes campaign. And this we want to continue to do in this Defeat Diabetes campaign movement also. Improving access to the diabetes care. This year, IDF theme was that we have the access to diabetes care in our country is very poor. And through this digital platform, we are reaching to the rural most area. We have already district coordinator, and probably this year we will able to reach to the taluka also. And we want to improve the care for diabetic patients by improving the access to the these patients who are having diabetes to the best specialists, because we can train them, we can educate them. Aggressive management for tight glycemic control, because what we had seen, those patients who are even diagnosed, those who are taking treatment, even though they are not achieving the target for most of them, even 70 or 80% of our patients, even they are not achieving the target glycemic control. So the aggressive management of tight glycemic control that we should do, that is one of the very important part of this Defeating Diabetes campaign. Screening for complication, just forgetting, I mean, just not doing only glycemic control is not sufficient. They should be screened for complication, because like the diabetes itself is an asymptomatic disease, many of the complications of diabetes are also completely asymptomatic, and they require annual screening also. We should move from glucose-centric approach to complication preventive approach. We were having always only glucose control approach. Yes, we should have, but simultaneously from glucose control approach, now we should move to comprehensively complication preventive approach. Also, we should become more precise in diabetes. A precision diabetology had come in the picture now, monitoring the patients individually, doing continuous glucose monitoring, try to see their nutrition, and accordingly, we are changing their therapy. So a very, very precise diabetology, which we want for our patients, and prevention of diabetes for high-risk population. So just not sufficient to control for all those who have diabetes, but also for those who are at the risk of developing diabetes, we should try to prevent diabetes for high-risk population. So this is what in our campaign, this is what in our movement, and this is what our dream of defeating diabetes in our country, and that we should continue. So it's time that we should regard the blood glucose as a fifth vital sign. It's a time that we should early and aggressively control the diabetes and prevent complication, and making our country diabetes care capital of the world. With this, I conclude. Once again, thank you, Dr. Bharat, and thank you, Dr. Vasant Kumar, for chairing this session, and thanks Asian Diabetes Forum and organizing committee and scientific committee for giving me this oration. Thank you. Thank you.
As this is a keynote oration, we will not be discussing, but we will like comments of Dr. Vasant Kumar sir, none other than Vasant Kumar sir, please.
Thank you, Bharat. I'm sure you and everybody will agree that Dr. Bansi Sabu, as always expected of him, has given a wonderful talk, has taken us through the entire scenario of diabetes in Asia, especially in relation to India, the challenges we have, the areas that we need to focus, and already the many things that we have already attempted and we have almost achieved, which was an impossible task, which was made possible by RSSDI under leadership of Dr. Bansi. And he also said it's not limited to RSSDI or somebody. Each one of us need to work together, the entire medical profession, And this time he has also proved that we should work with the voluntary organizations like Rotary and others, where we could really work in the area of awareness and advocacy. And Dr. Bansi Sabu, thank you so much for this wonderful talk. And I'm sure this further helps us to take forward these things. Thank you.
Thank you, Bansi
Yes,
sir.
thank you, sir. Thank you.
Sir. Now over to Ishita for next session, please.
Thank you, sir. Thank you, Bansi Sabu, sir. Thank you, Dr. Vasant Kumar, sir. Now we are going to have a lecture on the state-of-the-art lectures. Like earlier it was discussed that technology has moved to a completely different platform. And due to the COVID pandemic, we have all relied more on technology. So over to the chairpersons, Dr. Mayura Kale from Aurangabad and Dr. Mahesh sir from Parbani, and to introduce the speakers. Thank you.
Yes, thank you so much, Ishita. Thank you, Bharat Sabu sir, for the opportunity to be here. I welcome you all for the next session. As Ishita said, the state of art lectures. So this is my privilege to introduce Dr. Puneet Saxena sir, who will guide us regarding the mitochondrial modulators in diabetes. Puneet Saxena sir is a senior professor and unit head of Department of Medicine in the SMS Medical College and Hospital, Jaipur. He's senior consultant physician and chief diabetologist at Asha Diabetes Clinic, Jaipur. He is secretary of Jaipur API chapter. Faculty for the PHFI for Diploma in Diabetes. He has numerous papers and publications in the index journals, and he has been faculty for national and international conferences. So I welcome Dr. Puneet Saxena sir for his talk and request him to proceed with the talk.
Thank you very much, Dr. Ishita. And at the very outset, I thank Dr. Bharat Sabu and his entire team to have taken this new initiative and making a conglomerate of people over Asia for better care of diabetes in form of ADF. And I was just listening to our dynamic ex-president, Dr. Bansi Sabu and Dr. Vasant Kumar. And his talk was basically for the care of diabetes, that what best can we do for stopping the diabetes and its complications. And in the same continuum, I'll be speaking on something to find out that what best can be offered to the patients. So in the meantime, let me share my screen. So somebody is already sharing a screen, so I need to. Okay. So I think I am visible now.
Yes, sir, you are visible.
Yes, sir, you are
visible. Sure. I'll just take a second more. Yeah. So let me do. So that was the slide. I'll be speaking on mitochondrial modulators in diabetes, and let me also invite you to the upcoming Epicon, which we are going to organize in Jaipur in March 22, which would be a full physical event. As of now, we have planned, and we are going full swing in the preparations. So I always start with the problem statement just to stress upon that what discussion is being held and for what. And the numbers are very important, and these numbers drive us to find new modalities of the treatment. And the mitochondrial modulators probably also one of the steps forward for the same purpose. So most prevalent non-communicable disease numbers, we all are aware, increasing every day. India is especially affected. And it's a global problem. You can see over here that how is this spread. So it's a concerted effort across the globe to find some new solutions to the problem. And the various hypotheses have come over the period of time, basically to understand the pathogenesis of type 2 diabetes. And this was the first one by D. Fronzo in 98, where the triumvirate hypothesis, where beta cells, the pancreas, liver, and skeletal muscle were seen as the malfunctioning organs or the culprits for development of diabetes. But then there was a paradigm shift as the number of diabetic increased, more research led to development of the science and to know that the different organs are involved in adipocytes, kidney, gut, alpha cells of the pancreas and the nervous system were also implicated in the pathogenesis. No, but why these are important? Why we need to know the pathogenesis? Because it's only if we understand this, we can develop new drugs and we can develop the targets to limit the devastating outcomes of the disease. And maybe there may be someday that we will have a drug which can probably either stop or maybe reverse or completely cure diabetes also. So that's far-sightedness, but yes, we are foraying into the pathogenesis. And beta cells, we all know that impaired synthesis and secretion of insulin, liver is the increased hepatic glucose output. At the level of skeletal muscle, decreased glucose uptake. At the level of adipocyte, increased lipolysis. Kidney, increased glucose reabsorption. Gut, incretin deficiency and incretin resistance, and alpha cells by increased levels of glucagon. And brain is having dysfunction of neurotransmitters and thereby insulin secretion and resistance. Now, please understand that all these organs, the defect has to be at the cellular level. And if it has to be at the cellular level, then what is going inside the cell, that needs to be understood. And that's why we are moving from organs to organelles for better understanding. And one of such organelle is mitochondria, which is the powerhouse of the cell. And we all know that each cell is having almost 1,000 to 2,000 mitochondria in it, and is the major volume of each cell. So malfunctioning at the level of mitochondria can be a big problem, because if you don't have powerhouse to run the cell will lead to the dysfunction of the organ, and finally the organ will lead to development of problems. So I'll not go into the detail. We all know that beta cells are exhausted by the time of diabetes is diagnosed, probably up to the tune of 80%. There is the functional loss. And please note, this is the functional loss initially, and then it's the loss of volume. And at the level of liver, the glucose is being produced very fast in diabetes, and an extra 25 to 30 grams of extra glucose is dumped into the circulation in type 2 diabetes as compared to the normal people. So again, there is a problem at this cellular level at the liver. Muscle, big problem at the cellular level. Two important pathways, the P13K AKT pathway, which leads to increased expression of GLUT for muscles and increased uptake of glucose, is hypofunctional, or it's downregulated. Whereas the MAP kinase pathway, which leads to inflammation, atherosclerosis, and cell growth and proliferation, is activated, and it leads to fast development of increased inflammation, atherosclerosis, and cell growth. So this is again a pictorial representation of what I have told you, but it's very complex one. I will not go into the details, I'm going to skip it. But adipocytes, again, one of the biggest endocrine organ of the body, because the fat cells, they are playing an active role, especially in diabetes and lipotoxicity and increased circulation of free fatty acids, ultimately leading to activation of pro-inflammatory cytokines, leads to disease progression. At the GIT level, then GLP-1 and GIP secretion is being altered, and there is resistance to the GIP. And again, this all has to come from the cellular level. Same thing is happening at the kidney. The convoluted tubules, they are absorbing the glucose up to the tune of 4-fold in diabetic patients as compared to the normal people. And the alpha cells, they are secreting more of glucagon, high fasting glucagon. Then there's a dysfunction at the level of brain. And this is the octet pictorial representation, but I've already discussed in brief about the dysfunction at each organ level. But finally, at the heart of the matter is the mitochondrial dysfunction. And mitochondrial dysfunction refers to dysregulated energy substrate metabolism in mitochondria. And healthy mitochondria allow alternate fuel switching involving glucose substrate or pyruvate, and alternate switching of metabolites in the mitochondria is lost. So if you see the mitochondrial dysfunction across the organ systems in type 2 diabetes, at the level of the cardiovascular system, where the vessel is also involved, is decreased ATP synthase, decreased mitochondrial density, decreased electron chain transport expression and activity at mitochondria, and finally, increased glucose lipotoxicity and decreased nitrous oxide, which can lead to development of endothelial dysfunction and vascular disease. At level of muscle, again, decreased ATP and ETC expression and increased oxidative stress, pancreas decrease ATP, and at the level of fat cells, decrease antioxidant enzyme, decrease mitochondrial number, and decrease ETC components. So mitochondrial dysfunction in diabetes and regulatory roles of anti-diabetic agents on the mitochondrial function needs to be understood, whether it is the existing anti-diabetic agents or the newer ones. And there are many pathophysiological pathways such as oxidative stress, inflammatory responses, adipokines, insulin resistance, insulin signaling, and beta cell apoptosis, which are seen in diabetes. And there is an increasing evidence that the role of mitochondrial dysfunction in the onset of diabetes is related probably to these processes. Now, there can be various causes for mitochondrial dysfunction in diabetes, and these can be point mutations in mitochondrial DNA, or whether there is activation of protein PKC pathways, where there is accumulation of long chain fatty acid CoA in the mitochondrial in the cells, the cellular level in different organs. Then mitochondrial induced oxidative stress is also can be the culprit. And if you see the pancreatic beta cell dysfunction, then mitochondrial dysfunction may also be involved in the pancreatic beta cell malfunction. And it suggests that excess production of mitochondrial free radicals in beta cells was associated with beta cell failure, leading to decreased insulin secretion. So there are various mechanisms which have been postulated each on the organ level, which generates from mitochondria. And there has been a strong relationship of mitochondrial dysfunction to diabetes and its complications. And there are different anti-diabetic agents which may have a protective effect against the mitochondrial damage through mitochondrial-dependent oxidative change, stimulating mitochondrial biogenesis and increasing the mitochondrial mass, potentiating the mitochondrial antioxidant defense system, and adjusting the mitochondrial membrane potential. But this can be converse also. Degrees of mitochondrial toxicity and mitochondrial suppression by few of the anti-diabetic agents have been reported that require clarification, because at the end of the day, the glucose control is not important, but addressing the underlying pathophysiology is more important. So mitochondrial dysfunction accounts for both skeletal muscle insulin resistance and impaired pancreatic beta cell insulin secretion, and long-term exposure to glucose-free fatty acids surpass the adaptive threshold for entering lipoglucose toxicity, and it leads to decreased ATP, and it leads to development of hypertension, dyslipidemia, and vascular complications. And this is a slide which shows the metabolic inflexibility in obese or type 2 diabetic cases, where the mitochondria switches toward the fatty acids. There is more of lipolysis. The free fatty acids are circulating in high number. And when mitochondria switches towards the fatty acid metabolism, then there is, at the end of the chain, you will find that there's increased glucotoxicity. And finally, the mitochondria gets dysfunctional. So this again is basically a representation where you can see on the right-hand side how the signaling is happening at the level of the mitochondria, and the MAP kinase pathway is activated, and there is decreased mitochondrial pyruvate uptake and lipid oxidation, and there is decreased substrate utilization for ATP generation, decreased nitric oxide production, and decreased glucose entry and endothelial dysfunction, thereby leading to all macrovascular complications and metabolic complications like hypoglycemia, dyslipidemia, and hypertension. So this slide summarizes that how mitochondria is sitting at the center, and the dysfunction can be because of genetic factors or environmental factors like obesity and pollutants. But finally, it leads to beta cell dysfunction and insulin resistance. And there have to be interventions then which should target the mitochondria and diabetes. And you can see here that how well it is represented over here. The mitochondria as an effector target of main diabetic factors such as obesity, aging, and sedentary habits, which all cause a decrease in the respiratory capacity. So if you see here this line, so if you have obesity, aging, sedentary lifestyle, the respiratory capacity at the cellular level is reduced, and mainly the mitochondria is sitting here, which is the powerhouse and which is the respirator of the cell basically, and lead to diabetes. But when you are adopting good practices like healthy diet, exercise, or maybe some pharmacological agents which have beneficial effect on these mitochondrial function, then you have an improvement in metabolic health. So the modulators, they make a point. They are drugs that benefit patient by novel mechanisms that would make the system, tissue, or organ function efficiently without altering the hemodynamics. And these are the mechanisms, how they correct the cellular defect in type 2 diabetes, right? They correct the metabolic dysfunction arising due to inappropriate underutilization of carbohydrate, protein, lipid substrates. They directly correct the metabolism defects in liver, pancreas, and skeletal muscle, thereby leading to improved insulin secretion and resistance. And directly, they improve cellular energetics by glucose and lipid disposal while improving nitrous oxide mediated endothelial dysfunction and severe risk. These are the various modalities. Exercise can increase the mitochondrial function, and how that it increases mitochondrial biogenesis and the mitophagy, that is the mitochondrial turnover. And these are different mechanisms that how the muscle contraction, which is the key element when one does an exercise, that how the AMPK activators, which are basically the energy sensing enzymes or the substrate utilizing enzymes at the level of the muscle, which leads to increased glucose uptake and enhanced insulin sensitivity and beta oxidation of fatty acids, how they are activated. Because transient low intensity reactive oxygen species production caused by physical activity serves as a signal where the mitochondrial biogenesis and function is improved, which is called as mitoformesis. And when this happens, then the glucose substrate uptake is there, and you can see here that how it is represented over here. So increased mitochondrial biogenesis, mitochondrial turnover, increased respiration, increased ratios like increased AMP, ATP, and NAD and ADH, increased cellular concentration of calcium, and there is mitohormesis, and this all leads to insulin sensitivity. So this is the role of exercise, how it is having better. And in this continuation, there are other drugs which can activate the AMPK pathway like metformin, canagliflozin, AICAR. There are new drugs which have effects on allosteric drug and metabolite site. And then we need to know about the existing pharmacological therapy and their effects on mitochondrial function. Metformin and sulfonylureas have been shown beneficial by having effect on respiratory complex inhibitor, and they are indirect AMPK activators also. Same thing with the pioglitazone. They are MPC inhibitor, and they are PPR agonist, and they have a better function of mitochondria. SGLT2 inhibitors, again, they are beneficial, and I will not go into the details because of shortage of time. Insulin, again, is beneficial, and it has a better effect on the electron transport chain of the mitochondria, which is the key for its function. Then there are drugs like NAD boosting molecules like SEP-MOX, which might be beneficial. It's a lipid lowering agent and increases OX-phos capacity. And then again, simvastatin has not been shown to be beneficial. Then lifestyle modification, dieting, what happens to the dietary restriction? So restricting calories alone does not have a good impact on mitochondrial dysfunction because there is increased generation of free fatty acids if a person is starving. But if you have dietary modification along with exercise, then probably you have the best results where you can improve the mitochondrial function. Then there are novel therapeutic approaches which target mitochondria like exercise mimetics, and these are AICAR, AMPK activators, PPR agonists. Resveratrol is one of them, which is found in grapes and red wine, and then epicatechin, which is found in coca and dark chocolate. And please note that the grape, red wine, and the dark chocolate has been touted as the protective agents for coronary artery disease and endothelial dysfunction. The other novel therapies being tested are imeglimin, which has dual effect on both glucose stimulated pancreas insulin secretion and insulin sensitivity in liver and muscle, and it makes it a great candidate for therapy. Then another research molecule, TRC 150094. It's a novel mitochondrial modulator that can restore metabolic flexibility by improving insulin resistance in preclinical studies. And it is being studied in India. and probably it may see the light of the day someday. Then allosteric activator of circa, right? I'm moving fast because of time, but this is the comprehensive slide which shows that how different kind of drugs and the newer molecules which are in development can improve the mitochondrial function, where you can have mitochondrial membrane property modulators, and you have PPAR agonists, AMPK activators, MCP inhibitors, CoQ10 analogs. There are so many, and there are novel drugs which are coming. So ultimately, they improve the insulin secretion and resistance. So ideal OAD for multifactorial approach should be available with us, which should target these mechanisms. And in context of my presentation today, I've just shown the mitochondrial dysfunction as one of the target, which improves insulin resistance, insulin secretion. And final effects are these ones where we want a better control of HbA1c, blood pressure, CVD risk. The drug has to be neutral and has a beneficial effect on lipids. So another, this is a basically paper which has recommended that how mitochondrial modulators can be used and can be placed in usage. And you can see here that along with metformin alone and along in the combination with SGLT2 inhibitor, and not only type 2, but even in type 1 diabetes, you can see here in the type 1 diabetes also. So they have been touted to be beneficial because they correct the core defect. So concluding slide, that with recent advances in the field of type 2 diabetes, it has become evident that mitochondrial dysfunction is a central element in the disease pathogenesis and progression. Hence, understanding of diabetes pathophysiology at the cellular level, like mitochondria, is the new way forward for novel therapeutic agent developments. And with this, we can hope that the aim of therapy of diabetes in coming years shall shift from reducing blood glucose to correction of underlying disease pathology and possibly halting the disease progression. Thank you very much. And I have moved fast and skipped some of the slides because of time. So maybe if there are any questions or clarifications, we can discuss. Thank you very much.
Thank you, Puneet sir, for the wonderful talk. Thank you. We will have question answer at the end of the session. So can we have, I would like to request chairperson to introduce Dr. Jyoti Dev sir. Dr. Mayura, Dr. Baheti.
Yeah, Dr. Sabu, I'm there.
Yeah. Can we take on the next speaker?
Yes, we can. I think we should. It's almost the time. We'll take the next speaker, and I invite Dr. Jyoti Dev. We know Dr. Jyoti Dev very well, and he has been a thorough academician since long, and we have been following his so many papers and so many talks. So he is he's the chairman of Jyoti Dev's Diabetes Research Center at Kochi. He's vice president of IRO, that is All India Obesity Kerala chapter. He's a reviewer of more than dozen indexed endocrinology journals, that is Diabetes Care, Diabetes Technology and Therapeutics. He's associate editor, Journal of Diabetology. He publishes a monthly internet-based free diabetes newsletter for the past 11 years. He's one of the first authors for Indian guidelines on vaccination, insulin pumps, and glucose monitoring. He's pioneer in cost-effective treatment of diabetes with use of telemedicine and technologies. He's delivered lectures at the ADA, IDF, ATTD, and EASD. He has lectured in more than 500 forums all over the world, I would say. And his center is recognized for the excellence in diabetes care and education. So there is long list with Dr. Jyoti Dev. I welcome Dr. Jyoti Dev for the next lecture. And
Thank you. Thank you very much, Dr. Mayura Kale, for the kind words of introduction. And congratulations and thanks again to Dr. Prayas and the team. What should be the duration of my lecture? Is it 20 minutes or 25 minutes? Dr. Prayas?
Sir, it's 20 minutes and then
20 minutes. Thank you very much. So let me share my slides, and this is going to be a lecture. This is a topic which is suggested and given to me by Dr. Bharat. And in the Next 20 minutes, I'll be discussing on automated insulin delivery devices. So we have been listening to a fantastic lecture by Dr. Puneet Saxena, and we were going through the biochemical abnormalities, the mitochondrial dysfunction, and there were a lot of discussions on the upcoming drugs in diabetes. So this is going to be a different story altogether, how we can automate the delivery of insulin discovery when we are in the centenary year of discovery of insulin. And I will also be discussing what is a new arrival in India. And the long wait is over for we in India. And soon we will witness the launch of the stage 4 of automation. So there are different stages of automation for insulin pumps. I'll be definitely discussing the various stages of automation. And we will be witnessing the stage 4 of automated insulin delivery in India very, very soon within the next 2 weeks. And this is the answer to the long awaited question. So this is the guy, and he represents the parent. You and me are treating hundreds of patients with type 1 diabetes. They keep on asking us, doctor, my son, my daughter is having diabetes, and when will the insulin be automated? Of course, there are the conventional insulin pumps, but when this be a fully automated device? And this has been a dream for, I would say, 100 years. And how can we automate the delivery? It is very simple. It looks very simple. You need a smart insulin pump. You need an advanced and reliable continuous glucose monitoring device. And then you require a modulating or a control algorithm. So what do you mean by artificial pancreas? Artificial pancreas will automate the information. So information is automatically collected, and then the decision making is automated, and even the insulin delivery should be automated. And this is despite the various nuisances, and there are a lot of disturbances. And these disturbances in diabetes could be because of anxiety, could be because of stress, the meal pattern, the exercise, the sleep. So there are a lot of factors which can affect control of diabetes, and this is normally regulated by the normal physiologically secreting insulin from the beta cells in the normal healthy human being. And this is what we are dreaming for the artificial pancreas to do. So these are the different stages. I know this is the Asia Diabetes Forum, which is a masterclass, and this is more or less like a teaching session. And these are the various stages of automation, starting from the basic system and then moving on to stage 2, 3, 4, and ultimately it is stage 5. So I will very briefly go through all these stages of automation. But remember, when did we start using pumps in India? It was in 2004 when officially Medtronic, I will be discussing predominantly the Medtronic or the Minimed insulin pumps, because they were the insulin pumps consistently available in our country. From the beginning onwards till even now, they were consistently available in our country. And when you consider the insulin pumps as a standalone device, they are not automated. They will be simply delivering the dose of insulin, which is programmed based on the different basal patterns or the profiles. But this date you should remember, or the year you should remember, because this was the year 2006 and 2007. Because 2006 we started using, and these were the imported pumps the patients used to bring to our centers in India. And then 2007 onwards, they were officially made available. So this was the year when we started visualizing, when we started seeing the glucose, the interstitial glucose values on the pump screen. And it was an excitement. The pump screen displaying the real-time interstitial glucose values, and just keep on changing. They kept on changing every 5 minutes. And this was connected, the sensor was connected to the insulin pump via radio frequency. And of course, I agree with you. Although these were the first sensor augmented pumps in India, the sensors were not that accurate, but still they were able to give us the alert and alarms for hyperglycemia as well as for hyperglycemia. So this is something which is old, and we used to describe this as partly closing the loop. And it was a phenomenal breakthrough at those times. And then we moved towards stage 1 of automation. So stage 1 of automation was a particular number, for example, 70 milligrams per deciliter can be programmed. And based on the CGM glucose values, the pump will stop the delivery of insulin when it reaches a threshold. And that is called threshold suspend pumps. And this was the 530G or VO was the first generation of those pumps. And this was the picture which we took of the first patient, which we initiated in the year 2012. There were merits. The merit was it could prevent a severe hypo. And this was the first stage for automation. What was the demerit? The demerits were still there is hypo because it couldn't prevent a hypo. That was not possible. Another demerit was after 2 hours, the pump will again automatically start secreting or it will deliver insulin. And that could be a patient who probably suffering from a hypo. So those were the 2 major demerits. And then we were moving ahead with the second stage of automation. And this could predict when the glucose is going to low. So there is a predictive low glucose. And here we started measuring the time in range. So this was when we started assessing the time in range when hemoglobin A1C was no longer significant. Because when we are using insulin pumps and automated delivery systems, the whole aim, objective is to have the patient optimally spent in range, that is between 70 and 180 milligrams per deciliter, and then maximally prevent the time which is spent below range, that is level 1 hypo below 70 and level 2 hypo below 54. And of course, level 1 and level 2 hypoglycemia, which is above 180 and about 250 milligrams per deciliter. So this was capable of reaching up to 63% TIR, and that is phenomenal. I would say it is phenomenal, and this was when we started using the control algorithms. And this is still the popular automated delivery system in India, 640G, the first gen artificial pancreas, is still the popular insulin pump connected with sensor in our country. And this, why was it so special? It was so special because when we started using this is the news of the patient who started using it first time. So this had a smart guard mechanism which will prevent the occurrence of a hypoglycemia. So before the hypo, the pump will stop insulin. And once the hypo is over, then only the pump will resume the production of insulin. So the pump will resume insulin only when the glucose is back to normal, which is not time dependent. Basal insulin delivery. So the basal insulin delivery started automatically changing once in every 5 minutes, especially during the night time. But still, the patients need to manually bolus whenever they are having a meal or whenever they are having a snack. So these are the hybrid closed loop systems, the HCL. And the prototype, again from Minimed, is 670G. So there are many other manufacturers. I am only discussing Minimed Medtronic because they are the pioneers both for insulin pumps. And remember, they were the ones who introduced the CGM as well. It was CGM's gold long ago. And from 670G, we are moving ahead with stage 4 of automation. Stage 3 was not available in India. It is still not available in India, but we will be very fortunate to have stage 4. So we will be actually moving from stage 2 to stage 4. And this is the automation where we will be successful in exceeding the target recommendation. That is, we will be moving ahead with almost 80%, 75 to 80% time in range. And what is special? I'll be discussing this in detail towards the end of my discussion today. This will automatically adjust the delivery of basal insulin once in every 5 minutes. And this is in response to the sensor glucose values, both for low and for high. And remember, a situation where we have forgotten to deliver the bolus. Bolus is manually delivered. So all these hybrid closed loop systems, the bolus is manually delivered, and we have forgotten to deliver the bolus. The pump by itself will deliver the bolus. So it will automatically deliver the bolus up to every 5 minutes if the control algorithm decides so. So this is going to be a much advanced system, the advanced hybrid closed loop system, where these are some of the initial studies, and this was presented in the ADA in the year 2020, the 90-day US pivotal trial. One of the studies have been published yesterday in Diabetes Technology and Therapeutics. All these studies have shown that the overall TAR could be above 75%. But remember, overnight TAR, because all of us are scared. If you ask anybody with type 1 diabetes, the parents will tell you, and this is a scare for all the physicians, and this is a nightmare for them, sleepless nights for the parents. The overall overnight time in range is up to 82%. 82%. And auto correction with the help of smart guard and with the help of algorithm, contributing to 22% of the total bolus which is delivered. So 22% was automated and the rest was manually delivered. And this is incorporating the DRIAMED algorithm. And the DRIAMED, this is a consortium which is formed by Tadej Batinov, Moshe Philip, and Thomas Dane. All of them are very good friends of Dr. Benshi as well as me, and they have actually created or innovated this new algorithm. And this is incorporated in the new insulin pump, that is a stage 4 of automation. And if you are manually adjusting the active insulin time, look at the left and the right hand, please compare the overall TAR, which is improving when you are reducing the active insulin time from 2 to 3 hours down to 2 hours. So from 76, it has gone up to 79% overall TAR, and the overnight TAR also has been improving from 84 to 87%. So with expertise and with experience using the new system, the 780G, our patients and physicians will be capable of achieving much more than the initial promises. And this is again a very old publication, more than 10 years old, in 2010, when it was more of a necessity or a legal requirement for us to publish an insulin pump guideline for our country. So I approached almost all these KOLs, including Dr. Mohan sir, and all of us tried to establish guideline for developing countries, because insulin pumps were new at those times, and even the doctors were criticizing. Some of the senior physicians and endos, even they were criticizing, why do we require insulin pumps? We are having the syringes in India, we are having the insulin pens in India, then why should we have insulin pumps in our country, which is unaffordable? But now we know these are life-saving devices, because almost everybody earlier with type 1 diabetes used to have uncontrolled diabetes, and we know the history and how it all evolved. And I am, as an individual, and all of us are very much grateful to RSSDI, to Dr. Benshi Sabu, to Dr. Basan Kumar, Dr. Sanjay, and the entire team for implementing a lot of newer resolutions and projects for supporting our patients with type 1 diabetes in our country. And we do have published a lot of research, and this is excited, exploring the pleiotropic benefits when using insulin pumps in all types of diabetes. What do you mean by stage 5 of automation? Stage 5 of automation means you need not bolus during a meal. The meal need to be recognized by the device, and the device is going to automatically bolus. And this is going to be the ultimate. Automatically deliver the appropriate meal boluses by recognizing, detecting the carb content in the meal. And then you can probably describe or define it as completely closing the loop. So these are the globally available systems. Most of them are not available in our country, but I should not be forgetting to mention the DDATs. DDATs, there are many in number, more than 50 of them are there. They are the dedicated ones with children with type 1 diabetes, and they have created technologies not just for supporting their children. They have created technologies for the entire type 1 diabetes community. This is Damiano, and this is his lecture at the Boston University when he has partnered with them, and he has created this for his child, David, with type 1 diabetes. And this is the founder of type 2. And if you look at the other, this is the automated delivery system from Damiano, the generation 4, where in addition to insulin, there is also glucagon incorporated in the pump. And they have all established with hashtag, we are not waiting. So we are seeing a lot of technological innovations in other industries, in other branches of science, but why not in diabetes? So we are not waiting for the technologies. We are not waiting for the doctors. We are not waiting for the companies. We are not waiting for the FDA to regulate or approve. We ourselves are going to create. And this has resulted in do-it-yourself artificial pancreas and many other systems. So the do-it artificial pancreas, DIY artificial pancreas, can be classified into 3. The open APS, the loop exclusively for the Apple phone, that is iOS operating system, the Android exclusively for the Android users. Each of these have its own benefits and of course some demerits. So this is an extensively written review from Dr. Benshi Sabu, me and the team on how we can create ourselves an artificial pancreas. Of course, these are not approved by any scientific organization or by the governments, but thousands of patients all over the world are already using it. And hence, a basic information, a basic know-how of what exactly is DIY should be there for every physician treating diabetes. So they're using the older insulin pumps or the newer ones which are open to connect with the continuous glucose monitoring systems. And the patients are using the open source algorithms. If you ask me the difference, some of them are reaching even 90 to 95%. Incredible time in target, with almost not even 1% time spent in hypoglycemia. But most of these innovations are using a hybrid system rather than a completely closed-loop system. The reason being, not only the lag time with the sensors, another reason is the currently available insulins are not that rapid enough. Of course, we have the faster acting insulin aspart, the ultra rapid acting Lispro, but still the time and range remains the same with these newer insulins in the pumps. So the delayed absorption of the subcutaneous insulin is still a major hurdle. And this is another insulin pump which will be soon launched in India. And if launched by Accucheck, this will be the first ever patch pump. So the patch pump will have insulin incorporated in the same patch which is attached to the skin so that there are no infusion sets externally visible. So there are no tubes and strings attached. So something about the new launch, 780G, the path-breaking innovation which we launched in India by the end of this month. And these are the components, the smart insulin pump. It comes along with the Guardian Sensor 3. This is the Link 3. And this is a fairly, very reliable sensor. And in the same package, there'll be an Accucheck gauge meter. So this is another advanced glucose meter, which will automatically communicate the glucose values to the pump. And this can also be connected with your smartphone, where it is connected wirelessly to the CareLink server. And of course, by USB to download the data. So it is designed to optimize, to maximally spend within the range. And SG stands for sensor glucose. And the goal is to have 85% time in range. So it uses the different algorithms, the proportional integral derivative, the model predictive control, the fuzzy logic. And what is the PID? The PID is proportional integral derivative. So the proportional is to find out how far the sensor glucose. So this is the distance from the target. And integral is how long, that is the duration, which is away from the target. And derivative is the speed, how rapidly the sensor glucose has been changing. So the algorithms are fairly new, and that is the reason for its accuracy. And at the touch of the button, it will also display the time which is spent in range, below range, and above range. Yes, of course, this is the necessity. This is Dr. Benshi Sabu and one of the recent recommendations to adopt DIR in all types of diabetes, including type 2 diabetes, since this is an urgent requirement. Remember, if something is repeatedly going mistake, if something we do repeatedly, is again when we are committing mistakes, when your patients are not reaching targets, when your patients are again succumbing to the complications of diabetes, it is time to stop and look behind, and it is time to review whatever we are doing. We may not be right, but these are some of the exciting moments when the American Association of Clinical Endocrinologists and the ADA EAST, all of them recognizing some of our recent original publications in technology from our country. And this is on continuous glucose monitoring. This is on do-it-yourself artificial pancreas, where Dr. Benchisabu is also a co-author, where the original research from India in technologies has been recognized and incorporated into the clinical practice guidelines by the major scientific organizations. And we in India, we are also performing an original research on creating an algorithm, and this is for elderly with type 2 diabetes, and this is in brittle type 2 diabetes, an artificial pancreatic algorithm, and this is one of those publications, the smart artificial pancreas with a diet recommender system. So this is my last slide. Last evening, and that was December 3rd, 2021, in many parts of India, especially in the north, some mysterious lights were seen, and this has gone viral in the social media, especially in the northern part of the country. And what were those mysterious lights? The reports have suggested these were created by the Starlink satellites. Starlink satellites, and this again is the innovation by Elon Musk. And this group of Starlink satellites, and these are operated by SpaceX, another project from SpaceX from Elon Musk. And this is to offer internet in those areas where there is currently no coverage, especially in the rural parts, not only in India, but in the entire world. And this is exactly where we are in technologies today. So thank you very much for this opportunity and for your patient listening.
Thank you, sir, for the wonderful talk. Thank you. So I just have one question, sir. How we can make it more affordable to reach to the far to reach areas, the poor people, the villages, how we can percolate knowledge and technology both?
So Dr. Parisabu, I believe that your question is specifically with respect to automated insulin delivery systems, because it has become much more cheaper, user-friendly. But the hurdle here is we need to have cheaper continuous glucose monitoring devices. Insulin pumps can be created in India. It can be manufactured in India. And it is possible because insulin pumps have been there around for more than 50 years now. So that is not a big deal. CGM is still very expensive. So I have been discussing with many patients using the artificial pancreas and do-it-yourself artificial pancreas in India. So they have used third-party devices to connect to the currently available sensors, and then they are connecting to the old model of Medtronic insulin pumps. But there is a risk involved. So I believe that if we all can create a consortium and work in unison with some of the technologists, I mean some engineers, IT, then probably this will become a reality. Because we cannot do it ourselves as doctors. We need to partner with those who can create an algorithm, those who can create cheaper versions of the pumps and so on. But there will be some sensors reaching India very soon from Korea and from China and from Japan. So they are supposed to be probably much more cheaper than the currently available ones with a similar accuracy. So the future is going to be bright even for those who cannot afford. Thank you, Dr. Bharat.
Sir, I have a question. What will be the cost of the patch pump which you said will be launched soon? And I mean the one-time cost and as well as the recurrent cost of that patch pump.
This is not launched in India yet. And this has been actually available for more than 10 years. This has been the property of a startup company by name Medingo, and they couldn't market it. So a couple of years ago, Roche Accucheck has procured this, and this is a modified version of the pump. And they are also planning to have this launch along with the CGM. So the cost will be almost similar to the other pumps. The cost will be almost similar to the 780G. And they are waiting to launch because currently it is only a standalone pump. But if they can connect it to a CGM, then it becomes an automated delivery. Because in future, I don't think that anybody will launch only an insulin pump. Because everybody will be launching either their own pump and sensor, or, there is something called ACE pump. And these are control-enabled pumps, and these are the insulin pumps which can be connected to any sensor. One exception is Medtronic pump, because a Medtronic pump can work only with their sensor. So it cannot work with another. That is why the people are hacking and then trying to explore and find out reasons to use older pumps. Older Medtronic pumps can be hacked and they can be re-engineered so as to work with the current sensors. And that is how they are creating the DIY. So the cost is almost going to be similar, but I would say that, Dr. Mayur, it is unaffordable to the common man. Dr. Vasan Kumar, our current RSSA president, is there, SAR is there. So all of us together, and Dr. Benshibai is already working on it for several years. So we probably together can do something so that it becomes affordable to the common man.
Yes, that would be really great. Thank you. Thank you, sir.
Yeah.
I have a question for Dr. Saxena, sir. Sir, can you hear us? I think he can't hear. Anyway, I just wanted to ask him whether is there any difference between the mitochondrial modulation done by the different kinds of exercises? So whether aerobic exercise will have some different modulation and resistance training will have some different modulation or not? That's what I wanted to know, if he can answer. Anyways, I think I will hand over the session to Ishita for further to go to next session. Thank you, Jyoti Dev sir. Thank you so much. Thank you.
Thank you, Mayura ma'am.
Sorry, there was a disconnect, temporary disconnect. Thank you very much. I could not gather.
There is a question for you, Dr.
Okay.
Mayura madam had posted a question for you.
Okay.
Mayura ma'am, please.
Yeah, actually, sir, I wanted to know, is there any difference between the mitochondrial modulation done by aerobic exercise or resistance training or the flexibility exercises? So I just had
so there is a difference basically, because the isometric exercise leads to accumulation of more of lactate in the muscle cells and the mitochondria, and the aerobic exercise leads to production of reactive oxygen species to a lesser extent. So if you have overwhelming reactive oxygen species and maybe the products of you can say heavy hypoxia, which can be induced by isometric exercise, then the AMPK activator in the mitochondria is negatively impacted. But whereas if you are using the exercise in moderation, and that to aerobic exercise where the oxygen is also coming in, because it's ultimately the respiratory capacity of mitochondria, so that leads to stimulation of mitochondria. So that is the difference between the two.
Okay, thank you, sir. So that means our patients, diabetics, will have to go for aerobic exercise in addition to
that is the basis, perhaps, why the exercise which we recommend. Obviously, both types of exercise are recommended, but it's mainly the aerobic exercise which is recommended for diabetic.
Thank you, sir. Thank you so much.
Once again, I would like to conclude the session by thanking Dr. Bharat Sabu sir and Dr. Abhishek sir for organizing this event. Dr. Jyoti Dev sir and Dr. Puneet sir, thank you for your wonderful insights and your expertise on the respective topics. And now I'll hand over the session to one of its kind lecture to the rapporteur, Dr. Sachin sir from Kanpur. Over to you, sir.
So a very big namaste to everybody out here. I hope I am audible in.
Yes, Sachin, you are audible. Please go ahead with introduction of chairpersons, please.
Thank you, sir. First of all, it's a big thanks to Dr. Bharat Sabu sir and Dr. Abhishek Srivastav sir for giving us so nice and so big launch of this masterclass in diabetes, where we get enough of sessions on various clinical as well as theoretical topics. And moving ahead, we have a very good next session, which is clinical and theoretical both. And for this session, we have very famous chairpersons, doctors with us. We have Dr. Ashish Dhingra sir, who is from Jabalpur, and we have Dr. Subhajyoti Ghosh sir, who is from Dibrugarh. To further to further go on with the session, I just request both of the chairpersons, sir, to kindly continue with the session.
Thank you for the kind introduction, and Bharat, thanks a lot for inviting me here for the important update that is ADF, that is Asia Diabetes Forum. It is worldwide famous now. And I would like to introduce a very dynamic, my friend, Dr. L. Srinivasa Murthy from Bengaluru. He is MD FRCP Edinburgh, Glasgow, FICP, FRSSDI, PDCR. He is a senior consultant physician and diabetologist. He is a Life Care Hospital and Research Center, Bangalore. He is a director of Life Care Hospital and former consultant at Fortis Hospital and Gleneagles Global and Apollo Hospitals. Over 2 decades of experience in both undergraduate and postgraduate teaching. He has faced successful US FDA audit in the field of research and faced world's first ever Canadian audit, that is outside Canada, successfully. He is a principal investigator in over 75 clinical trials and is a part of landmark trial. Trials like Hope 3, Clarify, Begin, Dwell, I, Elixa, Excel, Sustain, Soul, Flow, etc. He has been part of all these well-known trials. He is a national leader investigator for Indian multinational phase 3 study, GCP trained, fellow of ICP RSSDI, Royal College of Physicians, Edinburgh and Glasgow. He has national and international publication and deliberations to his credit. He is faculty at various national and international forums and conferences. He is life member of RSSDI, API, CSI, AARO, ACE, ACP, Endo Society, CSDI, IPF, and is a governing council member of National RSSDI. So he is a well-known personality and a very good friend of mine. Over to you, Srinivas, for excellent topic which you are going to deliver today.
Thank you, Ashish. Thank you. I thought we were 5 minutes ahead and you utilized reading out my CV for 5 minutes here. So Bharat is upset about that you lost 5 minutes in introducing me.
Actually, we wanted to have, sir, 5 minutes from you, because this is the topic is very, very interesting to me. Actually, we had a long discussion about it, and you remember Paytm number and WhatsApp transfer.
Yeah.
So please go
Thank
ahead.
you. Thank you, Bharat and Abhishek. Congratulations for the successful ADF, which is ongoing now. I think let's move on. Can you see my screen and I'm audible?
Yeah.
Great. Thanks, Ashish. And let's move on. So disclosures is Bharat is yet to send a Paytm to me, so I don't have any disclosures for this lecture. And this is going to be something called Evolution in Diagnosis and Classification of Diabetes, which we are trying to look at the history. As we say, we need to learn by history and how the classification is evolved in the diagnosis of diabetes with respect to initially with the diagnosis, the numbers, then with respect to emphasis on the treatment modalities and the complications. So that is what we're going to look at in this. Now, remember, we were first in diagnosis of this diabetes way back in 5th, 6th century, where it was first noted by these Ayurvedic scientists, the Sushruta and Charaka. So Charaka Samhita describes very clearly the Madhumeha runny urine. And it was these Indian scientists who first described even the distinct type 1 and type 2 diabetes in a detailed manner. And that's very, very surprising because this was in way back in 5th and 6th. Now, coming to the Western people, it is in the 1600s. I excuse me for probably pronouncing wrongly the spellings. The Paracelsus also described diabetes as a constitutional disease that affected kidneys and provoked excessive urination. In 1700s, several European researchers like Thomas Willis and William Cullen had attempted to describe diabetes through its classical clinical symptoms of sweet tasting of urine and basically a disease of the kidney. Then later, the research by Joseph von Mering and Oskar Minkowski on dogs led to the observation that when the pancreas of a dog is excised, it develops symptoms of diabetes. I think we all know this story. And when the urine was tested for sugar, they were able to confirm the diagnosis of diabetes. And this is how they started, which heralded that pancreas was the organ which is controlling the diabetes or the causative organ. Late in the 1800s, researchers, the Apollinaire, Bouchard, and Lancerex were able to distinguish between different patient types. Notable patients who had more severe symptoms were lean, expected to have poorer outcomes along with pancreatic lesions and autopsy. And another type of patient group who had a milder form of disease were overweight and presented at later stage in life. So these were the observations they made in late 1800s. Now let us look at the transformation and classification of diabetes per se. Until 1960s, no systemic classification of diabetes existed. It was in 65 that an expert committee on diabetes mellitus published the first WHO report on diabetes classification. Now, this report was one of the first attempts at an international consensus on classification of diabetes. The expert committee, way back in 1965, classified diabetes based on the age of recognized onset and need for insulin for survival, which seemed to be the only reliable means of classification for universal use. And the report also recognized certain types of diabetes like brittle, insulin resistant, gestational, pancreatic, endocrine, iatrogenic, all this. So these are all not new. They were already there in 1965 WHO classification. Later, the National Diabetes Data Group, the NDDG, what we call now, formulated a revised classification of glucose intolerance that was later amended and adopted in the second report by the WHO expert committee in the 80s. The 1980 expert committee proposed two major classes of diabetes and named them as insulin dependent, R type 1, and non-insulin dependent. I mean, even today, many patients, I'm sure all of you will encounter this, keep asking about this insulin, non-insulin dependent. It was very, very impactful. In 1985, study group report, terms the type 1 and type 2 were omitted, but the classes of IDDM and NADDM were retained, and new class of malnutrition-related diabetes was introduced. And it was the 1985 WHO classification that was essentially based on the clinical descriptions with specific focus on the pharmacological management of patients. That means insulin dependent or not dependent. So both the reports of WHO included other types of diabetes with glucose and impaired glucose tolerance, as well as gestational diabetes mellitus. It is now well established that diabetes may progress through several clinical stages during its natural history, quite independent of its etiology. So that becomes null and void kind. Individuals may move from one stage to the another stage in both directions. Even if there is no information concerning the underlying etiology is present, the persons who are developing the disease can be categorized by staging according to the clinical characteristics. So this type of classification allows for various degrees of hyperglycemia in individuals, irrespective of the disease process. Now, the glycemic stages ranges from normoglycemia to hyperglycemia, where insulin is required for survival, we know that. And the stage of glycemia may change over time depending on the extent of the underlying disease, the deficiency of insulin production. Over the years, the terms insulin dependent and insulin non-dependent have been removed from classification as they were more focusing for clinicians as they were based on the treatment giver rather than the pathogenesis. So we moved on to pathogenesis. And in the current widely used classification, the terms type 1 and type 2, though it was coined in 85, it is still retained. Now, ADA 2021 classification, type 1 diabetes and type 2 diabetes and specific types of diabetes. So the specific types of diabetes due to other causes, monogenic, exocrine, or drug-induced, all these are included in this, including HGDM as a separate section. So this is the latest classification, which talks about the autoimmune beta cell destruction and the insulin deficiency, the latent autoimmune diabetes of adulthood, LADA, etc. are seen, and this is mostly concentrating on the pathogenesis of the diabetes per se. So let us look at the evolution and diagnostic criteria over the decades. Now, the guidance towards diagnostic criteria for diabetes has also undergone changes over the last few decades. In 1979, the US Diabetes Data Group, now it's called NDDG, upon reviewing epidemiological studies, observed a correlation between diabetic-related complications like nephropathy and retinopathy with the blood glucose levels. And that's how they came out with 140. And if glycemia was less than 140, but more than 120, then it is called as IGT. So this is how they came out with these epidemiological studies, which are linked to the incidence of nephropathy and retinopathy and the blood glucose levels. That was in 80s. And 1997, the expert committee from ADA revised this diagnosis. The cutoff fasting values were lower to 140 to 126. From 140 to 126, that is what we follow now, because that 7 millimoles into 18 becomes 126. That's where that odd number comes. it was based on the population study showing that the incidence of retinopathy was higher even with the glucose levels which is above 120. So that is how it was brought down from 7.78 millimoles to 7 millimoles. And cutoff value of 126 for FPG reduces the discrepancy between the FPG and 2 hours OGTT blood glucose values, promoting its use in the place of OGTT, which is associated with the technical challenges, of course, lower reproducibility and greater cost. Of course, ADA defined the new diagnostic criteria within diabetes, referring to IFG for fasting glucose between 110 to 125 and IGT between 140 to 199 at the 2 hours post OGTT. So these are the new diagnostic criteria. Now, HbA1c as a diagnostic marker, of course, more than 6.5 is part of diagnostic criteria for diabetes. However, it is definitely facing many challenges because of its susceptibility to vary based on different clinical conditions such as dialysis, pregnancy, anemia, which is very common in our country, genetic background, hemoglobinopathies, race and ethnicity also have got a confounding factors on the HbA1c. So what is the current ADA criteria? The criteria for diagnosis of diabetes, FBS more than 126, PPBS more than 200, and this test should be performed as described by WHO, that is using a glucose load containing equivalent to 75 grams of glucose dissolved in water. Or A1C more than 6.5%, the test should be performed in a lab using a method that is NGSP certified and standardized the DCCT assay. So this is a big question mark in our country because we do not follow the standardization across the country. So it's a bit tricky in our country to be based on only A1C. Or the other diagnostic criteria is a patient with the classical symptoms of hyperglycemia or hyperglycemic crisis. Any random sugar more than 200 would be enough to diagnose. So this is the latest guidelines what we have evolved into. Now, pre-diabetes, FBS 100 to 125, 2 hours, 75 grams OGTT, 140 to 199, or A1C between 5.7 to 6.4. So these are very big numbers as we know in our country. We need to be very, very cautious in diagnosing these pre-diabetics and try to introduce the lifestyle modification and thus prevent progression or at least delay in the progression into diabetes. Now, GDM is there are screening and diagnosis, one-step strategy, two-step, and the step 1 and step 2 in the two-step strategies. So one step is easy. It's very, very compatible in a OPD setting where 75 grams of OGTT with a plasma glucose measurement when the patient is fasting at 1 and 2 hours are estimated during the 24 to 28 weeks of gestation. And this is in the women who are not previously diagnosed with diabetes. So OGTT should be performed in the morning after an overnight fast at least 8 hours. And the diagnosis of GDM is made when any of the following plasma glucose values are met. If it is fasting more than 92, 1 hour more than 180, 2 hours more than 153. So 92, 180 and 153 respectively, 1 and 2 hours. You should remember this because this is for diagnosing first time who are a non-diabetic pregnant woman. Two-step strategy, I think it's cumbersome, not very practical in a OPD setting, and also people who travel long journeys, all that to our OPDs, but it will be difficult. So let us move on now. In the need for this, there is an increasing need for more individualistic approach to manage diabetes, redefining the classification to identify individuals who are at an increased risk of complications at diagnosis itself, so we can offer them more personalized management to prevent long-term complications. So this is what we should move on, is the need Aadhaar. Now, the research by Emma Alquist and colleagues remarked that the current treatment guidelines focused on measurements of a single parameter of glucose alone has major limitations in the fact that they respond to poor metabolic control as it develops. Moreover, they contend that there is no means to predict which patients need more intensive treatment. Yes, we diagnose, but it does not predict who requires an intensive treatment or the other parameters, which I'm going to discuss in a couple of slides later. This is a crucial factor for prevention of long-term complications of diabetes, as the target tissues have a metabolic memory. We talk about this metabolic memory, legacy effect, all that, and that will remember this poor metabolic control for prolonged periods of time. So we need to hit hard and eat early when it comes to the initial or the first time diagnosis. So they propose this cluster-based classification. This is a Scandinavian population where they advocate identifying clusters with specific characteristics based on the 6 clinical variables. Now, what are those? The GAD antibodies, age at diagnosis, body mass index, HbA1c, and OMA2IR and OMA-A2 beta also, because beta cell dysfunction, and the homeostasis model to assess the insulin resistance. All these 6 parameters were included, and they defined into these clusters. So this is a cluster-based classification by Emma Alquist, which looks very practical, of course. The cluster 1 is characterized by early onset, relatively low BMI, poor metabolic control, insulin deficiency, GAD antibody positive. This is called as a severe autoimmune diabetes or SED. Cluster 2, labeled as severe insulin deficient diabetes. This is called SID. It's a GAD negative, but similar to cluster 1 with respect to younger age of onset, lower BMI, low insulin secretion indicated by the OMA, and the poor metabolic control. Cluster 3 is severe insulin resistant diabetes characterized by insulin resistance and a high BMI. Cluster 4, obese, but not by insulin resistance, and was labeled as mild obesity related diabetes. And cluster 5 is patients who are older than the patients in other clusters but showed only modest metabolic derangements. So this is how they classified based on these 6 parameters. So this is a new and unique cluster based, and we also have this in our South Asian population, which is studied by our South Indian Dr. R.M. Anjana and colleagues. They have proposed this, and this Asian phenotype definitely is different and unique in many ways, because we have younger age of onset, thin fat Indian phenotype, low muscle mass, sarcopenia, increased insulin resistance, and less obesity. So this is what we see in most of our patients, and this they have modified and proposed this cluster-based classification of the South Asian population. These people have included 8 variables which defined clusters at the based on the age of diagnosis, BMI, waist circumference, HbA1c, triglycerides, HDL, as well as fasting and stimulated C-peptide. So this looks more practical, less financially burden onto the patients, because waist circumference, BMI, A1C, triglycerides are all routine workup which we tend to do, except for the C-peptide, which may cost little, but definitely they are more practicals. So the 2 clusters identified were similar to those of the Scandinavian population, the SID and MERD. That is, the 2 new groups were added here, the insulin resistant obese and combined insulin resistant and deficient diabetes, which is very typical for our, again, Indian context. So what is the difference in approach? The individuals falling in the milder clusters would not require aggressive management, whereas individuals with severe insulin resistant, insulin deficient would definitely benefit from aggressive management with the pharmacological agent. So this is what we should look upon now, that based on the severity of the disease or the deficiencies, which should help us to prevent their complications. So we can target the treatment by the classification using this simple 6 clusters, 6 variables, so that we can identify which patient will require early aggressive treatment or less aggressive with the pharmacological agents. Of course, the lifestyle modification is always there. So such cluster-based management also helps us in appropriate selection of drugs based on the individual specific requirements. So to conclude, the challenge is overwhelming in resource-constrained and limited health expenditure settings, such as the countries like India and China, where the prevalence of diabetes is exponentially rising. Therefore, the adoption of more complex and multiple pathways for diagnosis and management may not be affordable and hence practical and feasible. And simple diagnosis with parameters like A1C, FPS, OGTT, the waist circumference, these are the parameters which you should look at, especially in a country like ours, which will be still most suitable options for large patient population in such developing countries. Thank you very much for patient hearing, and any comments, I would be very happy, because this is history. I don't think anybody would have questions on the history part, but definitely you can put forth your thoughts and comments. I'll be very happy.
Thank you, LSM, for a nice lecture. And over to the chairperson, co-chairperson, if there are any questions. Ghosh Dada?
Yeah, good evening. The program seems to be very good. The deliberation was very insightful by Dr. Murthy sir. So now we can go to the next talk.
Kindly play the CV of Dr. Sandeep Mathur sir, although he doesn't need any introduction, but still it's customary, please. Pranay, can you play the CV slide of Dr. Sandeep Mathur, sir?
So good evening once again to all. So today our next speaker will be Dr. Sandeep Mathur, sir. He is serving as a professor and head of Department of Endocrinology. Then he is keenly involved in research and has conducted several clinical trials over the years. He's a dedicated writer, having contributed regularly with papers and articles, many of which have been published in peer-reviewed journals. He has a fellowship in molecular genetics, physiological genomic group, Imperial College School of Medicine from London, and he has also like a bibliography of his work published in well-known journals. So over to you, Mathur, sir.
Thank you very much. I want to share my screen. Somebody else is also sharing, I believe. Okay. Yeah. Can you see my screen now?
Yes, sir, it's visible now, sir.
Yeah. Visible now?
Yes, sir.
Thanks to Bharat for accommodating a topic of my choice. Thank you, Bharat. Are you listening? I'm audible?
Yes, sir, you're audible, sir.
Okay. I will speak about for next 25 minutes about lipodystrophy syndrome and thin fat phenotype clinical implications. So there are two keywords in my title. One is thin fat phenotype. And we always talk about Asian Indian thin fat phenotype, central obesity, more visceral fat, more metabolic problems. But our attention is on the belly, our attention not on the limbs which are thin. Actually, my focus of my clinical as well as molecular investigations, as I will show in my presentation, on the thin limbs, which believe is the major factor for Indian dysmetabolism. You know, we current epidemic of diabetics in our country and all these things we talk about, and I think this originates from these thin limbs rather than large belly.
Mathur, sir, sorry to interrupt. Your slides are not visible, sir.
Not visible, but not visible.
Yes, sir. Your that tab with rediff mail is visible. Your slides are not visible.
Oh,
Dr. Subhajyoti, am I right? Can you see it?
Yeah. Yes. On the tab is visible, but slides are not visible.
Just a minute. This I will log out. Now visible?
No, sir.
No, sir. Still not.
Just a minute. Yeah. Now visible?
Yeah, now it's visible, sir.
Not visible?
Yes, sir, visible. Now go to the full screen, sir.
Okay. Yeah, it's fine. Okay?
Okay, sir. It's fine, sir.
Done, sir.
Visible?
Yes, sir.
Yes, sir, visible.
No?
Yes.
You are very much visible, sir. Slides are visible.
Good to go, sir.
I'm audible?
Yes.
Yes, sir.
Thank you. Yeah. So, you know, I mentioned that Indian phenotype is thin limbs and increase actually your visceral adiposity or central adiposity. But what I want to point out here, thin limb is very important part of Indian phenotype, which has been largely been ignored. Same time, in this presentation, I am drawing your attention to a genetic syndrome or a non-genetic, also a rare syndrome, so-called lipodystrophy syndrome. Actually, these two syndromes, lipodystrophy syndromes and thin phenotype, they share so many things in common. In general practice, it is very important to recognize lipodystrophy syndrome because they have their own specific treatment. So this is the background of my presentation. So now first issue is, what are lipodystrophy syndromes? You see, lipodystrophies are group of heterogeneous disorders characterized by varying degree of fat loss and predisposition to insulin resistance related metabolic complication, inherited or acquired disorder characterized by absence of adipose tissue. You know, characteristic feature of lipodystrophy syndrome is as shown in these 5 figures in this my introductory slide. You see there is loss of subcutaneous fat. So we see many individuals in our practice, but our attention is on the glucose level, our attention in the lipid level, but hardly ever we look at their subcutaneous fat. Hardly we expose our patient to look for their subcutaneous fat and fat distribution. So this is an important message I want to convey, that some of the patients who come to a clinic could be lipodystrophy syndrome instead of severe metabolic syndrome or simple diabetes mellitus or a hypertension patient. You see, the basic pathophysiologic defect of lipodystrophy is inability of that individuals to hold excess calories in the form of fat in their adipose tissue. This is the basic fundamental defect. Though this syndrome can be acquired also, like for example, with your therapy for HIV, but in a good number of patients, this is genetic. And this syndrome results from genetic defects in various steps or genes involved in your handling of your adipose tissue, your fat, right from your adipogenesis process by which the fat tissue expands. You know, our adipose tissue is not static like your bone. Even bones are also not static. You know, they are being coupling unit, they are changing. Likewise, your adipose tissue is replaced in every 10 years. So this process of adipose tissue, you know, replenishment is called adipogenesis. It could be defect in adipogenesis. There could be defect in your transportation of your triglyceride into your Golgi apparatus or endoplasmic reticulum. Could be defect in storage of the fat in your adipocytes. There are so many genetic genes which are involved in this process. There could be defect in these genes. And what happens, the consequence of this poor handling of adipose tissue or fat by your adipose tissue, there is ectopic fat deposition. If it in liver, it can lead to NASH, insulin resistant. If it in muscle, it leads to insulin resistance. It can lead to pancreas, not only pancreatitis, but also your diabetes mellitus. And of course, blood vessel can lead to your atherosclerotic process. So actually, lipodystrophy syndrome, the classical definition includes defect in adipose tissue or your subcutaneous fat or your fat tissue or adipose tissue, but it has so many metabolic features like severely elevated triglycerides, severe insulin resistance, ectopic fat deposition, progression to poor control diabetes, complications of diabetes. It lead to hyperphagia. Very important point. Some people are not obese, but they are hyperphagic. So there could be so many reasons for that. One of the reasons is lipodystrophy syndrome. This can lead to cardiomyopathy, atherosclerosis, arrhythmias. This will lead to liver hepatic steatosis, hepatomegaly, steatohepatitis, cirrhosis. It can even lead to your glomerulonephritis and proteinuric renal disease. It is independent of diabetic nephropathy. It can lead to chronic pain, mood disturbances. Of course, it is an important cause of your PCOD and hyperandrogenism. So actually, etiologically, it is broadly 2 types: congenital lipodystrophies and acquired lipodystrophies. Congenital lipodystrophy could be generalized or partial lipodystrophy syndrome. These syndromes have, broadly speaking, some specific for generalized this congenital lipodystrophy will be like AGP82, BACL2, CAV1, PT, RF. These are all genetic disorders, and these gene mutations have actually autosomal recessive generalized lipodystrophy, but partial lipodystrophy, most of them are actually autosomal recessive. Some are autosomal dominant also, like your LMNA, PAPAR gamma, AKT2, and CIDEC, etc. Similarly, lipodystrophy can be acquired and it can be associated with autoimmune disorders. So remember in your practice, if some patient is having autoimmune disorder, for example, a patient with your SLE, he comes with poorly developed fat and developed with severe diabetes insulin resistant, it could be nothing but an lipodystrophy syndrome. Similarly, it could be associated with your dermatomyositis. It could be associated even your hypothyroidism. And sometimes it could be associated with hemolytic anemia, microcytic anemia. So autoimmune disorders can also be associated with your lipodystrophy syndrome. Something if you have in back on mind, you can diagnose this patient in your practice because they have very specific treatment that I will discuss in the part of presentation. Similarly, HIV and its therapy can also lead to lipodystrophy. So remember, lipodystrophy you suspect when you see there is no fat in the patient's body. When you look from surface, that means no fat in subcutaneous tissues. It could be acquired defect, it could be genetic defect. And remember, these genetic syndromes have their unique different features also. For example, some defects could be associated with intellectual disability, some with associated with your pulmonary hypertension, short stature, hypertrophic cardiomyopathy, skeletal myopathy. Yeah. Some defects could be associated with your, for example, I'm saying muscular dystrophy. So there are several different features of lipodystrophy syndrome. So if your patient diabetic with any of these complications, just consider lipodystrophy as a diagnosis. Similarly, complex genetic syndromes can also be associated with lipodystrophy. For example, Bloom syndrome, Werner syndrome, your MOPL syndrome, and this mandibuloacral dysplasia related nephropathy. So these are in young patients, they are very rare, extremely rare, but at least clinicians should be aware of the genetic syndrome can present as lipodystrophy and severe insulin resistance and diabetes and other complications. So these are some syndromes which are autoinflammatory syndromes like your PSMB8 and Kendall syndrome, your Lawrence syndrome, Becquerel-Simons syndrome, and heart-induced lipodystrophy, which is definitely an acquired drug-induced. So keep in mind these clinical manifestations. If intellectual disability, your cardiomyopathy, arrhythmias, everything come in your diabetic patient, at least if you say there is no subcutaneous adipose tissue in your patient, consider lipodystrophy as a diagnostic entity. Now question is, what is Asian Indian thin fat phenotype? We all know about it. This slide you must have seen 10 times in life. More abdominal fat, more insulin resistance, higher C-reactive protein level, lower levels of adiponectin, diabetic dyslipidemia, low HDL, high triglyceride, and increased susceptible diabetes. This phenotype we all know about, but we know thin fat and YYU must have many times, hundreds of times. They have more fat and less fat, and Yudkin and Yagnik story you must have heard, but I am pointing to some different aspect of this story. You see increased central adiposity, but thin limb. Actually, our attention has been on the abdominal adiposity, but never on the thin limb. So I looked at the so-called, landmark studies which raised the foundation of abdominal fat story and everything. In these papers also, Indian men compared to Caucasian lacked peripheral fat. Nobody talk about them. Even these journals, despite their data, they did not know anything about it. Thin limbs in Indians. Similarly, one more study when diabetes was compared to non-diabetic, they had large pancreatic volume, hepatic fat, more central fat, but there were no mention of less fat in the limbs as compared to non-diabetics. So I look at the classical Indian data at a different perspective, that is not only more central fat or more adiposity in the trunk, but less fat in the limb, something which has been grossly ignored. So now question is, because I mentioned about lipodystrophy syndromes, they are congenital, acquired, so many varieties, so many syndromes, so many manifestations, not much talked about, and you may not have heard about, some of the audience may not have heard about them in their life as an internist. So does thin diabetic in Indian origin or anywhere in the world resemble partial lipodystrophy? Thin fat individuals are considered to be at high risk of metabolic syndrome because of their excess body fat content, more central and possibly less glutofemoral adipose mass, despite having relatively lower BMI. Phenotypically, they resemble partial lipodystrophy. Phenotypically, they resemble, but a lesser degree of defect. So these are the classical partial lipodystrophy. You see, there is no subcutaneous fat. We look at the skin, it looks pinch out like your Turner, this Cushing syndrome skin, very thin skin, but it is not fragile. Now question is, are thin fan phenotype and partial lipodystrophy genetically distinct entities or shared genetic predisposition? Now my attention is, you heard previous speaker in a subclustering, one cluster with high insulin resistance but non-obese. So my focus, that is not a small number of patients in our practice, very large number of patients. So does they are genetically, are they lipodystrophy syndromes or they're different syndromes? Are they similar, then there should be overlap between genetic loci associated with both of them. So my view is, if partial lipodystrophy and thin fat are genetically same, the gene showing association with partial lipodystrophy should also show association with your lipodystrophy syndrome as well as with your thin fat phenotype also. In fact, there are two landmark studies from this Scott's group, and they, in the first study published in Diabetes in 2014, they find that insulin resistance score, which is an score based on genes making them susceptible to develop insulin resistance. You know, insulin resistance susceptibility genes, they were given a scoring system and the score was estimated. And what they find, insulin resistant gene score was associated with lower insulin sensitivity measures, as well as score associated with lower BMI and glutofemoral fat mass. That means the genes which are showing association with insulin resistance, they show association with less fat rather than high fat. So here is a divergence from classical concept, more obesity, more fat, and more diabetes. No. If you look at genetic association, things are, it is less fat and less glutofemoral fat. So genetic susceptibility to insulin resistance is with less fat rather than more fat. So this is in favor of that lipodystrophy syndrome is possibly there in your insulin resistant state, in your diabetic. In another study which was published in Nature Genetics 2017, they find there were few genes which were showing association with insulin resistance. And interestingly, they were associated with less glutofemoral fat. That means genetic susceptibility insulin resistance is associated with less glutofemoral fat rather than your large amount of fat. So with these studies, even higher quartile, less fat. If you are more insulin resistant, even you are type 2 diabetic, you have less glutofemoral fat as far as genetic association, the root cause of your problem. So they identified 53 genomic regions associated with insulin resistant phenotypes and higher fasting insulin adjusted for BMI, lower HDL cholesterol, high triglyceride, and possibly evidence they are linked with higher cardiometabolic risk is underpinned by an association with lower adipose mass in peripheral compartments. So your genetic association with less peripheral fat. Now question is, if they are phenotypically similar and share genetic loci associated with them, then there should be an overlap between genomic network underlying these two entities. So not only genes associated, their function should also be shared between them. In fact, we developed a hypothesis that Indian phenotype is if a pattern of partial lipodystrophy syndrome or not. In fact, we enlisted genes responsible for your lipodystrophy. And this is a very popular picture on Google if you search this lipodystrophy term, that most of these genes enrich the pathway of adipogenesis. That means your adipose tissue development pathway. In fact, we are expert in the field of gene network. Genes which are responsible for lipodystrophy in different individuals, they interact with each other and they enrich on the adipogenesis pathway. So we presented this hypothesis in Biomolecules, I think 2017, and we find so many genes responsible for lipodystrophy for showing altered expression in your adipose tissue diabetic patients. So we give a theory that your type 2 diabetes thin phenotype is functional defect in lipodystrophy genes. Lipodystrophy gene, if mutation there, gene is sequence or mutated or sequence is changed, then it will lead to classical lipodystrophy. If gene function is altered, then it will lead to your classical type 2 diabetes or thin phenotype. In fact, we went further and did further functional studies of lipodystrophy genes, thin phenotype individuals, and this paper published in Adipose, I think 2020. And we find we developed network of the lipodystrophy genes, and we also developed network of your genes which were differentially expressed in adipose tissue of diabetic patients. And we find there was 18% overlap between them. That means our so-called type 2 diabetic patients are basically functional defect of lipodystrophy syndromes. And we can subcluster diabetic patient on the basis of individual lipodystrophy gene. Your type 2 diabetic patient, if you take their adipose tissue biopsy from peripheral fat and do functional study of lipodystrophy gene, they can be subclustered. So we are talking Dr. Mohan's paper subclustering on the basis of, gross phenotype, BMI and all these things. But if we go to molecular level and gene level, we can subcluster according to lipodystrophy genes. So we come with a theory that type 2 diabetes thin phenotype is basically can be, funneled down to few lipodystrophy gene functional defects. Some patients have 5 gene defect, 2 defect, 3 defect, 4 defect. So this is a new concept for type 2 diabetes subclustering. So this already mentioned. Now is glutofemoral failure generally considered to be protective, but its role in pathogenic diabetes remains unknown. What we did, we developed transcription profiling of peripheral adipose tissue and see if how it is abnormal. We find that it was pathological, and the genes which are known to be associated with the pathologic process with the pathologic adipose tissue, which is so-called adiposopathy, they were there in your pathway, were there in your peripheral fat diabetics. In fact, there were so many, modules of co-expressed gene in peripheral fat, and these modules actually have different genes which related to adipose tissue function. I will not go in detail. And in diabetes genes, many of these modules of co-expressed genes were showing association with diabetes-related intermediate phenotypic traits. That means, but none in your non-diabetic patients. So we conclude from this study that several modules of co-expressed genes show an association with diabetes and some of its intermediate phenotypic traits. Therefore, these findings suggest role of peripheral subcutaneous adipose tissue pathophysiologic in Asian Indian population. So I am now saying I have some enough data to say peripheral fat is very important in causation of diabetes, and most of the genes are related to your lipodystrophy syndromes. Now question is, with another paper, we find the modules of co-expression pathways which are associated with pathologic adipose tissue and peripheral adipose tissue were converging on the process of adipogenesis. Adipogenesis is the fundamental process responsible for thin limb. Adipogenesis failure, ectopic fat deposition, and adipogenesis pathway, same genes which are involved in your lipodystrophy syndromes. So this is pathologic adipose tissue. Now coming to clinical implication, I think I will try to wind up as fast as possible. Now question is, can pharmacologic enhancement of adipogenesis help in correcting metabolic defects in thin fat phenotype? Because I already mentioned, we have enough data or some very supportive data, molecular data, that thin fat phenotype, Indians have thin limbs, not only central obesity, thin limbs. The thin limbs have poor adipogenesis process. This poor adipogenesis leads to actually less amount of adipose tissue in the peripheral fat. Now question, can we enhance the amount of this fat by the process of adipogenesis? Would that help? That was our hypothesis. And secondly, we find that this adipogenesis defects were actually showing association with beta cell dysfunction also. So-called beta cell dysfunction genes, they are also same which were converging on the adipogenesis pathway on their intactome analysis. So we did a very simple study. We treated T2DM patient with pioglitazone, and we find that diabetics had less peripheral fat as compared to non-diabetics. And the improvement in HOMA-IR after 3 months of pioglitazone was related to increase in limb fat mass. This is an indirect evidence. Most thin fat individuals and Indian diabetics, actually high HOMA-IR is related to less amount of peripheral fat. And by pioglitazone, if we increase this amount of fat, this corrected completely the insulin resistance. HOMA-IR became comparable to non-diabetic. So this confirms that poor adipogenesis is the primary factor responsible for Indian thin fat phenotype. So this is the conclusion drawn for this paper. Need to replicate this, of course. So pioglitazone is an important drug. Definitely we ignore it as a third-class drug, but I believe even Di Fronzo believes it could be a wonderful drug for most of people. Now question is diagnosis lipodystrophy in patient with diabetes and metabolism, very important part, because lipodystrophies are having it's shown in this picture as compared to different phenotypes of fat distribution, minimum amount subcutaneous fat. So actually the main distinguishing feature of lipodystrophy syndrome and your metabolic syndrome or thin fat phenotype is actually level of adiponectin. They're drastically reduced, but leptin levels are in obesity and metabolic syndrome are elevated. This is the main distinguishing feature. So we are not doing in our clinical practice, but in research, I am doing it, and I am trying to analyze my data in the terms of who are lipodystrophic or non-diabetic, very complex subject, and I'm trying to figure out. But you see, in your lipodystrophy syndrome, BMI is less, body fat percentage is much less, visceral circumference is may not be increased, hip circumference is drastically reduced, waist to hip ratio is definitely increased, insulin resistance is much higher than your type 2 diabetes, triglyceride level are much higher. I will come to that point. And their leptin levels are low. Actually, one of the most distinguishing pathology factor these two entities is low leptin levels. Now question is when to suspect lipodystrophy in clinical practice. I think for general practice, this is a very important slide. That essential feature is generalized or regional absence of body fat. Look for body fat in the limbs. If it is very less in amount, look at the face, there is no fat, consider lipodystrophy. With the essential criteria, failure to thrive in children, prominent muscles, prominent veins, severe acanthosis nigricans, eruptive xanthomas, Cushing-wide appearance, very important point. Clinically, patient like Cushing, thin limbs, central obesity, cortisol is always normal, consider lipodystrophy. Acromegaloid appearance, very important. I think clinically I find very important criteria that they look like acromegalic, but they are not acromegalic because of the excess IGF-1, because of hyperinsulinemia. This is insulin act like IGF-1 receptor activation that lead to acromegaloid appearance. And progeria. Some people are 30 years of age, thin limbs, central obesity, they are bald, they look older. Consider lipodystrophy in these patients. Progeria can be one of the manifestations of genetic lipodystrophy syndrome. So your bald man, thin limb, obesity, I'm not saying be old, consider lipodystrophy. Another important point is they require more than 200 units of insulin per day or 2 units per kilogram body weight for control of sugar, because some of them required insulin very early in their natural history. If triglyceride more than 500, always consider a diagnosis of lipodystrophy in absence of DK and others. And early onset cardiomyopathy, NASH, PCOS, if these complications are present in your diabetic patient, consider lipodystrophy in the differential diagnosis. And I think I can avoid this. And remember, this is the diagnostic strategy. You suspect it, take the history. If they have progeroid features, if they have do detailed pedigree analysis, look for physical examination and clinical features I already mentioned. If they are all suggestive, suspect genetic lipodystrophy, and genetic testing is available for some of them, not for all. Actually, this is an area which we are very active. If you find a patient, we will be happy if you can refer us for genetic testing. We are doing genetic testing in this patient and trying to develop actually a database in Indian genetic test for this purpose. Of course, consider presence of autoimmune disorder. If autoimmune disorder, then your autoimmune acquired lipodystrophy. This is the approach. These are certain conditions with Wimig lipodystrophy. You can diagnose them clinically. Now, treatment of lipodystrophy. They are to be treated like usual diabetic patient, like lifestyle control, diet, exercise. Meteroleptin is a specific drug. Lipodystrophy fundamental defect is low leptin levels. And now a specific drug is available. Some very difficult patient, very high insulin resistant, does not respond to high dose of insulin, high triglyceride, pancreatitis. We say very difficult case, but there is specific therapy for them. That is the most important message general practice, because that can be lipodystrophy. A specific drug is available. I think this audience may not be interested in a lot about details of this drug, because shortage of time will not tell about detail of all these things. But a specific drug, leptin replacement, is available. A wonderful drug, wonderful effect. In fact, decreased hyperphagia, causes weight loss, markedly improve fasting to HbA1c by 2%, reduce triglyceride 1 week, reduce by 60%. Very difficult to reduce triglyceride. triglyceride. So this drug is very effective for lipodystrophy syndrome. And of course, comorbidity, you treat like your all diabetic patient with pioglitazone, metformin, ACE inhibitors, and all these things. Now, fourth important implication. Now, question is, can we use metrelaptine for anti-diabetics? Unfortunately, limited trials, but they were not found to be very effective in treatment type 2 diabetes. So don't use leptin in your diabetic patients. So there are several new drugs in pipeline. The importance of the point to know about lipodystrophy diagnosis, there's a different state of treatment for that. So the conclusions are lipodystrophies are relatively rare and heterogeneous good disorder which are genetic or acquired, cardinal features which are complete or partial loss of adipose tissue. Failure to store excess calorie in adipose tissue lead to ectopic fat deposition in liver, muscle, pancreas, blood vessel that lead to insulin-resistant diabetes, NASH, PCOD, and atherosclerotic vascular disease. This phenotype, particularly partial lipids, resemble thin fat diabetic phenotype, and underlying pathophysiology and genetic component is basically shared. It's the poor adipogenesis. Thin phenotype of diabetic lipodystrophy not only resemble phenotypically, they share genetic predisposition, functional genomic mechanism. These mechanisms convert on the process of adipogenesis. And lipodystrophy need to be diagnosed in clinical practice because there is specific and effective therapy are available for them like metrelaptine. Thank you very much for your patience hearing.
Thank you, sir. Wonderful presentation.
So, any questions?
So, Sandeep sir, as you told us that we always think about the belly and we don't think about the thin limbs.
Yes.
So we should make it mandatory to watch for it,
But actually, we are trying to develop clinical marker or clinical parameters. Still, it is in infancy because now next phase in molecular research or molecular investigation, we are trying to find out the biomarkers of this pathophysiology of sick fat. Once we have enlisted biomarkers, which are actually non-coding RNAs and some transcription factors, non-coding RNAs, once we enlisted them and verified them, then we look for anthropometry. Because thin limb and loss of peripheral fat is less peripheral fat is very important. We are doing at the moment on the DEXA. And DEXA, there is no cutoff value. Rather, we have comparison of the groups. But definitely, pathophysically, peripheral fat is very important in Indian phenotype. Because I have a couple of papers in some good impact factor journal like your biomolecule others, where we find your visceral fat does not show correlation with diabetes intermediate phenotypic traits, but peripheral fat shows associated with traits. So peripheral fat is very important pathophysiologically.
Wonderful, wonderful take, sir. Actually, this is the aspect which we are usually missing. We never look at it.
And so there is one more doubt actually. For our PEM patient like proteinuria malnutrition, we used to have this Harpendin's caliper to measure the arm size. Can you give some insight about how to measure the thigh size to assess about thin limbs?
Yeah, actually, we measure actually this skin fold thickness. Tricep skill fold thickness is the most appropriate clinical parameter. It is measured between your acromion and the olecranon and halfway between them, and the calipers are available for this purpose. We are generating data in our actually research project where we are doing actually genotyping, right from genotyping to transcription profiling, and we will try to figure out some cutoff value. So cutoff value should be not only epidemiologically defined in terms of disease, but also in terms of pathophysiology. So still it is in infancy at our level to find out what is right for Indian population, but this is going on.
Great, sir.
Sir, there is one more thing actually. What doctors are usually missing out is actually calculating the fat percent, and then they go only by the body weight. So how does it impact the treatment and all those things? You have a huge data on all these things.
Yeah, Bharat, actually, if you look for few physical signs, one is acanthosis nigricans and another two is acrocordons. And patient is not obese. Very simple criteria. He doesn't fulfill the BMI criteria of obese, but he has acanthosis nigricans, acrocordons. On investigation, he has hypertriglyceridemia. He is hypertensive and of course diabetic. Consider thin fat. And these are the patients who have primary defect of poor adipogenesis in peripheral fat. I have shown one study, not published in a very good journal because that was preliminary work. And these are the people who respond very well to your pioglitazone. And I am telling my clinical experience for last 15 to 20 years, my patients are controlled with only pioglitazone metformin in last 15, 16 years. So I start pioglitazone around 15, 16 years ago. They are doing very well because I corrected their underlying pathophysiologic defects. So it is very important. So insulin resistance features like your acrocodons, acanthosin nigricans, not high BMI, that means less than 30. They are hypertriglyceridemia, treat with pio because they have poor adipogenesis as their underlying pathophysiology.
Thank you, sir. Any more questions? Ashish sir, would you like to ask anything?
No, it was an excellent talk and everything was covered. And thanks a lot, Mathur sir, for the insight given on the topic. And thanks a lot, Bharat. You can move on to the next topic.
Thank you, sir. Thank you.
Thanks.
So over to you, Dr.
So
Sachin Mishra.
So thank you, our my eminent speaker and our chairpersons for this session. So moving forward for the next session, we have Dr. Prasant Shankar sir and Dr. Sanket Pense sir from Nagpur, who will just drive the session. The next session will be taken by the international speakers. So over to you, the next chairpersons.
Sandeep sir, can you stop sharing your slides?
Yeah, I am trying to do that. From where to do? I'm not able to do it. Stop share. Yeah, I can do it here.
Thank you, sir. Thank you.
So again, introducing once more, Dr. Prashant Shankar sir, who is from Pathanamthitta, and Dr. Sanket Pense sir, who is from Nagpur, will do the proceedings for the next session. Over to you, sir.
Thank you, Bharat, and thank you very much for giving me this opportunity to be a part of this wonderful conference. So the Asia Diabetes Forum Masterclass in Diabetes. So without much of delay, I will just introduce the speaker for today, who is none other than Dr. Puneet Kempegowda. He works as at the Wellcome Trust Clinical Research Fellow at the Institute of Metabolism Systems Research in University of Birmingham at the United Kingdom. He is a specialist registrar in diabetes, endocrinology, and general internal medicine, University of Birmingham NHS Foundation Trust, UK. He has got more than 87 research publications to his name. He has also won various awards, John Munro Medal for Excellence in Teaching awarded by the Royal College of Physicians, Edinburgh in 2021, Turner Warwick Lectureship awarded by the RCP London in 2020, and the QIC Diabetes highly commended award, Diabetes Education Programs for Healthcare Professionals 2020 for developing world-class diabetes education and training. And also the Quincentennial Lectureship awarded by the Royal College of Physicians, London in 2018. And he will be discussing on a very important topic, that is the role of improving care in patients with diabetes in diabetes care, and how the quality improvement programs can improve the overall quality of care in managing patients with diabetes. So over to Dr. Puneet.
Thank you, Dr. Prashant. Thank you for a kind introduction. Sometimes I feel like an imposter when you read out all those things. I still feel I'm just starting in my career. So let's start with first things first. I prefer not to be addressed by a sir. Just call me Puneet. That should be enough. Can I just check if I can share my screen? Yes, I can. That's perfect. Can I just confirm you can all see my screen?
Yes, it's perfect.
Thank you. Firstly, thank you to Dr. Bharat Sabu for the kind invitation to present here. Before I start my talk, I'd like to say something, if that's okay. I did my medical bachelor's in India, and when I was doing something like this, I can't remember anything of this kind of forum where early career endocrinologists and researchers coming together, talking about science, not from a drug perspective, but from an improvement perspective, but from a medical education perspective, from a scientific aspect. This is completely new, and this shows how much India has evolved in the last couple of decades. So kudos to Dr. Bharat Sabu for bringing together such an amazing forum together. Right. I know Dr. Shankar has mentioned my topic, but I've used slightly different topic heading here, and I'll talk through this. I'll have to close my video, so I won't be able to see if anybody's around, but if there's anything I'm missing, or if there's anybody who wants to raise any questions, please unmute yourself and ask. Otherwise, I will not be able to know. So I'll just keep going otherwise. Okay, so we'll talk about sustaining improvement in diabetic ketoacidosis management through quality improvement project. I've used one of the examples, and by the end of the topic, I'll explain how this is a generic model which can be applied to any situation in diabetes-related management. So here's a brief layout of my talk. I'll start by introducing about DK and QIP. I believe most of you here are experts, consultants, and trainees in diabetes. So I don't think I'll be dealing much with DK as such, but I'll discuss a little bit more about QIP, which is Quality Improvement Program. Then I'll discuss about how we came up with the hypothesis and how the QI was initiated. Then we'll talk about initial results and interventions, and then we'll talk about follow-up findings when we did not do any interventions. And then we'll talk about how quality improvement can go beyond just improvement and develop into science and scientific research, answering several critical questions in management of diabetic ketoacidosis. And lastly, I'll share a snippet of how we are sharing our learning with other colleagues in the UK and worldwide. Before I continue, can I just confirm my talk is for 20 minutes? Is that correct, or 25 minutes?
20 minutes.
20 minutes, that's perfect. That should be perfect. So moving on. So diabetic ketoacidosis, it's an extreme metabolic state of insulin deficiency. Now, until about 2 decades ago, DK was synonymous with type 1 diabetes, but that's changed. We've just got a publication coming out probably next week, which has shown that in the last 7 years, when we have looked at in our practice, about 25% of the people had type 2 diabetes who developed DK. So this is no more a synonymous factor to type 1 diabetes. Joint British Diabetes Society came up with guidelines for managing DK in 2010, which was further revised in 2013, and now in 2021, I think in June 2021. Now, this guidelines, to the best of my knowledge, is used over 100 countries in the world. So it's a very relied guidelines. Back in 2014, one of my colleagues did a study, looked at how confident early career doctors who are in the hospitals in managing DK, and more than 50% were not confident in managing DK. Now, this is an important thing, because patients coming in with DK are very, very ill, very sick, and they need immediate treatment. And if you treat them well, they have good prognosis, less hospital stay, less complications. If you end up making a mistake in diagnosing them or managing them properly, it can result in serious complications and even death. So this is a serious thing. As I said, I'm not going to discuss too much about DK, but I'll talk more about quality improvement. Now, quality improvement isn't a new topic. It's been there for centuries, and it's been there mostly in industries where they tend to check the quality of products they're producing using various sampling systems. The most common thing that was used in industries is something called as lot quality assurance sampling, where they take a batch, take one sample out of it and test if that's correct. And if that's fine, then the whole batch is fine. And that's how even the COVID vaccines are being prepared at the moment. There are other methods of sampling, cluster sampling, so on and so forth. And then comes the concept of audit. Audit is a snapshot. So you just go down one day and say, how are we managing all the people who are admitted with DK in our hospital today? And that's what you see. Quality improvement goes one step beyond that. You not only look at a snapshot, but you look at the whole trend over a period. In the simplest way I could describe this, an audit is more like a picture. You take a picture, and as you know, most of the people in picture are smiling, happy, and you can never figure out what's happening in the background. But A quality improvement project is almost like a movie. So you can see the whole scenario, what's happening, the ups and downs, emotions, so on and so forth. And that's pretty much a gist of quality improvement project. There are several ways to do quality improvement. But the most common system that's used in the UK and worldwide, and the one we have used, is the Plan, Do, Study, Act system. I'm going to talk a little bit more about this. Plan is you first come up with what you want to do. Then you do that. Then you study what was the impact of it. And depending on the impact, you act, whether you want to change your aims, methods, or measures, and then continue the cycle. There are several things that integrate with each other. Again, with the interest of time, I'm not going to discuss too much about this as theory, because I strongly believe you can sit at the bank of a river and read reams and reams of books about swimming. But if you don't put your foot in water, you don't know swimming. So let's jump straight into it. The other concept I want to talk about before we move on to applying all of this is outcome, primary driver, and secondary driver. Outcome is something that you want to change. Primary driver is something that directly influences the outcome. Secondary drivers are the ones which influence primary drivers. As you could see, primary driver is usually the biggest wheel, and it's difficult to move biggest wheel because of inertia and resistance and weight. Primary drivers are somewhere between outcomes and secondary drivers, still slightly big, sometimes challenging to move. However, you can easily move a secondary driver, and we'll talk about this. How do we apply this into clinical practice? So if you move secondary drivers, it moves primary drivers, and eventually you'll be able to move outcomes. So a typical journey of a patient admitted with DKA starts being super unwell. They come to the A&E, they get diagnosed with it, and they usually get managed in a critical setting or an acute medical setting till they come out of DKA. However, the journey doesn't end here. They get to be seen by the diabetes team, who then needs to see what caused the DKA, provide them with adequate support, be it psychological support or a specialist support, till they get well and they get discharged. When we started at QI, we focused on the first half of the journey, from the time they come into the hospital till they come out of DKA. And we did do this later on. I'll talk about that in a bit. But the hypothesis we had was, if we implement a quality improvement project on limited clinical criteria and provide frequent feedback, that will improve DKA management. So how did we do this? We had to first identify which are these limited criteria. So we started off with an audit to see what was the current practice then. We conducted this particular QI from April 2014 to September 2016. We adopted the Plan, Do, Study, Act model as we discussed. And this is how it works. So we did an audit and we found out there are five key markers of primary drivers which influence the outcome. And I'll talk about the outcome in a moment. That's fluids administered, fixed rate insulin infusion given, glucose measurements, ketone measurements, and specialist referral. These are in turn influenced by various clinical and non-clinical measures, such as how the people are treated in emergency medicine, acute medicine, how are they managed by diabetes team. Non-clinically in UK particular, we have impact on bed management, clinical governance, information technology. Again, these in turn are influenced by several other secondary drivers. As you could see, this goes on for a while, but we've identified this, and this was the first task for us to identify how the whole system works. Then we started our quality improvement project. Over 6 months, we started our QI. Each month, we focused on one aspect of DKA. We focused on bringing in automatic referrals so that any person who's admitted with DKA is automatically referred to the diabetes team and we can provide input. And at the same time, we focused on explaining the importance of fluid therapy to the clinical care people. The next month, we focused on insulin and hourly measurements of glucose and ketones. The following month, we focused on blood gases and how it's important to do that. The following month, we introduced a mnemonic to manage DKA. This was more like a advertisement, but it brought in the attention, it brought in the attention of various stakeholders, which was important for us to move things forward. And then when we had input from all the stakeholders, when we listened to all the frontline staff, we changed our DKA protocol. Now, before we started, we had a 20-page protocol which explained everything about DKA and what needs to be done. But the first thing I was told by the frontline staff, people who are in the emergency medicine department, acute medicine department, was, Punit, when I'm managing DKA, I don't want to know the theory. The patient is sick. Just tell me what to do. And that's exactly what we did. We changed the whole protocol into, and as I was mentioning, the outcome we were focusing was the duration of DKA. We changed the whole protocol into one-page guideline, one page which had everything you need to do for 24 hours after getting the patient. And this is the mnemonic we introduced. And this was well received. However, there was criticisms about this too. Two main criticism. One, saying that it was way too colorful, and that came from a person who was colorblind, and I can understand where they were coming from. Second, it was too wordy. Again, we don't have time to read this. So we'll talk about what we did in a moment. So what was the impact of our quality improvement project? As I was explaining, we focused on the 5 parameters. We managed to get 100% diabetes referral with our automatic referral system. We then measured how diverse was the management of DKA in terms of fluid, glucose, ketone measurements, and insulin prescription. Firstly, we focused on insulin prescription, and the scale, I'll explain this to you. Pre-intervention is before we started doing anything. Intervention was the 6 months when we intervened. And then we followed it for another 18 months after that to see what happened. And this is important. I'll explain you why. Now, y-axis 0% means they followed exactly what was said in the guidelines. If they deviated by minus 100%, that they were way out, and plus 100%, they were shooting over. I'll give you an example. A typical management of person with DKA is to give them fixed rate insulin infusion. And the rate at which it should be given is 0.1 unit per kg per hour. If a 70 kilo person comes in with a DKA, using the formula, they should get 7 units per hour of insulin infusion. If they get 7 units, if they were given 7 units, then that will be 0, as in they were exactly on the line that they were supposed to. If they get 14 units, which is double, then they went 100% over what was required. And if they got 3.5 units per hour, then they get less. So that time they were deviating by 100%. As you'd see, we started noticing a nice trend that we were not deviating much and people were starting to follow protocol. Same thing happened with fluids. Same thing happened with glucose. We weren't that much successful with ketone measurements, but we'll come to that later. But these were the primary drivers, and this influenced our outcome measures, which is the duration of DKA. Before we started, a median DKA duration was about 20 hours. And more importantly, look at the variation. It could be anywhere from 5 hours to 160 hours, a huge variation person to person. By the time we focused, we brought down to a nadir of 7 hours with a very tight interval. So proving that if we adapt quality improvement project and use guidelines, we will be able to provide not just uniform care, but the best possible care we can to the patients. So this was all done in our in university hospitals, Birmingham, where I am currently working. But as part of our training, we have to move to another trust, and that's what happened in 2017. I came back in 2018, and I wanted to look at what was happening with DKA, and particularly I was interested to see if the improvement sustained, and that's what we saw. This was the pre-intervention period. This was the intervention period, and then we saw the pattern over the time. As you saw, till I was there, things were good. Then it started drifting up, but it was still better than what it was pre-intervention time. Clearly, it showed that if you do a good quality improvement project, the improvement sustains over time. However, if there is no focus or regular feedback, it starts drifting up. And that's an important message that we got. Again, we listened to the junior doctors and frontline staff. We revamped the guidelines, and this is not the current guidelines, and our current guidelines is even better. But this was much less wordy, less colorful, focused on what needs to be done. And we even brought in the criteria of euglycemic ketoacidosis, because this was around 2018 time when SGLT2 inhibitors were more commonly used, and we were worried about euglycemic ketoacidosis. Right. At this point in time, let's take a small deviation from quality improvement project. We wanted to know if this quality improvement project can also answer scientific questions. We were very interested to see if DKA management varies between people of different age, sex, ethnicity, type of diabetes they had. And we could answer that question. By this time, we had over 786 consecutive DKA episodes. We looked at it, and as I was mentioning, we had about 25% who had type 2 diabetes who came in with DKA. We looked at what was the precipitating causes in type 1 and type 2. Again, in the interest of time, I'm not going to go in detail, but the most common reasons were intercurrent illness. If they were ill, they were prone to have decay, or if they did not follow recommended treatment for diabetes, they went into decay. We will also be able to see the variation in and the trend in the various causes of decay across time. And as we see, we started seeing newer things coming up: SGLT2 inhibitor induced, immune therapy induced, COVID, and other drug induced. So this is again informative that we need to be more mindful in terms of changing etiology over the years. Interestingly, we did not see much difference in the decay duration between type 1 and type 2. Corollary being, there's no need for us to treat patients with type 1 and type 2 diabetes differently if they get decay. You can use the same guidelines. However, remember the second half of the journey, they needed more time to recuperate in the hospital. So this is something you need to be mindful of. If you are admitting a person with type 2 diabetes with decay, they will need longer stay due to various reasons. We also looked at how age impacted. Younger age got out of the hospital quicker. There was not much of difference between male and female when it comes to decay management. Now, that clearly shows that if you do a good quality improvement project, you can answer a lot of scientific questions as well and get good publications out of it. Now, we've done all of this and we wanted to share these practices with the rest of our colleagues. So we contacted our neighboring hospitals in Birmingham. What we did was we created a simplified single data collection system using Google Form, and I'm going to show that in the next couple of slides, and we trained the junior doctors in those hospitals to collect the data. And the people who were collecting data were medical students in 7 hospitals. So basically it shows that you don't need trained professionals, you don't need postgraduate doctors, or you don't even need specialists to do this. Even a medical student can do it. We centralized the analysis, which reduced the time of data collection and intervention. We were able to give them feedback every month on how they were performing with the decay management. And we were sharing each other's best practices. In some things we were doing good, and other things another center was doing good. So these were the main centers which came into play. These are 3 main trusts in and around Birmingham and spanning across 6 hospitals. And this is a snapshot of one of the form that is used to collect the data. When a person gets admitted with decay, the medical student gets a ping, they open their mobile, open this form, and they fill the data. All data that's entered is pseudonymized. Pseudonymized means each person gets a code, and that code is assigned to that person. So when the data is collected at the central system, we don't know who this person is, but they have a code. And if we go back to the local center, we can figure out who this patient is. And this is important from an information governance point of view and from an ethics point of view, because you're having central system of data collection. We collected a ton of data. We had loads of data collected, and we are just scraping the top of the mountain to see what kind of information we're getting out of this. And the most important information we got was there was variations between hospitals in terms of how decay was managed, and again, in how long the patients were staying. This gave us a scope for us to explore how we can share practices and work with each other to improve practices. So basically what we have shown is uniform data collection is possible across multiple sites and hospitals without breaching information governance. We can share each other's practices to provide the best possible care for patients. But the most important thing for us was information is powerful, and letting people see the data was enough to change the behavior, both patients and doctors. Where are we going with this now? Last couple of slides. Firstly, we have now invited more hospitals to take part in the decay registry. We have expanded it to the national level in the UK, and we are also exploring in India. We've just had a collaboration set up with MS Ramaya Hospitals in Bangalore, which is my alma mater, where we have started the quality improvement project, not just on decay, but exact same system on HHS, hyperosmolar hyperglycemic state, showing that the same model is a snug fit. We just have to make a minor tweaks, but it can be adapted to any kind of diabetes related situation. You can name anything: retinopathy, nephropathy, neuropathy, it can fit into it. We are implementing feedback system to each of these hospitals and sharing best practices from other hospitals with each hospitals. Now, last slide. This is not a one person's job. This is not a one man's journey. This is not what I have achieved. This was all a good teamwork. initially we had a lot of junior doctors, and this is important because this was all delivered by very early career junior doctors. So if your junior doctors put mind together, you can achieve miracles, and that's what our team showed. And now we are having medical students coming into play. What this is doing is two things. They are understanding quality improvement projects right from the scratch so that they can adapt this as part of their clinical practice. Plus, it's increasing their interest in diabetes and endocrinology. I don't know how things are in India right now, but in the UK, we're struggling to recruit for people coming into diabetes and endocrinology for various reasons, but it's now changing, and we are getting more and more junior doctors joining our meeting. We had a host load of consultants who supported us in this initiative, and our National Association of British Clinical Diabetologists, JBDS, which is the Joint British Diabetes Society, and all our hospitals. With that said, I'd like to thank Asia Diabetes Forum for this opportunity for me to present my work here. And again, my special thanks to Bharat for this invitation and opportunity to share our experiences. Thank you.
So, thank you, Dr. Puneet, for that wonderful lecture. It's not a topic which is commonly discussed in the diabetes meetings, especially the quality improvement programs with respect to the intensive care and the management of DKA. So I think this is something which should be extrapolated to all areas of diabetes, whether it's the critical care or the outpatient setting, it's the diabetes education. All areas should be included in the quality improvement program. I'm not actually sure whether in India we have a specific quality improvement program only for diabetes. We definitely have quality improvement programs for hospitals as such. But disease-wise or department-wise, I'm not very sure we are having such facilities. So anyway, it was an eye-opening lecture. If there are any questions to be asked, I request the audience to type in their questions.
If I may start, I know this is not a common topic. As I said, this was not a common topic in even UK. The concept of quality improvement project only came in about 5 years ago, but it's still in its nascent period. However, we've shown that it has huge impacts. And I agree with you, it's not just the critical care. We have now expanded it to looking at our retinopathy screening, and we're looking at multiple other aspects, even outpatient settings. So it can be adapted. And I think this will not just improve the quality of care we provide to patients, but it will also help us understand what we are doing and how we can do things better. I appreciate it might be a very tough topic to ask questions on. As I said, it's very new. So if people wish to go back, think a bit, and then come back and ask more questions, you've got my contact details. So you're more than welcome to contact me. I'm easily contactable on Twitter or email. So just drop an email. I'm more than happy to share. And as I explained, we have just, I had this conversation. I was in India in September. Bharat knows, he invited me to come to his place as well. I went to my alma mater in Ramaya, explained this to my medical department, and they were very keen. And we've just started setting up the concepts there. And hopefully from January, we will be expanding the quality improvement projects there. The biggest advantage is you don't need to start anything from scratch. The whole model is there. If you're interested and if you have patients coming in with DKA, we're more than happy to share with you. And it does not involve any resources. You don't need to invest any money. All you have to invest is spend some time to collect the data, and that's pretty much. And within 6 months, you'll know how things are going and how you can improve.
Yeah. Thank you, Dr. Puneet, once again. I think we shall move on to the next lecture. I hand over the session to Dr. Sanket, who is ready to introduce our next speaker.
Super stuff. Thank you. Bye.
Thank you, Dr. Puneet, for an excellent talk and an eye-opening lecture. The next talk is by Dr. Irina Lesenko from Ukraine. She's a distinguished speaker, and she's a board member of IDF Europe Regional. She has done a PhD of pharmacy and is an associate professor at National Medical Academy. She has several research interests such as pharmaceutical care for people with diabetes, developing new technology and medications for treatment of chronic diabetic wounds, and in dentistry also. She has a lot of publications with more than 155 publications to her credit. more than 8 patents, and she has authored more than 6 books. She is also editor of several scientific journals, pharmaceutical journals, and diabetes journals. Very interestingly, she has been the director of the first international football championship for people with diabetes, which is called as the Dia Euro. It's a very interesting accolade, and there are several more accolades to Dr. Ariana. So I would like to invite Dr. Ariana to speak on the topic, which is art of communication, which is a key to successful diabetes management. Over to you, ma'am.
Thank you very much for kind words. It's a lot of information. Thank you, Dr. Bharat Sabu, for invitation for this great conference with great program. You remember I will speak about this. I was impressed, and I'm sure that our audience, our colleagues all over the world have enjoy and knowledge, and we have possibility to share our knowledge and emphasize on something which very important for the diabetes treatment. Thank you so much. I'm very happy to be here, and I'm very happy to be useful for my great country, India. I love India from my childhood, special dance, and I'm very happy. Thank you very much for your invitation. And if I can share my slides. It's not possible. Yeah. Sorry. Just a moment. And yeah, I can share. They won't. Sorry. Okay, did you hear? Did you see my slides? Yeah.
Yeah.
This. Okay.
And click on slideshow. Enlarge the slides.
I don't know what this.
Next to animations, there is slideshow.
Full screen model. Oh, that's. Thank you. Now we will speak about the communication skills, because this is very important. Now it's in past we more focus on knowledge about new research. It's very, very important. But without communication, without skill communicate with a patient, I'm not sure that it will be super successful. We must find some time for teach this subject. It's not easy. It's maybe less interesting for us as specialists, but we need this for our good treatment. Because according to Joint Commission, communication failure rate than any lack of technical skills or understanding was at the root of over 70% of serious adverse health outcome in hospital. In 60% of case patients walk away from doctor visit, not understand what they are supposed to do, instruction for medication and lifestyle changing. This is I confirm because I work in pharmacy in past, and this is problem also. It's also patient problem. People with diabetes internalize messages from many resources, the media, those around them, and healthcare provider. But doctor has a unique position or respect and power. But doctors are not born with excellent communication skills. Effective doctor-patient communication increase motivation, incentive, research and support, increase job satisfaction, both of them, and reinforce patient self-confidence. And this is increase outcomes and decrease cost of care. Patient-doctor communication is a complex interpersonal interaction that requires an understanding of each party of emotional states. Despite communication skill training in medical school, doctors continue to demonstrate poor patient-doctor communication skills. And now we can see this is barrier to good doctor-patient communication. This is interpersonal, linguistic, physical, culture, organization things. But also we have, I can focus on 6 factors of communication risk. This is culture, according to some culture beliefs. Social economic factors. Patients from low social economic status desire less information. Literacy factor. Patient with English as a second language may not be able to understand writing instruction. And gender factors. Male physicians are more likely to overestimate their communication skills. Sorry, guys. And personality behavior factor and time urgency factor. We know that we need time for explain. It's not easy. It's take a lot of time, a lot of energy, but we must do this. Important but overlooked communication lapses. Not verbal, eyes contact, facial expression, paralanguage, verbal, active listening, inappropriate choice of words, poor attitude, lack of respect and empathy, and content, poor quality and quantity of information provided. And today we must remember that today patients have recognized they are not passive recipients and are able to resist the power and expert authority that social grants doctor. They can implicitly and explicitly resist the monologue on information transfer from doctor by activity reconstructing expert information to assert their own perspective. Look, it was interesting questionnaire that show that patients say that it's very important for providers to communicate about chronic disease management, making personalized recommendation based on information that is specific to patient and their individual needs, helping patient understand that their currently and target health metric, sending medication refill and pick up reminders, and delivery online services. And if you look, most complaints about doctor are related to issue of communication, not clinical competence. And the general guidelines for following this patient, you can see, and we can see, this is link. If you want, I can send you. This is free link because this is cost money, but this is free link. You can learn this communication skills for healthcare professionals. Very interesting book, unfortunately big. And this is one part of diabetes. Show respect and compassion, practice unconditional positive regards, show concern and interest, practice objectivity, and remember that diabetes is a complex and challenging disease involving many factors and variables. Stigma that has historically been attached to a diagnosis of diabetes can contribute to stress and feeling of shame and judgment, and this is decreased understanding. Every member of healthcare team can serve people with diabetes more effectively through the respectful, inclusive, and person-centered approach, which now is very modern. And finally, this principle recognizes some words, phrases are potentially problematic. Use language free from a judgment or negative connotations, collaborative and judgment rather than authoritarian and controlling. Avoid language with attribute responsibility or blame to person for the development of their diabetes or its consequences. Avoid language that infers stereotypes, and use development and empathic language. Finally, few practical things which sometimes people forgot, doctor forgot. Introduce, it's simple, introduce yourself, but with not only with patient, but also with family member if they are together. Speak in layman terms, translate technical medical terms into simple terms. Don't say hypertension, use high blood pressure, for example. Checking your patient understood you. This is very important thing. This issue I check many times, and people afraid answer and show that something they don't understand. Don't ask, do you understand? Patient will respond yes, but can they actually explain into back to you? Ask, repeat what I say. Have the patient explain the treatment plan back to you. This case, it could be, maybe it will be short, but it could be more useful. Be adaptable, slow down, and adapt to situation. And sometimes doctor want to show this super knowledge, and of course, but it's not help for communication with patient. And just be honest. Patient want to trust. Don't beat around the bush. And this is, I want to emphasize the 4 critical times to provide and modify diabetes support service. And in this case, we must find special solution for communicating this period. And in diagnosis, annual, and when not meeting treatment targets, when complicating factors develop, and when transition in life and care occur. This is very important. You know, this is in diagnosis period. It's very, very difficult. And explain, because patient don't want to listen anything. It's not possible. It is very difficult, but anyway, it's possible. Fine, but we must know about this and recognize what we can do. A model of patient education or patient communication. Anyway, when we communicate with the patient, this is education process. I decide for you. Paternalistic model. Sometimes it's very work. But not with every person. You must understand who is affordable for this. And additional, I tell you my preference. This is a good model. I like this. I give you fact and help you to find your preference. But it's a long time. First of all, you must create this communication and explain and got feedback from patient. But anyway, it's possible, and this is, I think, it's a great model. But sometimes also used for paternalistic model work. Language philosophy. This is language is powerful, and words has the power to elevate or destroy. For people with diabetes, language has an impact on motivation, behavior, and outcome. And we know this for decades. A substantial amount of the language around diabetes has been focused on negative outcomes. But this is time for change this, and we work on this. And IDF Diabetes Federation published a language philosophy, because they believe that there is a responsibility to set example about appropriate language to other. If you want one small example, this is glycemic control. If you use glycemic control, bed control, blood glucose level, and so on. But are you sure that a patient understands you? In this case, first you must define what is good control. It's simple things. Doctor know this, but sometimes we not use this for people, for a patient. Language matter. This is English documents. Language that encourage positive interaction with people living with diabetes, and subsequently positive outcome. If we speak about in positive and empathy. This is a study about show about training that that student was interns to advance their communication skill. This is great, and they find the results that interns who had completed training tendence to allow patient more time to describe their feeling and concern about their illnesses. And this is the training doctor should include also not verbal paralinguistic element. it's not easy, because this is take also time and knowledge which we not know, and I'm not sure that many university uses. Communication training, also one of research. Our colleagues, communication skills training has been found to improve doctor-patient communication, and this is understandable. But however, the improved behaviors will lapse over time. This case is very important to practice new skills with regular feedback of on the equipped behavior. And last point about doctor-patient communication in the ear health area. We live in this area, and we use absolutely another methods for communication, device for communication. We must be also be ready for this. And if you look on this schema, it's extremely complicated. I will not explain, maybe I don't know. But anyway, this is a big part of our communication now. And this include many things like digital literacy, that safety communication is also very important, and so on. And delivery technology and new, as I say, new challenges for communications. Are we ready? Patient ready? And we must remember that telemedicine in diabetes now is extremely implemented, but telemedicine method for monitoring diabetes issue are yet to found that we have some barrier, a lack of acceptance, and doubt about the effectiveness, availability, potential technical problem, regulatory issue. And it's a lot of publication about that adult and elderly people lost this part of communication. We must remember also about them. And finally, I want to promote our IDF Congress, which start next week. I'm sure that it will be very interesting and big international Congress. Welcome. Register is open now. Thank you so much for your attention.
Thank you, Dr. Ariana, for an excellent talk. It was a very practical talk on a very important topic of communication skills. And you made certain recommendations, like simple ways like introducing yourself and asking whether the patient does it. These are very practical points and will definitely help anyone to enrich their clinical practice. You also mentioned regarding various models of communication like deliberative model and patternistic model. All these points are really useful. And I believe that communication with a diabetic patient, which is a lifelong chronic disorder, is as important as making the therapeutic choices for the patient. So if we communicate well with the patient, I think it will make the treatment very fulfilling for the patient, enriching for us, and will also help our practice to grow. So I would again like to congratulate you for this excellent talk. And if there are any questions, then they're welcome.
Dr. Sanket, yes, I would like to ask something. Irina, I would just like to discuss something, because this is again very close to my heart, the topic you are talking about, communication, because I have seen through my practice also that communication imparts a greater sense of treatment change as compared to the treatment, actually the pharmacological treatment change. So communication sometimes becomes a key, but to us in India, with higher patient burden, high patient load, it sometimes becomes problematic to talk in detail or to elaborate many points what you have mentioned. So can you suggest, being an expert in all those things, can you suggest us something so that we can improve our communication with our patient in a crisp manner?
Thank you very much, Dr. Bharat, for this question. It's very important. I say that this we have barrier a lot and a lot of risk for communication. From my side, this is we have no time for this, yeah, and this for explain, and we are very busy. This is really busy. And how we can of course, we can say, oh, I use time for this, but it's like this. If we can do, it's great, but sometimes we have not. From my side, it's very, because I, in this area, try to develop that pharmacist can be part, not can, he is part on this diabetes treatment. And this together, he is assistance for doctor, not prescription, not, we only support what the doctor prescribe and explain, they have time. This is his skills, and they must do this. They must consultation about medicine, how to use, which side effect, for example, could be. And this is if you if you find good communication with your pharmacist and they help you and they can better will be outcome together from this is I practical son. Of course I can say that please spend more time, but in really I'm not sure that you can do, because it's a lot of patient, a lot of problem in same times, not only but this is, it's very important together. And also nurse from you must involve her very much. And I remember we have one project which education project, and was one doctor and one nurse. I like doctor, super, she explained everything from my side. But when I make questionality who is best, it was nurse, because nurse used maybe simple words and understandable for patient. Thank you very much.
Now, just to take something more out of you in that context, because I knew that the things will come to this, that you answer this. In COVID times, you must have read in USA, a lot of psychological consultation was going on with chatbots. And the results were phenomenal. There are a lot of papers regarding that also, because a chatbot doesn't get angry. So patients were more friendly with the chatbots, yelling out at chatbots and telling them what is happening. So how do you see the future of technology in terms of AI in counseling? Because this is an aspect which future demands.
Yeah, this is absolutely interesting question. We don't know exactly what happens, but I think it's anyway this come, and we must be ready for this and try to improve this situation, which must work for this, for patient, for our knowledge. We can improve this communication. This is, to be honest, for young people, as I say, for young people, it could be easier because they have already involved in this process. They study in by technology, but all the elderly people and old, it's not ready for this, and they maybe we must more time for them and explain better how to can use this. And sometimes it's I'm sure it come, but at the same times we lost something. We must find balance. Now it's very difficult because it's COVID time, but anyway, we will, I hope it's over soon. But it's a difficult decision, but anyway, we can through the practice find better solution from my side.
Just for our audience, is IDF running any project on this language matters or something like that, or they are helping people who are trying to improve the language of themselves, their patients or the caregivers? Is there anything which is going on, or training module sort of?
To be honest, thank you very much for idea. I also, because I also part of educational committee in IDEA. Thank you very much for this idea. I will soon have IDEA board meeting. I propose to this because yes, we have like a policy, IDEA philosophy. This we have this document, but it's not training. This is very important. Thank you so much. I know this.
Do count us in, because we all are working, me, Sanket, Surjit, we are all working towards patient education. Even Sachin, who is sitting with us, Prashant is doing a lot of work. We people want to actually reach to the places where diabetes education per se is not there. So that will help us percolate proper knowledge regarding the disease, because the problem is not the disease itself. The problem is not having a proper knowledge regarding it. And they are actually fearful of diabetes while they should be friendly with it. If once they are friendly with diabetes, they can conquer it. By being fearful, they can't conquer. What Dr. Surjit, you want to say something, please?
Yeah, absolutely, Dr. Bharat, totally agree. Public education is absolutely essential, and I have this experience, and I am working on few of this public education project, particularly on diabetes and hypertension, on these diseases. And it will be very helpful if we collaborate and if we get some module related to this. And Dr. Irina, your input, and you have made the right point that you will discuss this in the IDF forum. And this is very important. Public education is absolutely essential.
Irina, actually, the purpose of this, Dr. Prashant himself is a good. He runs a club, and I know him personally. He runs a club. He is having a huge fan following because he is percolating knowledge. We all are doing. Ashwin is doing, and we all are here who are, I would say, in your league of communication. We work a lot on communication with our patients. Sanket is there. So we always feel, and Prashant will agree to it, that communication is, I think, the biggest burden as far as or hurdle in diabetes care in India. Dr. Prashant.
Yeah, definitely, Dr. Bharat. And again, there are situations where there are clinics where you have access to diabetes educator when the things becomes very easy. But most of the places we do not have enough diabetes educator or nurse educators, so the problem becomes very difficult. Even today, I had a new patient with a couple with diabetes coming in. Both of them were 70 plus. So in the first visit, I had seen actually almost 20 patients in the first 1.5 hours. And for this single patient, I had to spend another 45 minutes. So we have to spend a lot of time with the patient, especially like when you are initiating the patient on insulin, or when you are discussing the new complication which has developed in the patient. So it's very important. And as Dr. Bharat said, the education part is also very important. I've been frequently doing this. I have a Facebook page which has been running for the last 6 years, where I have been consistently giving updates to the patients by different ways. It could be your own videos, it could be diabetes related videos, which could be posted by anyone else. If Dr. Bharat is posting an educational video, I can share it to my patients, and the other way around also. So we should all work as a team, I think, to improve the communication.
I also want to remind you that we IDF have education school, IDF school. You know this, and sometimes it's free, and this is very. I think it's good point and good chance to improve knowledge, and also for educator, for endocrinologists and GP. Of course, I dreaming about pharmacists, but now I work with Pharmaceutical Association International, and we improve this knowledge pharmacists also.
I think IDF previously had a diabetes education program known as IDEAL. I had actually completed that program in 2014 or 15, if I remember. But right now, I think it is not there. Just IDEAL, IDEAL.
No, it was past. I don't know about this.
Yeah.
And now we have IDF school. It's very good development, and now we have a lot of projects for special region, for example, for Africa, which support by even government who implement to region, some region like Africa, or Asia. We also work on this for different languages. This is also, and then we have very good Ramadan school. I think you know this is like new, but it's very popular for about Ramadan times for people with diabetes. But I'm very happy listen you that what you need. This is very important for me. Listen and understand really problem from people. who hard work in
Actually,
this
Irina,
area.
just to interrupt, diabetes cannot be treated without a proper communication. This is
No.
the thing.
To be
Communication
honest,
is there.
nothing without communication cannot be.
And the thing is, we actually can only impart knowledge down the line. We can go to villages, the far to reach areas, people who have not been used to these kind of things, doctors who are treating those patients. So actually, the purpose of the morning's inauguration ceremony and awarding those people who are doing work in rural area was the same, so that other people can get motivated to do certain good work in their rural areas or peripheral areas or something like that. So actually, we can't treat diabetes unless we go down the line to the villages or the far to reach areas.
I think it's more critical important, because some people without, it's not only about India, we have also problem in Ukraine. In village have not accessible. In reality, it's not accessible care.
You are absolutely correct.
Dr. Daria, he's here. He runs a peripheral OPD also. So Dr. Daria, what you want to say?
Sir, you are absolutely correct, because if we are looking entirely in Indian context, so the people, more than 60% are living in a basically rural area. And in rural area, the lot of people, when we are going for the diabetes detection camps, and we found that people are unaware about that their sugars are more than 300, 400. And they're really working hard. It is not like that somebody is working hard and then he is not having a blood sugar, or he is not having any, even they are not having any symptoms. But in this case, if we are going for a detection camp, and this help absolutely fantastic for the control or prevention of this diabetes. In that case, we can even say their families also, that if somebody comes sugar higher in one family, then we should keep track also for all family members. So I think rural India is the main focus where we should do these detection camp for prevention of this diabetes.
I absolutely agree with you. This is a big problem, and I think I want to remind about our legend, Dr. Shaukat Sadikot, who very hard emphasize on this point, and that we have a lot of people without care in real life. In this case, I'm really miss him. It's my friend, that I was happy to have this person in my life.
Saurabh sir wants to say something. Dada, please.
Yes, Bharat, thank you. This was a very, very important topic. I and Sachin we both are traveling to Lucknow to just see an OPD basically. So Sachin was chairing the session. So I thought that you were always discussing about the communication skills. What I think so, there should be specified models which you should design to save time. Suppose you want to explain about diabetes, so you have to have some model structures. जैसे क्या है, what I use in Hindi, what I will tell to my patient in local regional language. देखिए, आपको डायबिटीज है, मतलब अगर आपके घर में 10 सिलेंडर हैं लेकिन माचिस नहीं है, तो आपके घर में खाना बनेगा? नहीं बनेगा. अगर किसी को पता चला आपके घर में खाना नहीं बन रहा है, तो उसने 10 सिलेंडर और भिजवा दिए. These type of some models in local regional language saves your time. Some types of sayings. So communication skill will increase if you just save time, then you will devote time. So while you are saving time, what I practice, I make certain models. Models are very much easily understood by people because they simulate the science behind the cause. So that becomes very easy to explain. So I will just try to educate all. I will try to share my views that if you make simple models at your clinics, at your OPDs, which to communicate with your people. So this was the thought. And with this, as Sachin has told, that if it is permission of all the humble chairpersons, we can move forward to the next session and hand over the mic to Dr. Hina Goswami.
Thank you, Irina. Thank you for enlightening us. And I'm looking forward to something from you regarding language matters. We are all looking forward to it. Thank you.
Thank you so much, guys. And thank you very much. I'm very happy to be with you.
Thank you, Dr. Sanket.
Thank you.
Thank you, sir. Over to you, Dr. Hina.
Good afternoon, sir. Good evening, sir. I'm from Jamnagar. I'm going to introduce the two chairperson for this session right now. Dr. Ashwin Mukundan from Kunnur, Kerala, consultant physician and diabetologist, MBBS, MD general physician, PG diploma in diabetes, renal management, advanced diabetes care from Royal College of Physician. And second is Dr. Surujit Kumar Patra, MBBS, MD, CCDB, diabetes, consultant diabetologist in Surujit Patra Clinic, Bhubaneswar, fellowship from Apollo Hospital, Kolkata, and Royal Liverpool Academy, UK. Certificate courses for diabetes from Fortis Hospital, New Delhi, and Royal College of Physician. Over to you, Dr. Ashwin.
Very good evening to all. Thank you, Dr. Hina, for the kind introduction. It's a privilege to be here chairing the sessions with legends in the field of diabetology and endocrinology. So I would, without wasting much time, I would like to introduce our first speaker, Dr. Krishna Sheshadri sir from Chennai. He's an American board certified, has a course in endocrinology, diabetes metabolism, and internal medicine. Chennai Diabetes and he runs the Chennai Diabetes and Endocrine Clinic. He has a clinical and research lead in Apollo Sugar Hospital, senior consultant in Apollo Hospitals, visiting professor endocrinology and medical education Sri Balaji Vidyapith, recipient of PN Shah Oration of the Endocrine Society and Sam GP Moses Oration of the RSSDI. Funded translational research, gut microbiota and inflammation, vitamin D and glucose transport, metabolic abnormalities in PCOS, thyroid nodules, and FOXO. He is the president of Endocrine Society Tamil Nadu, associated editor JDDC, editor-in-chief Thyroid Research in Practice, and member of Reconciliation Board, Medical Council of India UG Expert Group. And his main interests are in Chola history and Advaitic philosophy. Warm welcome to you, sir. It's a privilege to welcome you to this wonderful session. I would like to hand over the session to Dr. Krishna Sheshadri, sir.
We have a recording. Can you start playing that? And I will take. Yes, thank you. Namaste. My name is Dr. Krishna Sheshadri. Thank you for having me in this program. It is really a pleasure to be part of this wonderful program. I thank Dr. Bharat Sabu and his colleagues for this opportunity. I thought I will talk about something that is always so controversial and something that leaves us wondering, are we doing the right thing? How can the right care be cost effective? The inspiration for this is something that's been in me for many, many years. When I came back from my training and started as a young assistant professor, we had a patient who was admitted with a unstable angina in the ward. And my attending physician the next day morning said, let's do conservative care and send the patient home. Then I said, sir, don't you think we should have an angio? And he said, Krishna, your plane is not landed yet. How can this person afford an angio? So I took a history from this patient. I found out he was a truck driver and he was making this much amount of money a year. And then I went back to my teacher and said, look, if he goes as a cardiac cripple, he's going to lose his ability to earn for the rest of his life. His children who are going to school now will have to drop out and work. His family is willing to support his angiogram. And this is what the angiogram costs, and I think we should be able to get some amount of concession and actually do the angiogram. And we can get some, and they will be able to fund his revascularization. I was quite ostentatious, but my teacher, my attending was wonderful. Instead of giving me the look, he said, you know what, I never thought about it. That patient went back to his work. His children are studying, and they've now graduated into jobs and they're taking care of their parents. But if he had gone home, his wife would have had to work. His children would have had to drop out, and not doing the right thing would have hurt them. So with that in mind, let's look at this particular one. Here's a 45-year-old man who's diagnosed with type 2 diabetes. He's a clerk in a bank. His salary is 32,000 per month. I calculated the average salary of someone who works in a private bank. His wife supplements the income by taking tuitions. He has 2 children with aspirations and studying in a private school. He smokes 5 cigarettes a day and takes a multivitamin. He's worried about his diabetes. He wants good care, and that is why he chose you. At the same time, he's worried by costly treatments. At the urging of his wife, he has undergone initial testing. His A1C is 7.5, and EGFR that was calculated was 98. His LDL is 140. His urine albumin creatinine ratio is 32. His body mass index is 24. Blood pressure is 145/90. He has a normal foot exam, and a fundus photograph that was done was also normal. So let's talk about the most cost-effective way to practice medicine. The average income of a person in India, put just one number, is 270 rupees per day. So it's not the 10 and 20 rupees, right? Now let's look at the cost of drugs used in diabetes care. These are the supportive drugs for hypertension and lipids, and you will notice that the lowest the cost of a blood pressure medication can anywhere between 1.15 and 3 at the lowest, and 5.4 at 18 per day at the highest. And remember that when push comes to shove, there's not much difference between these two. Any of these drugs, you get the blood pressure down any way you want. These are the costs of the lowest and the highest doses of statins. I've given the equivalent values, 10 and 20 milligrams, and of course, aspirin is quite cheap. The data is, of course, not very supportive. These are the sugar medications. Sulfonylurea, and I'm not even talking about an older generation sulfonylurea, 2.4 to 15.5. Metformin, about 2 rupees per day. You can go up to 4.5. A gliptin between 9 and 40 rupees. A gliflozin at the lowest at 12 and highest at 28. Empagliflozin is only available as a trade drug, a trade name. Glitazone between 2 and 8 rupees, and about 15 units per day of glargine in a pen is 24 rupees. So let's keep this in mind. The first strategy is it's cost effective to prevent complications than treating them. The same principle that I talked about in the event that actually changed my life. This is a very interesting article that is published in the Indian Journal of Public Health from Manipal that talks about the heart failure related costs. The index hospitalization is given here, right? Looking at people. What is the average cost per patient? What happens subsequently? Readmissions, cost of medications, caregiver cost, total follow-up cost. A single hospitalization in the next 2 years leads to about 1.33 lakhs plus or minus about 36,000. This is in someone who does not have diabetes. If someone has diabetes, the cost of this doubles. So clearly, complications are costly. It looks like preventing those complications is cheaper. Let's look at the NNT for heart failure or CHD. If 19 patients are treated with an SGLT2 inhibitor for 2 years, 1 event of heart failure or CHD is prevented. So treating 19 patients for 2 years using the lowest APA or the highest is about 1,70,000. What is the highest? 2,50,000. That's less than the cost of hospitalization for 1 patient. The cost of dapagliflozin for 1 patient at the lowest rate for 10 years is 44,000. The cost of heart treatment in diabetes for 2 years after 1 hospitalization is 2.6 lakhs, right? Remember that bringing down glycemia reduces heart failure. Remember that a lot of people forget that. And of course, using dapagliflozin also reduces heart failure. Controlling your blood pressure also reduces it to somewhat, right? So clearly, it's cost effective to prevent complications and to treat. The second strategy is something that I think we need to look at a lot more, and that is first year yields are higher. The earlier you treat, the better it is, right? Think of it as investing, right? What you put in your first year will help you in the 20th year. So if you look at this, this is from this is a slide that I modified from the UKPDS. That's looking at a 1% reduction in A1C, not getting an A1C down to target, but just a 1% reduction in A1C. If you do early in the first year versus after that, see what's happening. The mortality reduction in 20 years, if it is earlier, is about 23%. On the other hand, if you do it later, it's only about 12%. The incidence of myocardial infarction in early versus late control, again, is very, very high. So 25 years in terms of myocardial infarction. So clearly, getting that A1C down in the first year and throwing the book and sort of telling the patient, look, you know what, I agree, let's go on diet for a while. I know you can do it, right? The way we need to say is, look, I'm happy for you to work on the diet, please do it. But till everything is right, let's get these medications on board. And you want to get that A1C down. So what are the first year costs to achieve a target A1C? Not a 1%, but a target. If somebody's got an A1C of 7, you want to bring it down to 6.5. It's about 750 to 1600, lowest to highest. Adding a DPP-4 inhibitor makes it 4,200 to 14,000. A metformin plus DPP-4 plus SU is still 5,000 to 20,000, depending on how much, what brand you're doing. And then adding an insulin on top of this gives you 13,000. Remember that 1% reduction from baseline reduces outcomes by 25% by year 20. So we're not even talking targets, we're talking about 1%. The way I look at it is, one, when it prevents complications, is better than treating them. The first year is certainly the highest yield year. But what is even more important is doing the small things makes all the difference. This is like investing. If you start putting small investments, you may think you're putting a small amount of money, but at some point of time, it compounds. And compounding is what the big investors look for, right? Not retailers, but investors. And we are investors. This is the new CVD equation, right? A 0.9% reduction in A1C, 2.5 CVD events prevented, 1 millimole, 37 milligrams of LDL down, 8% CVD is prevented. Similarly, 4 millimeters of lowering of blood pressure, starting pioglitazone or empagliflozin, all of these reduce CVD events, and they're very good at it. But I want to go to an old study. Nothing great about it, small numbers, lots of dropouts over the years, but we have data from 1993 to 2014. All the study did was randomize people to some conventional versus intensive therapy. They wanted to get the A1C down, get the total cholesterol down. Remember, it was an earlier study. Wanted to get the glycerides down, the diastolic blood pressure down, and aspirin therapy in a select group of patients. This was 15 years later that was published, and of course is a 21-year data. What you did, the small thing that you did for 7 years, 7.8 years of intervention, at 21 years gave you an additional 7.9 years. Small study, big heart, but big results. That tells you that the little things that we do, doesn't matter what is the money involved, compounds. So make that effort. This tenor showing that the all-cause mortality is better, the CVD mortality is better, retinopathy progression comes down, autonomic neuropathy progression comes down, macroalbuminuria comes down. So how much does this cost? At each year, adding another 2 antihypertensives is usually $1,000. A statin, 1,000 to 6,500, depending on the brand you use. And we're looking at moderate intensity statin for 30% reduction. And aspirin is another 60 rupees a year. The total cost per year is, you can keep it as low as you want, choosing generics, 1,543. Or if you're a brand person, you can escalate the cost, right? So first, it's cost effective to prevent complications. Invest in the first year. Adding and taking care of the hypertension and the lipids and all of these is not very costly. The fourth thing is to use, I would suggest use an EMR, but definitely risk manage. This is the Barry 2D trial. And what is interesting is that each risk factor compounds the risk of death. And the more you reduce it and work on each of these, there is benefit. So in this particular patient, remember he was taking cigarettes per day. If you're smoking half pack per day, a 10 pack costs, I think, 100 rupees or more at the lowest. Filter cigarettes cost more. If you add the antihypertensive, if you add the statin, if you do the aspirin, the total cost is 1543 to 1286. If the person smoking 10 cigarettes per day, he's spending 36,500 rupees per day. Cutting it off almost takes care of all your other costs. So this is a very interesting study that was published by Van et al. In Diabetes Care. This is looking at Hong Kong. And if you risk stratify patients and you do that, something very interesting. One, it reduces complications, which is nice. What it did also is to reduce all-cause mortality, frequency of hospitalizations, attendances in emergency room, and other things. Which means it not only saved lives, it saved money for the system and the people. That's really what it means. So, one, it's cost effective to prevent complications. Invest in the first year. Small investments make a big amount, as a steno showed. And you do the right thing, it saves money. Let me add something to it, which is my pet peeve, and that's cutting throats. Well, most of us have patients on multivitamins. We use it as a substitute for not talking to them. They're on vitamin E, which can harm. Many of them take antioxidants, which don't work as a pill. And many of them love supplements, and we engage them with protein powders. That all costs money. And none of these help patients. All you have to do is to cut these off, and you actually save money and put it on to what works. Evidence works. The simplest way to do that is to educate, empower, and involve patients. And to sort of tell you that evidence-based care is actually cost-effective care. So this is, sorry about the lack of the reference, but this is something that looks at what is cost-effective. Screening for fundus is cost-effective. Self-management is cost-effective. Glucose measurement among insulin users is cost-effective. Glycemic control among newly diagnosed type 2 diabetes, remember what we talked about the first year, is cost-effective. ACE-ARB for intensive hypertension control is cost-effective. Multi-component interventions are cost-effective. Many of them are cost-saving. Smoking cessation is also cost-effective. Integrated patient-centered care is cost-effective. Foot care is cost-effective. Statin therapy is cost-effective, right? Of course, even bariatric surgery can be somewhat cost-effective. So what it means is for which there is evidence, and if you do it, it's cost-effective. In India, we are wonderful because we don't have to depend on third-party payments for most of our patients. We just have to be smart, be ethical, and be sensitive and care for and be responsive to the patients. And the cost of care is actually going to be quite low. So here's the patient. We started on DPP-4 inhibitor plus metformin, a statin, and ARB. Was educated on lifestyle. He quit smoking. The multivitamin was stopped. The annual cost of evidence-based care: 1 drug, 2 drugs, 3 drugs plus insulin, right? 2 antihypertensives, your statin and aspirin. Total cost can be anywhere between 1,543 to 12,866. Add in about 1,000 for 3 A1Cs, a lipid profile at 400, urine albumin creatinine ratio 375, a fundus photograph at the maximum 350. A creatinine is 100, a foot exam free to 250. A doctor visit for 3 or 4 times depending on where you practice, usually not more than 1,000 or 2,000 rupees. And education is, many of us we do it free, but can be a cost center. And if you want to, you can keep it at the lower limit of normal, right? You don't have to use expensive brands. as long as your bioequivalents are fine and you're comfortable. It's true that many of them do not have the standard that you want, but you can get comfortable with a few generics that you're sure that that there is a standard. Back to this patient, at the end of 1 year, the patient is on DP4MI plus MF plus statin, ARB, A1C 6.5, LDL is less than 100, blood pressure is 130/80. His first year's cost of care was 8,670. And because you spent some time on talking to him about reducing his stopping his smoking, which he did, and his wife made sure he did, he saved 18,000 rupees, which went into a recurrent deposit that actually earned him 6% interest and then compounded. Another 700 was shaved off because we stopped all the supplements. So his total cost of care was around 8,000. He realized that doing the right thing need not necessarily be expensive. So let me summarize. The most cost-effective way to practice medicine is to do the most appropriate thing first. And always. All it takes is for us to think through it and work with it. Instead of giving up and thinking that, we can't help this patient, we know that we can help every patient who comes to our doors. We're no longer that poor country of indigent, famine-ridden India. We are a new India where our people are willing to work hard, they're willing to push up, they're willing to grow, they don't want doles. All they want is a ear and an understanding physician who helps them take care of their illness and guide them to wellness. I thought I will do this a little different. Most of the data here are data that I've gathered out from various sources. You are free to use them with the appropriate acknowledgement. Thank you for your patience, and again, thank you for allowing me to speak on a topic that are of my own choosing. I thought it was fun to talk on something that's very different than the usual stuff. Thank you. I'm happy to take.
Ovation, sir. Wonderful, wonderful. The way it has been dealt is phenomenal. I hope whosoever is listening to this will change the way they write from tomorrow onwards. Thank you. So the house is open for questions, please. Krishna, sir, I just want to ask you one simple question that many times I've heard this thing that I found this appropriate, but my patient is not accepting it. How to overcome this hurdle?
Right. I think the first important thing is to move from decision to shared responsibility. A lot of times, it's like taking care of children. As they get older, what do? You share. They become part of the decision making. Our big problem is we think that those decisions have to be made in the 10 minutes we spend with them or less. Many times, you can allow them to go think about it and come back. A lot of times, reflection allows people to make the right decision. Many times, for example, let us say I have to use a GLP-1R, right? I lay it out and tell them, look, this is an important medication for you. Given your situation, this is good for you. But if you think, but why don't you do something? You have two options. One is go sit outside with your family, think about it, and come back. But you know what? It's not such an urgency. We can always take this up in a few days. Or let's say the patient needs time. You can say, look, okay, I'm fine with this. Go back. Let's put you on this whatever you want right now. But 1 month later, let us revisit it. When a decision is made, it does not mean it is the end of the discussion. You want to revisit it. I don't believe in convincing patients. I don't believe in making patients the same. I am there to provide the information. They are adults. They have to make the decision. But I will not give up on them I will not judge them and I will not give up on them. I think that's all it is. You just have to revisit it again and again. And at some point of time, a patient says, no, this is what I want. Then you respect it and go with it. But you don't abandon them also.
And
sir, if I can intervene.
Yeah, please.
Okay, sir. Wonderful talk, sir. Krishna sir, it was an eye-opener for many of us, especially the topic. When I saw the topic in the list, I was wondering what you're going to talk about. Like after a point of time, I was like, you're talking about generics. I was thinking actually, but after listening to your talk, I was thinking, yes, treating, like my guru, Dr. V. Mohan sir, always used to say, treating diabetes is not costly, not treating diabetes is costly. So it goes again well along with your talk, sir. Just to have a word, like what's your opinion regarding, like we write some brands, good brands, patient will go for generic alternatives, but the effect doesn't remain the same. That's where a cost driven market like India, where we fail, we always used to, we have to check the the drug taken by the patient is the same or not. Many times the insulin is not effective as the brand we are writing. So what's your take on that, sir?
So I never stop patients from exploring generics, right? I'm going to take care of them for the rest of their life, not just for the 1 month. So the patient tells me, look, I've gone to the Prime Minister's shop and I'm getting this discount. Can I do that? I said, sure. But let come back in a month and then, let's see whether this is working as well. If it's working as well, I know there is one more brand that is working well and I will notch it there. If it's not working, many other times the patients will come and tell you, please change me back to the older medication. I'm comfortable with that. Right? See, at the risk of sounding, bad, let me tell you, many of us have a daddy complex. Right? We think we treat our patients as 8-year-olds. We should treat them as 16-year-olds.
Okay.
Okay, you fall and you find out.
That's great way of answering that, sir. Thanks a lot. It was really fun listening to you. I guess if there are any more questions for you, like we have 5 more minutes left with
Irena
you.
has a question, please. Irena, ma'am.
Yeah. Thank you so much, Dr. Krishna. It's extremely interesting how you propose to us. It is not like it's like through the individual to general picture. This is about economic aspect of diabetes. Is also a part of my, as pharmacist, a part of my interest in. And this is I only a little bit lost that when you call account that it's very important. Blood pressure, because without blood pressure, check blood, without self-management control, we cannot take targets. This is without discussion. And I also make some research how cost glucometer and test strips for example, for 1 year. And in this case, it's not extremely expensive. And as you say, I like this change words that we now use, like you say, investment in future. This is, we must explain patient, and we go back to our communication with patient. This is very important to explain, and how it's important for future. And but I really appreciate that you pay attention for first year treatment. This is very, very difficult period for patient and for doctor also, how to explain. But this is very important. I think we must more pay attention on this this point. Thank you so much for advice for us, and I'm hope that I will contact you. Thank you.
Absolutely. Thank you so much. It was my pleasure.
Thank you, Krishna sir. If there are no more questions, I would like to hand over the session to my colleague, Dr. Surajit Patra, who's waiting to chair the second session. Sabu sir, can I hand over the session?
You be there. You just hand over the introduction to Surjit.
Yeah, I'll be here. I'll be right here.
Dr. Surjit, please go and introduce Dr. Vinod Mittal, sir.
Okay. Thank you, Dr. Ashwin. And at the outset, I would like to thank Dr. Bharat Sabu and the whole team of Asia Diabetes Forum to involve us in this international academic feast. And it is going on very nicely, and a lot of very important discussions Okay, so and thank you, Dr. Krishna sir, for your nice and insightful presentation. And absolutely, shared decision making and the communication; those are the key words I would utilize in practice, and all our colleagues also. So our next speaker is Dr. Binod Mittal sir. So Dr. Binod Mittal sir is a senior consultant diabetologist and head of Center for Diabetes and Metabolic Diseases, Delhi Heart and Lung Institute. He is director of Delhi Diabetes Care Center and past chairman of RSSDI Delhi chapter. He is MD and fellow of American College of Physicians. Received many honors and awards, and we saw him presenting many as speaker in various conferences and papers, and he is a regular invited speaker in many national and international conferences. And he is a principal investigator in several international research projects and clinical trials. He has several publications in peer-reviewed journals and chapters in various books. So I would like to welcome Dr. Binod Mittal sir for your presentation. Over to you, sir.
Yeah, thank you, Dr. Patra, and convey my thanks to my dear, younger brother and friend, Dr. Bharat Sabu, for inviting me to share my views on precision medicine, which is appears to be new today, but it would become a routine tomorrow in special reference to management of diabetes. So just let me share my screen. Is my screen visible?
Yes, sir. Perfectly well.
Yeah.
Yes,
Is
sir.
it okay?
Yes, sir.
Okay. So I welcome all my esteemed, friends and delegates, and I would be sharing my knowledge on basically utility of precision medicine in diabetes management today and what we expect tomorrow. There's no conflict of interest, and basically, concept of precision medicine is nothing new. Like it's like appears new, but we are already using this in monogenic diabetes and say MODI, etc. And like basically like pharmacogenomics perspective and the role of genetic factors is helpful in calculating genetic risk score, and that is going to be very, very helpful in diagnosis of diabetes, and then even prevention of diabetes and prediction of future complications and precise management of diabetes. And then how to apply this risk score in prevention and other therapeutic aspect. And we can also predict who are the susceptible individuals for certain complications. And we can also reclassify type 2. Although in type 2, the picture is dismal today, like we don't have much value of precision medicine. But yes, in times to come, this would definitely help even type 2 diabetic patients. So one size fit all is basically, approach has been used like in the past in diabetes, but now today we are individualizing treatment. And it would be more personalized in times to come with the role of epigenetics, genomics, metabolomics, proteomics, and transcriptomics. So precision diabetes is now, the future of, not only diabetes in internal medicine and other so many things, a medical field we have. So it's already there. We are already applying it in monogenic form. I told you in MODI, even neonatal diabetes. And there's certain patients who are having actually MODI. We say MODI is not common because we are not investigating the patients. We are not taking history, proper clinical features and, pedigree charting, etc. So any thin patient, a child or, adolescent who comes basically between 15 to 20 years is always taken as type 1 diabetic, unless until it is proven otherwise, and patient is put on type 1 insulin. But such patients, some of them are having MODI, and we know in MODI sulfonylureas are very good. So in certain patients we can even stop insulin and they are put on sulfonylureas and they have a very good control. So rationale is basically the top line. It is very important that the right treatment for the right patient at the right time. This is what is we are going to, our duty and moral responsibility for the patient. And I'm sure in times to come, this would be fitting almost 100%. So the concept is quite old of precision medicine, and definitely, now assessment of genetic, metabolic state and disease categories, science-guided preventive and treatment decisions tailored to, the particular pathological, conditions, say for example, diabetes. And now, along with this, even digital devices and technologies are also there, and which can also help in managing diabetes better. So discrete treatment plan can be, already planned in the best way possible. And this is not only, for developmental and metabolic context, but for genomic variation and chromatin signals, expressed transcripts. So these are a number of things, which we have to understand. And it is going to become a very routine in times to come. In 2020, ADA and EASD has come out with, a joint consensus report. It's a full article, almost 20 pages article. I think we all should go through it. And there are very clear-cut things, which in this article, it has been mentioned that convergence of advances in medical science and technology has increased knowledge about diabetes, how it presents, its variable prevalence, how the best practice in treatment varies between the populations, and also focus on the development of tools for the application of precision medicine on areas of precision diagnosis and therapeutics. Yes, there are some key, barriers today, and some hurdles to implement all this, and but ultimately, we're going to succeed because we need more training and more clear-cut guidelines, for the physicians to follow. Then say monogenic, I told you, but the only thing is we want to know. There's so many things which are unknown today. And we want to clarify and clear all the potential in toto, of this precision medicine. We have 12 classes of medications for diabetes, but what we achieve? We achieve only, say, 30% of patients less than 7% A1C world over, and India it is around 25 or 26%. And at the same time, we are not able to prevent future complications. And also, there's no cure and remission. So basically, the important point is today that we are failing in preventing, as well as we are failing to some extent in preventing the complication of diabetes. And on the other hand, in all the patients also, we cannot write treatment as per the recommendations or guidelines, because the cost comes into the picture, side effects also, patient preference also comes into the picture. So sometimes, basic pathophysiological processes or mechanisms are missed, and we have to kind of across the table, 1:1 patient and doctor, a prescription kind of a thing has to be mentioned ultimately. So there, basically we are compromising on certain things. Say, suppose I want to write SGLT2 or GLP-1 or something, but patient is not agreeing. So, there is some compromisation on the treatment. So basically, Precision Medicine Diabetes Initiative was already, started by ADA, ESD in 2018. And then US NIDDK and Juvenile Diabetes Research Foundation also joined in. And there's so many activities going on by this Precision Medicine Diabetes Initiative, phase 1, 2, 3, and 4. And it's an ongoing process, So plan is already very concrete and it's there. And let's see how successful we are. There are a number of components of precision medicine, and these are precision diagnosis, precision therapeutics, precision prevention, then treatment, prognosis, and monitoring. So there's 6 arms of precision medicine. It is not only treatment, it is not only diagnosis, even prevention, prognosis, monitoring. So many things are there, which are with precision medicine. Now, in precision diagnostics, suppose we take barriers to implementation, the type 1 also, there's so many barriers today. And, like antibody tests are not 100% positive. There's so many things, which we still, are lacking. So maybe in times to come, we would have better therapeutic areas and diagnostic facilities for type 1 also. And similarly for type 1, this precision medicine would play a great role. So basically, precision prevention, therapeutics, precision treatment, all these are going to be a part of, a personalized care or, basically individualized treatment. Then prognosis of any treatment, suppose patient has some complication today, and how would be the prognosis of retinopathy, CVA or CAD, etc. That also the precision medicine, the genetic, genotype, genome, studies would definitely tell us, and we would be able to prevent future, progression of the disease. Then there are a number of other areas where precision medicine, it lessens the treatment burden overall. When I told you, say insulin, patients with MODY who are unnecessarily put on insulin are, then later on, once we diagnose started on sulfonylurea, they respond very well. So basically, we're going to have a more specific diagnosis, specific treatment coupled with the subcategory, the genotype subtype, which is going to tell us the future complication, will definitely help in preventing the future complications. Then today, misdiagnosis like type 1, type 2, because there is, epidemic of obesity also. So type 2 is also occurring in younger age. So there is, some overlap between type 1 and type 2, LADA, MODY. So sometimes there is a misdiagnosis that would be clear right from day one with the help of precision medicine. Then the complications, which we are not able to predict today. Once we have a genotype, we would know like this patient will have these kind of complications, more of retinopathy, more of CAD, or more of CVA. So these are, important things which we are already, doing. We are already having a personalized treatment, but genotype, studies are not there today as common as they should be. So a part of, an extension to precision medicine is personalized care. Both are almost the same, but in personalized care, we take into consideration the patient's social aspect also and patient's preferences. So a shared decision is taken. That is what is personalized medicine. Now, global initiatives, as I told you, is already there. So many countries are already having, basically initiative on this precision medicine. And genome-wide association studies are also going on, which are going to help ultimately, reducing the diabetes burden worldwide, and maybe prevention of diabetes, and at least prevention of complications of diabetes. Then pharmacogenomics detection of certain biomarkers is also, is a long-term, objective. And there, once we detect these biomarkers, we can always say that maybe, new drug selection. See, now today, along with lifestyle modification, we straight away start with metformin, but there might be some people, patients who are non-responder to metformin. How would we know? Unless until we continue for a couple of months and then later on we come to know. So similarly, even metformin intolerance. So in that case, we would know right from the day one that basically like this patient will respond to this particular medication. Then these are different genes, which already have been associated with these kind of medications. So that also would be known from day one. Then definitely there would be, genotype 1 and genotype 2, we can see here, two different patients. One has more expression in the adipose tissue, and there is a better response to anti-diabetic medication like PPAR gamma. Similarly, genotype, there may be, better response to sulfonylurea. So we would know from day one or initial stages that, what agent we should start in a particular patient. So overall clinical application, let's see that, and that is, one is type 2 diabetes, which is, almost more than 95% of total number of patients have. And but it is in the infancy stage. We really do not have much, application of precision medicine in polygenic type, type 2 diabetes. But definitely in future, the development of, the medications, response to treatment, complications also would be known. But what we have today is basically in monogenic diabetes, we're already using it, and especially MODY and neonatal diabetes. So let's take one by one in short, in brief. So in neonatal, basically there is no antibodies, and it is occurring in first 6 months of life. So there should be a blanket genotype, basically testing should be done in less than 6 months of diabetic patients. And once it is done, we would know which type of neonatal diabetes it is, transient or permanent. And once we know transient diabetes always respond to sulfonylureas, because otherwise all these children, infants, less than 6 months would be unnecessarily receiving insulin. So basically, one is selection of treatment, but other is also that, because these type of genotype and genes K and KC and J11, they are more of heart defects and gut and gallbladder atresia. Then basically, again, a resolution of transient diabetes, once we have actual genotype, testing done, we will know like whether resolution will happen or how much time it will take. And then early, intervention of comorbid conditions also would be known to us. Then in MODI, yes, definitely clinical history is very important. BMI, like it appears like patients would appear like, type 1. There won't be any signs of insulin resistance, but it is a, autosomal dominant, and 3 generations, generally there is a history of diabetes. So these are important things, and these patients don't respond to insulin well, and they're unnecessarily put on insulin. And we have so many, almost 13 to 14 types of MODI today. But these are common ones, HNF1A alpha, HNF4 alpha, and GCK, glucose kinase, a type of MODI, and NHF1 beta. But the important thing is that, like in GSK type, there's only mildly raised fasting glucose levels. We really don't need to do any treatment. So once we know, we may not be doing any treatment. Then, at HNF1 alpha, basically they have a progressive beta cell dysfunction and there's a glycosuria. So these are, kind of things which we would know from day one, and then we can plan treatment. And, these 1 alpha and 4 alpha will respond better with sulfonylureas. GCK, type, no treatment. And HNF1 beta will be requiring insulin. So that's how, once we know, we do genotype along with history, it is important. Like this is only to chart, for a patient where we can see, that basically the patient and, the mother and the grandmother, all the mother's sisters also, and the grandmother. So it's 3 generational transmission of disease. Now in monogenic, this we have already discussed. So basically, if we see in monogenic, there is a clear-cut role even we are using today. And in type 2, definitely in times to come, we'll have more information and more help to treat these patients. And overall, what I want to convey here, that, basically once we have BMI, sex, age, and genetic studies and other physiological markers like C-peptide, we would know like this category of patient will respond to drug A or B, or drug B. So that this kind of thing is going to be there in future for type 2 diabetic patients. Now, genetic testing, how we advise in children, like one is all infants less than 6 months, if they're found to be diabetic, then suspected type 1, C-peptide present in type 1, generally it should be absent or low normal, anti-GAD, say zinc transporter 8 antibody negative. So there also we should go for genetic testing. And then suspected early onset type 2 lean with no insulin resistance, no signs of insulin resistance, again, we need to do a genotype of this patient. Then a reclassification. Recently, I think 1 year or 2 years back, there was a study, from, say by, from Lund University, say Sweden, and there was a clustering of, all type of diabetic patients, and it was basically 6 clusters of diabetic patients were categorized. And it was first was severe autoimmune, which was basically type 1, anti-GAD antibody positive. Cluster 2 was severe insulin deficient diabetes. And this is something like, GAD negative, but, it is like basically indeterminate, but it is type 1, but antibodies absent. Then severe insulin resistant diabetes, cluster 3, then mild obesity related diabetes and mild age related. So these are a couple of things, which were found in that study, and this will definitely help us in managing patients better. Even diabetes complications can be prevented in, say, for example, diabetic kidney disease. Some mutations and variants of APOL1 gene and UMOD genes have been reported. And once we identify these, we can always, take steps to prevent future progression of diabetic kidney disease or development of diabetic kidney disease. Similar for diabetic retinopathy and neuropathy, there are different genes which can be helpful. So just 2 minutes more I would take. So basically, precision medicine overall advantages are that we are becoming more scientific. We are going to have very, very specific diagnosis, very clear-cut diagnosis. Then definitely there would be a better control of diabetes overall, and ultimately we're going to reduce the complications of diabetes and a huge burden, economical as well as social burden on the part of not only the patient, family, or nation, maybe worldwide. So that is very important. And then obviously we would have better personalized care, better quality of life, and then say some categories, as I told you, who are unnecessarily put on insulin, maybe oral agents appear good in those category of people. So basically, that basically precision medicine is going to allow doctors to select treatment, to predict future complications and take steps to prevent future complications, to kind of even new drug selection and development also would be there, reclassification of type 2 diabetic patients, and a targeted preventive treatment. So overall, this is my last slide. The future of precision medicine appears to be very bright. What appears new today would become a routine tomorrow. It is going to avoid unnecessarily insulin treatment, unnecessarily wrong diagnosis, a specific diagnosis, a specific treatment. Monogenic, we're already using it. Maybe in times to come, for other even polygenic type 2 diabetic patients also. So early, better glycemic control, less complications, and better quality of life is what is the future holds, as far as precision medicine is concerned. Thank you.
Wonderful talk, sir. Thank you.
Yeah.
Over to chairpersons, please.
Yeah, wonderful session, sir, on precision medicine. It was rather insightful session for all the attendees. Again, any questions from the audience for Mittal, sir, if there are any?
Mittal sir, I just wanted to ask you, we had before you the session on treating right sort of thing, where we should be treating at the right moment to avoid complications and increase in the cost burden by Sheshadri sir. So now your talk is related to that only, because you are talking the same thing, honing on a more precise manner on the precision medicine model. So how important it is to screen all our what we call type 1 patients in your view, because there are many patients who are monogenic, they are not actually type 1 and all those things. So how we can go ahead in our day-to-day practice? Any expert tips of yours?
See, the most important thing, what we are missing today, if I see myself, say 30, 40 years back when I was a resident, and then see the clinical touch is going off, proper clinical history, the patient's presentation, and we're not just talking anything. We're just seeing fasting and PPP or a random test and starting any treatment just like that. So take my words, if we say now, say for example, Modi. So one should think at the back of our mind should always be that it may be type 1, it appears to be type 1, it may be Modi. That point should be there, which is not there. Okay. So the most important thing is, so if a patient comes to you, appears type 1, do C-peptide. What is the problem in doing C-peptide? It'll be normal in Modi. Okay, do antibody test. And, take history, do screening in mother, and get the, sister examined and mother examined for diabetes, even if they're not known diabetic. You tell me what it requires. The only one, effort. Little effort and a little thought process that at the back of your mind, you should always take it that all young diabetics are not type 1. I think we should write down it, before reading for type 1, the first sentence should be like this. And then, we don't need, see, antibody, C-peptide, and a good history will tell everything.
You are very right, sir. Actually, and the more I see to it, you are expert. I am using a very explosive comment over here, but I could feel that the way we are here today, approximately 20 years back, we are not at this place in terms of diabetes, and it may be due to the wrong treatment methodology we have adopted over the years, wrong lifestyle measures we have taught to our patients, and not those who are not our patients even to them. So it may be a result of that, and now it is high time that we should correct all what we wrong are doing, what we are doing wrong actually. So that is actually your talk is actually to be very precise, very apt at this moment, because we are actually not treating everything right. Being a diabetologist, I should admit, because many times a young kid coming with high blood sugar value, we just label it type 1. Why?
No,
Very
Dr.
rightly.
Bharat, yeah, I'll just have a little different here. Like, we have not taught patients to become unhealthy. That is a society change in the society, and we are also a part of the society. I mean,
No,
just
I'm
one
not
point.
talking me, sir.
Yeah.
Actually, the advertisement, propaganda, the if you go into
So,
detail,
but the
all
only
these
thing
things.
is, what we need is that, some personal touch. I'll tell you my another experience, which I've, gained over last almost 35 years. That suppose I'm seeing 50 patients a day. So I don't counsel all the patients. I don't have time that much. But every day I choose 5 patients out of 50. And by rotation, I cover all 50 in next 3 months or 6 months. Okay. So what I want to convey that, it's very easy to say counseling this thing, but I think we have to find some ways of doing, and so that, yes, I will not teach someone who is not interested. I will see to it. So it is not my job to make 100%, but there are patients who are interested, but provided we take out some time every day, some time out of our, so maybe, 15 minutes every day or 20 minutes every day, I think, we would succeed. Take my words, we would succeed.
Very rightly said, sir. Wonderful take.
Great words, sir. Great words. Just I would like to mention two of my experiences in this session. Actually, we are seeing more kind of very young type 2s too, sir, to be very precise. Just two cases I wanted to mention on for your expert opinion. One case was a very young girl, 30. She was diagnosed first from a screening camp in school, where her blood sugars were kind of like 140ish, like fasting, and after food was around like just about 200. She was closely monitored, diet being strictly like monitored by her parents. Later, around 14 years of age, she ended up in our clinic. Her on presentation itself, we did a C peptide, which was on the lower side. Still, we started her on insulin. Her GAD was negative, and then we did a Modi 1 and Modi 3. Just she could not afford it completely, so where we could start sulfonylureas were Modi 1 and Modi 3. We did a Modi 1 and Modi 3, which came out to be negative, and she has a very strong family history. So this is where we still have a confusion. We don't have quite a good evidence to start a sulfonylurea or a oral anti-diabetes agents to change her treatment. That's one case, sir. Second case, we had a like one friend of mine, his brother, he himself was a doctor. His son was diagnosed with diabetes.
The screen is frozen.
Was quite low. He was labeled as type 2. Around stimulated and fasting C peptide was quite low. On diagnosis itself, we did a thyroid function test, which came out to be TSH was quite high. We started thyroid medications too, thyroid hormone medications too. Later, his blood sugars improved dramatically. We just repeated a C peptide. GAD was negative. Repeated a C peptide. C peptide came again high, to be on the higher side. Later, we could switch him to tablets. Now he is off medications completely. So there are certain
there are certain gaps. You're right. So in first case, actually, there's a family history you said, and antibodies negative. Try to understand. And C peptide was a lower, so it is not fitting into type 1. I mean, try to understand. So it may be Modi or type 2. And similarly, that second one, generally we have, KPD, ketosis prone diabetic patients now. who are basically type 2 diabetic patients, but they present like type 1, very high sugars, very low, C-peptide, antibodies also, maybe plus, because 8% of patients with type 2 can have antibodies plus. Okay. So in that case, we should not label. This is another lesson which I want to, convey, that young patient never label type 1 or 2 in the first sitting. Treat the patient, discharge the patient, maybe on insulin, it doesn't matter. So when you repeat C-peptide next time, because acute glucotoxicity can, make beta cell totally, deficient, and there is no insulin there. So they may not be C-peptide, and, they may be even ketone bodies. But when you treat the patient, and when patient comes next time, C-peptide would increase, like in your second patient, C-peptide increased. Okay, that will never happen in type 1 diabetic patient. Is that okay? So, never label in first day, label after 2 to 3 weeks or at least 1 month. Never be in a hurry to write, because once you write type 1, it's very difficult for the second person to change it. Okay, I think,
I think we should write it down.
Thank you. Thank you.
It's a learning, great learning curve for young doctors like us, sharing such screenplays with legends like you. Dr. Surajit, you want to comment something?
Yeah. So thank you, Dr. Binod sir. It was like absolutely enlightening about the precision medicine, and on a case-to-case basis. And as we discussed the 2 cases from Dr. Ashwin, so case-to-case basis, and that is what exactly the precision medicine is all about. We need to discuss with the patient and level, and very rightly you mentioned that is absolutely a learning point for all the young diabetologists. Never diagnose or never write type 1 or type 2 on the first visit. Just treat the patient with insulin or whatever your treatment, and then maybe after 1 month or next visit or 1 to 2 months, you can decide on the final diagnosis. So that is absolutely essential to gather and to work in our daily to daily practice. Thank you, sir.
Thank you.
It was absolutely enlightening.
Thank you, everyone, and it was my pleasure and privilege to be here. Thank you, Dr. Bharat Sabu, and thanks everyone. All the very best.
Thank you for enlightening us. Thanks a lot. Wonderful talk, sir. Thank you.
Thank you, Dr. Sabu, Dr. Bharat, and over to you, Dr. Hina, for proceedings.
Thank you so much. I'll introduce the first chairperson for this session, Dr. Sandeep Suri from Hisar, MD, FDIM Gold Medalist, CMC Vellore, FDFM Indian Podiatry Association, Senior Diabetologist at Advanced Diabetes and Critical Care at Holy Health Hospital, Hisar. Second chairperson is Dr. Sandeep Jain from Bhopal, MD Medicine from Ahmedabad, Fellowship in Diabetes and Endocrinology, Nepal, Bengaluru, Consultant at Atisha Diabetes and Endocrinology Center, Bhopal. Over to you, Dr. Sandeep Suri, sir.
Yeah. Very good evening, friends. At the outset, I must thank Dr. Bharat Sabu for opportunity giving to me to be part of this academic feast, prestigious Asian Diabetes Forum, master classes. And really, we have enjoyed Dr. Vinod Mittal's lecture and previous lectures also. Friends, today's first will be Dr. Dena Shrestha. Fine. So it's very important to know that diabetes never comes alone. It is most of the time it is associated with comorbidities, and we always call that it is a barat of various comorbidities which are there. And we are going to talk about these 2 comorbidities today in this at this junction. And first is we will be talking about diabesity. Now, diabesity, the term was given by Sims et al. And it was given in 1970. So you can just judge how much the time has elapsed. It's a 50 years from today onward. So it's a 15 years back the diabesity term came into the picture. And actually why it came into the picture, because when we realized that there is an underlying overweight and obesity that leads to increased diabetes, hyperglycemia, pre-diabetes, conversion to diabetes, and then these are co-associated, not only coexisting, but lot of comorbidities and complications are also being driven by both of these 2 when they come together. So it's a twin epidemic which we are facing now. So to talk about this, we have got very elegant speaker with us.
and Ma'am Dena Shrestha is there. She is from Nepal. She is MBBS MD endocrinology, present designation senior consultant endocrinologist, and she is working at under presently she is past president of Dean's Diabetes Endocrine Association of Nepal, immediate past president, but present she is president SAFE, that is South Asian Federation of Endocrine Societies, and she is working at Norvik International Hospital, Kathmandu, Nepal, and she's going to talk about a consensus of diabetes related to medical nutrition therapy in diabetes. Over to you, ma'am.
Thank you so much for that kind introduction, and thank you everybody for having me. And really, okay, let me share my screen. Yes. So definitely after such a wonderful talk from both our esteemed doctors, I mean, this comes like, I feel it's a very general, simple, and not such a fancy topic, but it is something that, you know, we deal with it every day, right? Like, and I'm so glad that I got to speak on this, because we did work a lot, the whole team, on this for quite some time, and we got it published also. And I think somehow it has been the underdog. We haven't been able to really bring it out. And I want to thank Dr. Bharat for giving me that opportunity to present our good work, you know. So we are really happy. So going on to my thing. So yes, as Dr. Suri said, so diabetes is the combined burden of obesity and diabetes. So we have seen a rising trend in both these epidemics, and we've labeled this as diabetes. Apparently, like you said, it's been there since the 70s, and almost 1 in 10, that's like 10% of, we have data, this is from the United States, that they suffer from diabetes, right? And I'm just going to put this away. And yeah, and so 90 to 95% of obese patients actually have type 2 diabetes. And when we see the other way around, we see that 80% almost of individuals who have diabetes now live in the lower and middle income countries. I think what is sad is not only that actually the lower and the middle income countries are affected, but also the fact that in these lower and middle income countries, the lower and middle class actually suffer more these days than the rich. And that is something that has been an issue in our Southeast Asia. Diabetes is reaching epidemics. We all know about that. And, you know, our countries like India, Pakistan, and Bangladesh, I will just present the data, it's mind-boggling. And what can be seen is that actually the improved socio-economic status has improved certain things, like we have less child death, or we have better, you know, our tuberculosis is much better, but definitely there's an increase in our sedentary lifestyle, and we are adopting a calorie-rich westernized diet. So if we see the burden of diabetes, I mean, everybody knows it's a lot. India is maxing out on it. Pakistan is there, then followed by Bangladesh. We can see that Sri Lanka, Afghanistan have lower numbers, but it's still there. And it seems that Bhutan is our leaner friend, but followed by Nepal. So Nepal is not so bad with diabetes. But when it comes to actually obesity burden, we can see that India, if it is there with 24 to 30%, depending on where you take it, Pakistan has about 30%, Bangladesh 34%, Sri Lanka has 30%, and Nepal, which is also not, the numbers are not so high when it comes to diabetes, but our overweight and obesity in men and women is about 28 to 30%. So this is a problem in all our South Asian countries. And Bhutan is still on the leaner side, it's about 25%. So the recommendations that we had, the overview is about, this is a paper that we published, and it's about screening and diagnosis. We've staged it. And then there's about medical nutrition therapy, managing diet, monitoring, counseling, and motivation, and the way forward. Today, in view of the time, I've only taken up the third, and I'll just generally just hit upon the last two. So how are we defining medical nutrition therapy, right? So that is, I think, if there are two slides that I want to talk about today, one would be the definition, which is that it is a provision of nutritional assessment, advice, and follow-up. So it's not only nutritional assessment, it is also about the follow-up for preventing and managing the disease. So it can be by both qualified or trained HCP. So you don't have to be particularly qualified, like you don't have to need a certificate, but anybody who's trained also can give this advice. MNT includes dietary, nutritional, and culinary advice. So this is something that we included, that it's not only about dietary and nutritional, but also about how to do it, how to cook. That is also important. And it includes both, it can be both homemade and medical grade formulations. And as well as diet-related content. So MNT also encompasses style of communication and counseling. I mean, definitely, if you just, which we'll discuss later, but we have come across where sometimes we think that, we give the patient advice and they don't take it, but we never actually reflect that maybe how we're communicating and counseling may not be good enough, or we need to change it. Just telling them sometimes doesn't work. Like I think Dr. Sheshadri said, like, there's a lot of involvement, a lot of empathy that has to be taken, a lot of consideration that has to be met. And that is the only way that we can actually make sure that the MNT works. And in context of diabetes, the medical nutrition therapy aims to manage both dysglycemia and adiposity. So that's obvious. So what are the indications of medical nutrition therapy is that obviously it has to be integrated into care for all individuals who require the glucose control and weight management, because we are talking about diabetes. And it can either be to decrease or increase weight. Sometimes we have really, really badly controlled type 1 diabetics who might actually need to increase their weight. So medical nutrition therapy can also be used for that. Or sometimes type 2 diabetics who've been catabolic, comes to us with ketosis and have got some infection, haven't been doing. So so medical nutrition therapy is not only about decreasing weight. It can be increasing weight or maintaining weight. So basically it's ideal for patients who have cardiac metabolic comorbidities, dietary restrictions due to diseases, especially renal diseases. We know there are too many restrictions and patients are always confused. And it can also be used for patients who have a busy lifestyle, they lack resources of healthy cooking, and patients with stroke who have chewing or swallowing or any other limitations, and patients who are unwilling to adhere to strict diet regimens. So what is the classification? We've classified medical nutrition therapy as therapeutic or preventive. Therapeutic if they already are diabetic, have metabolic disorders, or are obese or are diabetic. And preventive is they have metabolic disorders and obesity and for weight management. The classification is also further can be into whether we are doing it homemade or commercial preparations. That can be for kidney diseases, for glucose control, same thing for specific nutritional deficiency. We do see a lot of patients with anemia, and commercial can also be therapeutic and for the same listed as in homemade. So basically, the last way to classify is also depending on the method of use, right? This is also good. So how intense are we using the MNT, or what is the mode of delivery? Intensity can be, are we just replacing a snack? When simply we tell them, don't eat your, I think in India, maybe pakoras or samosas for tea, and for us, we say momo and noodles for your snack. That is also an MNT. So we replace the snacks with something healthy, or we replace the meal altogether. And whether what kind of delivery are we giving? Are we giving them intravenous like we do for TPN, or whether we are giving them enteral, and then there's whether we are using a vials or just oral feeding, whether we are giving them powder, bars, or liquid shakes. So basically, depending on the method, how we are using it, those are the three ways you can classify MNT. The goals are simple. You attain or maintain a glycemic, blood pressure, lipids, and weight. You delay and prevent complications. So goals for diabetes, according to ADA, is that we have an A1C of less than 7%, and the blood pressure, the lipids, and lipids can be lower or is better. HDL, a higher HDL, and appropriate triglycerides. Goals for obesity would be that you could, if they are overweight, you would prevent further weight gain. Sometimes I think I tell my patients that, okay, I keep telling them reduce weight and it doesn't work. And I'm like, okay, next time your goal is that do not gain weight and come. I mean, I'm going to be happy with that. Sometimes that is also good enough. And reducing body weight can be short-term, interim goal, or long-term goals. So short-term is like we expect, especially if they're newly diabetics and they're type 2, they're a bit on the obese side. We do tell them that the 5 to 10% of weight loss would be good. And, it can sometimes help you reduce medication and even sometimes be on minimalistic medication. Interim goal would be to maintain all this. And long-term goal is, if desired, you can further lose some weight, right? So what are the challenges that we face providing medical nutrition therapy here? Obviously, in advanced countries, we know that diabetes and obesity care is person-centric, and it is used as a therapy in addition to pharmacotherapy and surgery. So their insurance will pay for it. South Asian countries, actually, the MNT is not covered by insurance. Actually, most of nothing is covered by insurance. So it's an extra expense for them. And physicians are not sensitized enough to place such emphasis on MNT. And I think that it is, we say this, but I think it's a chicken and egg story, because I think that physicians are not sensitized to MNT because a lot of times patients don't follow the medical nutrition therapy and that doesn't work. And so, it's like, you don't listen to me, so because they go home and they kind of don't change. So somehow physicians are also like, it doesn't work. It's better to increase their medicines than to actually keep on telling them but I like that what our previous Dr. Mittal said, that maybe we can use those 5 patients every day and tell them, no, you got to do it, but that's what it is. And most hospitals and clinical settings actually have a pre-printed standardized MNT charts, which is easier, cheaper, because we do know that we tell patients that, no, you have to go to a dietitian or a registered dietitian or a nutritionist, and they just look at you like, you don't want to do your job. Why would I go to another person? And I'm for sure, I would like the opinion, but does it happen in India? Because they're like, it's your job. I'm coming here for diabetes. I need your advice, so I'm not going to another dietitian. And it does have to do with finances. It does have to do with how their faith in you. So all that mixed together. For me, I think an extra challenge in this last decade and a half of my work is also the socially. I think any patient losing weight is not accepted by the society. The husband loses weight, the wife is not happy. The wife is losing weight, the husband is not happy. Husband and wife is losing weight, the society is not happy. They're like, what happened? So, and then it's become such a taboo when you lose weight. It's like either you are really sick, you are end of your life, or like, you've lost your job, or it's just, they cannot take it that anybody who is losing weight or who's maintaining healthy weight is actually healthy in general. They would just have so much sympathy for that patient that that patient himself would be so depressed and sad, they inevitably try to gain their weight. I would like to know your opinions if that's the same in India. And really, also for the doctors, it's a bit overwhelming, because when we talk about, diet, it's like, what do you want to choose from? There's low carbohydrate diet, very low carbohydrate diet, ketogenic diet, which is very popular amongst the social circle, I should say. Then there's the paleo diet, the intermittent fasting, which personally now I do advocate. Then there's Atkins diet, and then the Mediterranean diet. And then there's a DASH diet for the hypertensive, right? Then there's low energy diet. And there's very low calorie ketogenic diet. So, and they are the vegetarians or the vegans. Really, to give advice is not going to be easy. So it has to be stepwise integrated approach. There's so much to choose from, and each individual is different. Each culture is different. Each household is different. So you really need to understand what is happening. So first, we as physicians need to understand the current practices, know the current dietary habits of the family, then recall the macronutrients breakdown, timings, oil usage, eating out. Then step 2, once we've decided what is good for the patient, then we have to think of the patient. And then in the step 2, we can have the key principles of weight management and then put it into the feeding pattern, then involve the family. A lot of times, actually, when my patient is not doing so well, I'd rather, even for the husbands, I'll write with wifey, So if the patient does not come with the wife, I'm like, no, I'm not seeing you next time. Your family has to be involved. And then Step 3 would be troubleshoot on follow-ups. I think this is one of the most difficult. Putting them on diet is good. Maintaining them is not so happy. And then following up, because once they achieve a good weight, it's really difficult for them to come back. I mean, especially when it comes to diet, like, they just give up on it. So what is our recommendation for the MNT is the group A is the general diet recommendations, which we've taken the plate, but half of it is vegetables and fruits, right? But I think fruits also, we have to tell them that when we say plenty, it might mean 3 to 5 servings is max, because sometimes people just go overboard with fruits. And then drink enough water. Whole grains, we have to tell them the concept that every grain is the same, because sometimes in Nepal, like they have grains like grit, we call it, where it's not fine, it's just rolled oats or and they'll just eat a lot of it. They'll fill half the plate or 3/4 of it, because we are a carbohydrate loving society. And so is, I'm sure, India and Bangladesh and Pakistan. And that is why we have to tell them, whole grains, but in 1/4 of your, and then healthy proteins. So whether it's fish, poultry, if you are non-vegetarians, but beans, nuts, and to limit red meat, cheese, and avoid processed foods like bacon, cold cuts, and other processed meats. The diet for the diabeticity in South Asia has to be planned carefully, right? We have to keep in mind, we can't say, okay, this is the one for Southeast Asia and this is what we're going to follow, because it's region specific. There's culinary diversity, there's lifestyle, and of course there's economic conditions. Telling people to eat organic, healthy, and having like olive oil. But I mean, we know we have people who are not so financially strong, and that might not work for them. So we just have to tell them how to eat healthy. Diet education should be part of the patient's counseling, and we can start with doing 5 patients in each day. A hypocaloric diet should be advised, and also encouraged to maintain food diaries. I mean, if they're educated, like at least write what you ate, once every few days, so they kind of understand what it is. And also tell them to keep in mind that emotional eating patterns are there, and that if they're overeating or if they're not feeling so good, that it can do with stress. So combining those 2 things to them can be helpful. Group B is nutrition and care. So we have to tell them about carbs and about what is saturated fat. And we have to tell them that, what is oils, and really cooking methods. That sometimes I say that like baking is too fancy. Like it's like Queen Mary Antoinette saying have cake. Sometimes I tell people to bake and it's like, do I even have an oven or a fridge? So, we have to keep that in mind. But steam is something that I think most people can afford that. And then we can tell them to just steam and shallow fry and, not use deep cook, to use too much oil. And unless contact indicated, we have to encourage them to eat enough protein and supplements. And because we tend to eat a lot of vegetables, green vegetables, and maybe a lot of rice, but the protein intake might not be good enough. And we have to monitor them, and really, especially for young, middle-aged and young individuals, we have to see whether they have eating disorders, whether they have psychological issues, and that really needs to be dealt with proper counseling and pharmacotherapy. And in group C, what we have is medical nutrition therapy. And as Dr. Kalra has suggested, we go through the cooking style, food source, presentation, storage, preservations. All these have to be appealing and stimulating. Without that, it's not going to work. So MNT should design that it incorporates the triplets of macronutrition, that is protein, energy, adequate micronutrients, and it should be medically and metabolically appropriate. We have to keep in mind dyslipidemia, renal diseases, celiac diseases, hyperuricemia, which is very, very common amongst our diabetic patients. MNT should be affordable. I think that is one very important thing, and that locally available, and it has to conform to local customs. I like this, that we have found the 7 A's of dietary choice. So it has to be accessible, acceptable, it has to be accurate, absorbable. Like you can't give a person with gluten intolerance or you can't, so that has to be there, and it has to be affordable, because we are living in Southeast Asia and we know that diabetes is affecting the low income people more. It has to be attractive and it has to be appropriate. So there's formula MNT can be used. So there's sometimes at the moment we talk about medical nutrition therapy, that's why the definition is important. We always think about formula, but formula is one of them. And when can it be used is like if it can be used as a meal replacement for people who are really busy and are not willing to adhere to strict diet. Sometimes for lunch, I think if they're rushed out, you can tell them eat a breakfast, eat a good, like eat your dinner, but lunch, you can actually replace it with a formula. Some people who have very limited access to healthy cooking, sometimes people live in hostels or eat in the canteen, so they can do that. Or people who have issues with chewing, swallowing, or other immobilities. Also, I think the next important thing is also that, of course, it has to go with your pharmacotherapy, right? I mean, if you're only on metformin or SGLT2, you're not so worried. But if you're on a full dose of sulfonylurea, you're on basal bolus insulin, then of course you want a 3+3 meal pattern. And also, if you're on a pre-mixed insulin or a human insulin, we know that the NPH is going to work at some point, or the premixed insulin will have a smaller peak in like 4 or 5 hours. So we have to make sure that the regular snacking goes according to that. And also, if they are going for shopping, or on a weekend they're going out with their children for some exertional physical activity, we have to advise them about the snacks. Lifestyle and physical activities it has to go hand in hand, of course. And we know that it only exercise, physical activity does cause modest weight reduction. But sometimes I feel that patients who've started physical activity tend to gain more weight. And that can be because, one, they could have put on muscle mass and lost their fat mass, which I always tell them. But the other thing is that really patients take, at least here, that when they exercise, they take it as a license to eat. So I always tell them, I'm encouraging you to exercise, but that is not your license to eat. Just because you've worked out for 1 hour, you've sweat in the gym, it doesn't mean you can eat what you like, But it goes hand in hand. We have to tell them that you have to exercise, and weight management does help preventing fat-free mass and maintaining weight. And of course, it has its cardiovascular and mental health advantages. Managing diet in the setting of abundance. We have heard enough patients who've complained that, there was a time when I couldn't afford good food, and now that I have it, because our socioeconomic in the last decade or two has gone up, and they're like, now when I thought I can eat and enjoy, because food is such a dopamine and endorphin and everything. It just brings so much happiness in our culture that they feel sad that they can't. So we really have to tell them that you have to make the right choices. Right? You can eat, but you have to eat the right food. Patient education and self-restraint is very, very important. Restricting access to unhealthy food. You have to tell them that at the grocery, when you go to shop, that's where your healthy diet starts, right? You always have healthy food alternatives at home, and exercising is good. This is another thing that we did discuss, and we have incorporated. Actually, the use of smartphone apps to provide nutrition, exercise, fitness guidance actually helps. So we can encourage patients that no matter which app, just if you can afford a smartphone, then these are the patients that you can tell them that download an app and just make sure that you use it, because it does help. And establishing farmers market, this is for policymakers, people who are involved, that like Dr. Bharat, I'm sure, in your campaigns, we can always ask to establish local farmers market, have subsidized fresh fruits available in school as a snack, and revisiting these strategies, right? We do need to monitor patient adherence. That is important. And we have to ask them about what their beliefs are, attitude, why they eat, why they don't eat, what is the level of physical activity. Then we measure their body composition and just tell them that this is, it can be a long-term goal. Sometimes I tell them, 3 to 6 months, you're not going to lose weight. But what about in 2 years? Inevitably, you will lose weight. So don't give up, right? And then we, of course, do the biochemical data that is always there. And then we have to be able to communicate, affect, make sure the appetite and everything is good. So counseling and motivation, that is what is important. We can tell them to go to a registered dietitian, but I think we reinstate that when they come back. We just don't shrug them off that, no, you know that you go to a dietitian or you meet them. No, you tell them, okay, what did you learn? If we did say, oh, you did it. So, okay, you know, that's working. So sometimes talking to a doctor about what they did with the dietitian and what they're doing home actually encourages them. And that's a positive feedback. So I think that works. And a study from Southern India for morbidly obese individuals suggested that actually 1/3 of the patients attending obesity clinic had psychological problems. So we really have to be empathetic. We have to tell them, like, we have to ask them if everything is good, if they have stress. And I haven't met anybody who said like they're happy, you know, so it's like, it's a vicious cycle. But we have to tell them that stress eating is something that people do, and that is what it might be. And exercising releases endorphins that actually help you with stress. Meditation helps, so only not food. So we kind of have to divert them into that direction. So a lot of counseling and motivation is recommended by us. If lifestyle interventions fail, patients they're not motivated. And even if they're not motivated with this, they then also don't get motivated with the medications, then they're not motivated enough to take care of the sugars. We've heard about diabetes burnout. So really, we have to ask them to assess, be systematic, communicate with empathy, de-stress the patient, and I say ourselves, because sometimes we are stressed out, you know, so we have to keep a happy face, and we have to make sure that, you know, the patients are de-stressed, engage all stakeholders, and agree on goals. Like sometimes we might, you know, if it's the festival season and they're like, I can't do it. So there's no rush. Like we can say, okay, we'll revisit this next time when you're feeling better, you know, and then tell them to change one behavior. Okay, tell them, okay, at least for 5 minutes, maybe while watching TV, you can walk up and down. And they're like, okay, that I can do. I'm like, yeah, I just do for 5 minutes. Come on, promise me that. And they're like, okay, I'll do it. So when they come back, of course, if they've done it for 5 minutes, they can do it for 10 minutes. And we can build like that. Cycling of weight, diet and nutrition therapy, exercise. So those are the contents that we need. So these are my last 3 slides. Way forward for diabetes management in South Asia is personalized medicine in diabetes. There's definitely a role for gut microbes and genes that is there. Like we talk about precision medicine, you know, how we've now tailored it down to what can be done. Even for weight management and diabetes, we know that the gut microbiota actually in patient with diabetes causes many, many pathological changes. The beverages, the foods that we take changes everything, and that and that results in inflammation, insulin signaling. And so really from the diet form of an important trialogue in diabetes, many genes can modify the response to diet. So that is one aspect that we really need to go further into, like research more about. I think yesterday Dr. Sanjay gave a talk about in Bangladesh for the Bangladesh Endocrine Society, and he was talking about how we should check about the microbiota in our dahi, or other foods, you know, and see how that's helping us or not helping us. So I think that is something that we really need to go. That's the way forward. And also in Southeast Asia, it's a developing region, and we are introducing the Western concept of person-centered and patient-centered care. This leaves involving patients with disease, giving them the right to make the treatment choices. And sometimes, like, they might just say, I don't want to do it. And sometimes we just might need to let them be for a while and say, okay, fine. But then, you know, I'm increasing your medication. And sometimes I say, okay. And then you go back and you might just need insulin, or you might just not be able to. Sometimes I scare them, see your kids, because your eyes might be affected. But if that's your choice over food, that's you. And then they're like, how can you be that, you know? But sometimes just telling them, okay, it's your decision, you do it, you know? As a guardian, as your well-wisher, I'm telling you where you'll end up, because this is the road you're taking. And so sometimes that also helps. Educating them about the disease. So basically telling them that it's an uphill MNT working, because it's not for 10 days. It's not like you have to die for it. It's like, it's forever. So people cannot change, I say. They need to evolve. And evolution, we know happens. So, and taking care of the psychological needs, especially with this COVID, I think that has been a big issue. And this is a team that was there making this happen. So really, thank you so much. And thank you again for letting me speak on such a topic that I like.
Yeah, excellent talk, Dr. Dina. Excellent. And very rare to listen to such a passionate talks on MNT. Thanks for sharing your experiences. You have very nicely said about medical nutrition therapy, and its whole definition has changed, looking from dietary advice to nutritional advice, culinary advice. We have to be very empathetic with our patient. We have to be very involved with our patients. Just I want to listen from you one or two lines that how you approach intermittent fasting, that you have mentioned few lines on that.
So basically intermittent fasting now almost is prescriptional for me if they don't have any other. We usually I write 7-11. So 7 p.m. they eat their dinner. I'm usually telling them roti dal saag, you can eat what you want. And then I tell them that till 11 a.m. So they eat their brunch. And I encourage them not to take breakfast, but brunch. And Nepal is also a dal bhat country. So I tell them to eat their brown rice and eat their good meal at 11. And but in the morning, in the beginning, how they say that you can take tea, coffee or something with low calorie. But I've realized that actually, there's, we say that you're not a true Nepali if you don't have gastric. So, a lot of people complain about gastritis. So I just tell them to take 2 or 3 glasses of lukewarm water since they wake up, and nothing else, because I think everything else messes up your gut. But if they take warm water, 2 to 3 glasses, and then at 11 eat their lunch, 1 o'clock I tell them to snack with a fruit and salad mix. 3 o'clock I tell them to take a snack, which is usually chana makai or some oats. And 5 o'clock I expect them to eat nuts and egg whites. And 7 o'clock they're back to dinner. So this is something that has really worked for me for the last 4 or 5 years. And people, I think even patients who have been on insulin, at first I was scared of hypoglycemia, but I asked them to check it, and they don't seem to go into hypoglycemia so much. And if they go, I always counsel them before that, that's a good thing. That means that it can decrease your medication, and it works. So 7-Eleven is something, and I don't know if 7-Eleven is a very popular store. It's a small,
really.
So I'm like, now you can 7-Eleven yourself, to help. So yeah, it works.
Fine. Thank you. Sir, can we go to next speaker? I think now it's time, Dr.
I want to ask one question.
Yeah. Okay.
Question to ma'am.
Sure, please.
Is there any chance of hypoglycemia when going for the intermittent fasting? Basically, the patient those who are on insulin.
Yeah, but I take it
because it's a big duration from 7 to 11.
Yes, but I think what happens, I've realized over the years, is it's your experience. So I wouldn't say this is grade A, but this is an E, expert opinion, I would say. Because I myself, I think we put most of our patients, and we tell them that you might go into hypoglycemia, but that means your medicines will be reduced. So everybody is given a glucometer for free, and we ask them to monitor. So it's a win-win situation. You want, in a way, hypoglycemia, because that means the intermittent fasting is working and you've achieved what you want, and you will reduce the dose. We only don't like hypoglycemia because if it's nocturnal, or if you think that, but if you check your bedtime glucose and in the morning, and very rarely I've had complaints about it, but if you counsel them enough and tell them to keep a banana next to the bedside, so just in case they do go into hypoglycemia, I think it works. I don't know, Dr. Anuj, do you have your intermittent fasting stories to tell?
As far as my experience is concerned, I had in my patient, but I always select whom I really take the chance of making a long fasting. If the patient is quite vulnerable to go hypoglycemia if the patient is is taking the multiple shots of the insulin. I usually do not prefer him to go on the long fasting time. To know it that we always say that fasting is not good in the daytime fasting, when most of the time we also say the people not to go for the Ramadan fasting, etc., etc. But in the night fasting, that is for the good intention, just to reduce the weight, just to keep your biological clock okay. It does not mean that patient should keep on eating all the time. He can keep at 7 p.m. and then he can take the breakfast in the morning. I think if the person is on the insulin and he is diabetic, he should take the breakfast at the right time.
Yeah.
Prolonged fasting is only good for those who are having a high IR, but they are not using insulin. They are not taking even any other anti-diabetic drugs, including sulfonylurea, etc., which may cause such kind of the event. So that is my view on this. But let me try. Sometimes in a patient who is having insulin, I will tell you that my experience.
Dr. Dina, wonderful talk, really. I read your paper and I thought if I could convince you to talk on this, and I'm so glad that you agreed to it. Intermittent fasting I very regularly use in my patient. 16:8 you are talking about, your is 7:11. And it works wonderfully well for those set of patients who are aware about their hypoglycemia. The hypoglycemic awareness should be there, because if they are having a hypoglycemic unawareness, it can prove fatal. And as Anush sir rightly said, it is a boon for those patients who are having IR. IR patients do wonderfully well on it. But those on insulin depleted, I have never tried. So I would again like to try it. Thank you. Thanks for the wonderful talk. Thank you.
Great talk, Dina.
Thank you so much.
I enjoyed.
Thank you so much.
Okay, so can we go ahead for the next talk?
Sure.
Yeah.
So it's pleasure to introduce Dr. Anuj Maheshwari sir. Sir is the professor and head of medicine in BPD University, Lucknow. And for last year, sir is the teacher for DNB and PhD students. Is the vice president of.
Don't read full. It will take a lot of time. So better.
No, sir, I will.
The duration of lecture will go away if you keep on reading, because we have already.
Sir is the vice president of RSSDI. And sir has got basically Health Icon Award in 2017 and 2019. And sir has got Marvelous Personality of the Year 2017 by UP Governor. And sir is also a well-being champion in 2018 by American College of Physicians. So without spending much time, sir is going to talk on the very important part, that is the blood pressure management or hypertension management in diabetic patients. That too in the Asian situations. So over to you, sir.
Thank you, Sandeep, for the kind introduction. And just I could remember that again I have to nominate few people for the well-being champion. If anybody of you is interested, you can definitely give your name for the same. So let me share my slides. Thanks for the kind introduction. And thanks Bharat Sabu for inviting me here one more time. I'm really feeling myself lucky. And so in next 20 to 25 minutes, I shall be talking about the hypertension management in diabetes setting. Very interesting and very good title it has been chosen. Should be more aggressive. It is really $1 million question. Let me try to answer if I can. Hypertension is more common in individuals with diabetes. It's not a new thing. Everybody knows that. Estimates of the prevalence of hypertension in diabetes usually ranges between 40 to 80%. And very interesting thing is that both the diseases are having the similar complication. And when they are together, these incidence of complications like coronary heart disease, cardiomyopathy, stroke, peripheral artery disease, end-stage renal disease, and other microvascular complications increases. What we know that when diabetes and hypertension are together, then 40 to 80% of the diabetics develop hypertension. And the person who is having diabetes, he is having 2 times chances of developing hypertension. We know that microvascular complications, which are more than 70%, and having and going into the end stage renal disease, especially with the hypertension as well as diabetes together, and even any of the one disease is there. More chances of the retinopathy, 3 times more chances of getting a cardiovascular coronary artery disease, left ventricular hypertrophy, congestive heart failure. Peripheral vascular disease, again 2 to 4 times more common in diabetic patient, and it increases the risk of the proportionate to severity of the blood pressure. Means as much as the blood pressure will be high, more chances of developing the peripheral vascular disease in a diabetic patient. And obviously the brain is again not left alone. It has got 2 times more risk of getting stroke. Apart from that, memory loss and other things are very commonly seen in patients those are having hypertension with diabetes. Very interestingly, we always keep our focus on the diabetes management. Very rarely we talk about the hypertension. Even if the patient comes to our clinic, we do check the glucose level, but most of the time we don't check the blood pressure and never care for that. And even if it is blood pressure slightly rise, we say that okay, you start reduce your salt and just forget about that without saying them. You should check it for 7 days continuously. Despite the fact we know that diabetes is having around 7.5 prevalence, while the blood pressure and raised blood pressure and hypertension is having the prevalence just 3 times. It is 25.3%. And both are open to get the similar amount of the risk and similar kind of the complication. What mechanism makes them more vulnerable to develop the complications as well as the complications which are ending up into the similar way? Obviously, the diabetes causes this problem through the hyperglycemia when it comes up to the advanced glycemic end products accumulation, causing microvascular complications. This rest, all other things like may be the RAS, may be the RAS activation, may be the immune activation, may be the oxidative stress, inflammation, messenger RNA, all are the mechanism which are working in both the diseases together to cause more and more macrovascular complication as well as microvascular complication. When we talk about the process which are running into the blood vessels, especially our vascular tree, whereby the diabetes and hypertension predisposed to the advanced cardiovascular disease or sometimes the stroke are similar. Although common risk factors like genetically prone, insulin resistance, dyslipidemia, obesity, they take us towards the diabetes and hypertension, both kinds of the disease, but these both diseases takes the end outcome of the cardiovascular disease through a common pathway that involves atherosclerosis, endothelial dysfunction, vascular inflammation, vascular fibrosis, arterial remodeling. So in this way, diabetes approximately doubles the cardiovascular disease risk in patients with hypertension. If we talk about the phenotypic characteristics which are associated with hypertension, especially in patients with type 2 diabetes, it's very interesting to know that males are more prone to get the hypertension in population. Familial hypertension is more prone to develop high blood pressure, especially in a patient if a person is having diabetes. Advancing age, advancing BMI, advancing duration of the diabetes, they all are the risk factors for the development of hypertension. eGFR, if it is reducing, means it is causing hypertension. Microalbuminuria, retinopathy, advanced retinopathy, all are increasing with the high blood pressure. And if the blood pressure is high, the chances of development of these things would be much more, including the hypertension, including the myocardial infarction and stroke. So if we talk about the hypertension characteristics in diabetic individual, diabetic patients are more commonly having the systolic hypertension. They have got the enhanced variability in blood pressure, which is very commonly seen. That's why we prefer ambulatory blood pressure monitoring in diabetic individuals. They are prone to develop orthostatic hypotension. They have hypertension which is more resistant to the treatment and experience less reduction in nocturnal blood pressure and higher baseline heart rate than their non-diabetic counterparts because of autonomic neuropathy. Blood pressure control in these patients presents a great challenge because the target blood pressure is quite low and the response to treatment is often poor. When we talk about the hypertension influence on macrovascular disorders, diabetic patients develop cardiovascular disease 2 to 3-fold more commonly as they are seen in non-diabetic individuals. Hypertension is one of the most significant risk factors for arteriosclerosis. The complication in diabetic patients increase the frequency of developing CVD. Compared to normotensive non-diabetics, the rate of onset of CVD is 5 to 7 times higher in diabetic individuals with hypertension. When we talk about the cerebrovascular disease or stroke or hemorrhage, brain hemorrhage, we see that hypertension, mainly the systolic hypertension, is one of the very important culprits, strongly and directly related to the stroke in all age groups. The presence of diabetes more than doubles the risk of stroke in patients with hypertension, and lowering blood pressure in patients with hypertension and diabetes reduces the risk of stroke by 44%. When we talk about the salt-sensitive hypertension, this is seen in the individuals, those who are having the diabetes. Because of what? These patients have high glomerular blood pressure and a flatter pressure diuresis curve. Hyperinsulinemia is one of the important factors which causes not only insulin resistance, which is involved in accelerating the reabsorption of sodium from the renal tubule, giving rise to the higher salt sensitivity. Excessive salt intake inhibits nocturnal blood pressure reduction. So in this way, we know that if we can reduce the 10 millimeter mercury of the systolic blood pressure, standardized association with all-cause mortality reduction, macro and microvascular outcomes reduction in diabetic patient can be seen. Apart from this, a very important correlation of this hypertension in diabetic individual is the morning hypertension. Prevalence of the microvascular and macrovascular events is more in a person with hypertension and diabetes, even if he is normotensive other time, if his morning blood pressure remains high. Characteristics of the circadian rhythm of blood pressure, which are determined by the 24-hour ambulatory blood pressure monitoring in a diabetic individual. What we could see here, very important observations. What we know that higher awake and sleep systolic blood pressure predicted increased risk of cardiovascular events more accurately than did clinic blood pressure in non-diabetics as well as diabetic individuals. Office heart rate, albuminuria were strong predictors of the mortality. Sleep heart rate, dipping, and ambulatory arterial stiffness index improved the prediction of the risk. The prevalence of the mass hypertension was 29.3% and 18.8% in untreated diabetes and non-diabetics respectively. So in untreated diabetes, the chances of getting the mass hypertension is almost 1.5 times. In untreated diabetic mass hypertensive, the risk of composite cardiovascular endpoint during 1 year follow-up by tended to be higher than in normotensive, like with a hazard ratio of 1.96. Now the question arises, that is the question of the day. Should we be more aggressive? More intensive blood pressure lowering improves the cardiovascular outcomes irrespective of baseline systolic blood pressure and atherosclerotic cardiovascular disease. This was the outcome of the advanced trial. Blood pressure and CVD risk in hypertension could be judged in the strong heart study when we could know that cumulative incidence increases from normal to the pre-hypertension, more than the pre-hypertension is in the diabetes. I'm not talking about the diabetes and hypertension. I'm talking about the diabetes and pre-hypertension. You can find the cumulative incidences of all cardiovascular adverse outcome more or maybe the highest of all the categories. When we talk about the blood pressure and cardiovascular events, we see that more incidences. This is the outcome of one of the study. When in this it has been shown more incidences of the cardiovascular events could occur in less than 140/90 blood pressure as compared to the more than 140/90 blood pressure. But it never means that less than 140/90 blood pressure is lesser safe. It always means more people are there which are having more variability of the blood pressure. Apart from that, more people are having which are keeping their blood pressure less than 140/90 as compared to the more than 140/90. Obviously, the problems will definitely be there in that group, but it does not mean that keeping more than 140/90 is the same. Adjusted hazard ratio for the death as well as ischemic heart disease increases with the systolic blood pressure rise. We can see it here that hazard ratio for the death is jumping from 1.16 to the 1.73 simply by increasing 10 millimeter of mercury rise in the blood pressure. In fact, the category is just changing from elevated hypertension, elevated blood pressure to the stage 1 hypertension. The significant change in the hazard ratio for the death is seen. Prevalence and correlates of the hypertension in a semi-rural population of the southern India, which has been published in the Journal of Hypertension in 2017. What we could see that hypertension, if the blood pressure is systolic blood pressure is more than 140, the prevalence may be the 27%, while it's pre-hypertension 39.1% and treated hypertension 15%. Means only 15% individuals can keep their blood pressure less than 140 systolic blood pressure if whenever despite their all efforts. So whatever the statistics says, whatever the guidelines says, may be saying that you should keep your blood pressure 130/80, but our reality of the data is saying only 15% people are capable enough to take their blood pressure less than 140. So it's all really useless to talk about bringing them less than 130. Probably lesser percentage may be there. So 50% of the pre-hypertension just enters into the hypertension, lands up into the clear-cut hypertension. When we talk about the meta-analysis, which has reported a gradient of the progressively higher cardiovascular risk going from normal blood pressure to elevated BP, we see it here that if the blood pressure target is kept 130 to 139 systolic and diastolic 85 to 89, it's 1.56 is the hazard ratio for the cardiovascular mortality, while stroke, coronary artery disease, myocardial infarction, all these hazard ratios are much higher as compared to those people who kept their blood pressure between 120 to 129 systolic and 80 to 84 diastolic. So it's always more beneficial to keep blood pressure less than 130 and 80. In the accomplished trial, it has also been shown that blood pressure also has the U-shaped relationship, especially in diabetic patients. The patient, those who are having diabetes, they are not really doing good if they go more low beyond a cutoff. Like less than 120 is causing the risk of events in diabetic patients as per the accomplished trial. May it be the primary endpoint or the cardiovascular death, both the condition we can see it here. If the blood pressure is further lower than 120 mm of mercury, it's increasing the risk. So when we talk about the blood pressure control defined as systolic blood pressure less than 140, statistically significant difference could be seen in the systolic blood pressure, which has not controlled their blood pressure up to the 6 months. We could see more chances of development of the fatal and non-fatal cardiac event, stroke, all-cause death, myocardial infarction, and heart failure hospitalization. So this review has also shown that strong support for lowering blood pressure to systolic blood pressure less than 130 mm of mercury. And what we could see it here, in a meta-analysis, which has included number of studies 123 and 6 lakhs, every 10 mm of mercury reduction, a reduction in systolic blood pressure, % reduction in all-cause mortality, together with major CVD events, risk reduction 20%, coronary artery disease 17%, stroke 27%, and heart failure 28%. So this meta-analysis of 123 studies strongly support for lowering systolic blood pressure less than 130 mm of mercury. So there are clear-cut benefits of providing blood pressure lowering treatment, not only for the cardiovascular disease, coronary artery disease, diabetes, stroke, heart failure, CKD. In all groups of the patient, we can see these events. This another meta-analysis further shows that lowering of the blood pressure or aggressive lowering of the blood pressure is giving better results as compared to the less intense blood pressure control. More intensive blood pressure control has caused better primary outcome, as well as it has also been found to be reducing all-cause mortality. This is another study, meta-analysis of 61 prospective observational study, which included 1 million adults, 12.7 million persons years, had shown that simply 2 millimeter mercury decrease in mean systolic blood pressure can give you a 7% reduction in risk of ischemic heart disease mortality and 10% reduction in risk of stroke mortality. So every millimeter of mercury counts. And when we see that the blood pressure threshold and blood pressure goal, almost all conditions which are seen clinically may be the condition of the clinical cardiovascular disease with 10-year atherosclerotic cardiovascular risk, 10% or more than that, or the persons which are having the older age, more than 65 years of the age, non-institutionalized ambulatory blood pressure, community living adults, having the specific comorbidities, diabetes mellitus, CKD with renal transplantation, heart failure, ischemic heart disease, secondary stroke prevention, secondary and peripheral arterial disease, as well as lacunar infarct. The blood pressure threshold and blood pressure goal has not been found to be different. They are the same, simply the 130/80, except the condition when we did not find any clinical cardiovascular disease. We have the 10-year atherosclerotic cardiovascular disease risk less than 10%. Only blood pressure threshold to start with the treatment can be up to 140/90, and BP goal is still to be kept less than 130/80. So this is the situation across the world where we have seen that multiple organizations, multiple guidelines, ultimately accepted by the American College of Cardiology as well as American Heart Association. This is the picture. And we Indians are more having the risk of the IR. We are having the more carbohydrate eating country. We are having the more postprandial glycemic uncontrolled glucose level, more glycemic variability. Obviously, the risk will definitely be more with us, even if the blood pressure is normal. So, European Society of Cardiology Guidelines 2021 says about the cardiovascular disease prevention in clinical practice. It's important to keep the blood pressure less than 130/80. 120/80 is considered optimal. If it is there, repeat the blood pressure measurement at least every 5 years. But if the blood pressure is 120 to 129 and 80 to 84, it is supposed to be the normal, and you are advised to repeat blood pressure measurement at least every 3 years. If it is at the high normal, means between 130 to 139, 85 to 89, marked hypertension can be there. You should repeat the blood pressure measurement at least annually. Also expose the patient for the out-of-office blood pressure measurement, may it be with the ambulatory blood pressure monitoring or a home blood pressure monitoring. If it is more than 140/90, no other way to start the treatment in any case. High salt intake, alcohol, smoking, cold temperature, Asian ethnicity, these are the conditions which are making us more prone to develop the morning hypertension. As we know that morning hypertension is the key to take us towards the cardiovascular disease, towards the CKD, towards the all-cause mortality, cardiovascular mortality as well. Work stress, home stress, they increases the blood pressure in the daytime. High salt intake, CKD, diabetes, sleep apnea, insomnia, and Asian ethnicity again is one of the important reasons of nocturnal hypertension. So when we talk about the target of the blood pressure, treatment target of the blood pressure in a simply hypertensive patient ranging 18 to 69 years of the age, if it is not having any other comorbidity, systolic blood pressure is to be kept between 120 to 130. If he is having diabetes, again, it is recommended 120 to 130. Only the CKD patients are given liberty to keep it between 130 to 140 systolic blood pressure. Lower systolic blood pressure acceptable if tolerated in a patient of diabetes if it is more than 70 or more than 70 years of the age. Less than 140 mm of mercury can be allowed if the patient is not capable enough to keep the blood pressure less than 130. Diastolic blood pressure treatment target is less than 80 for all treated patients. So again, these guidelines says that if your patient is keeping blood pressure more than this target, then you should start the treatment in the form of the dual drug initial therapy. One drug can be chosen between ACE inhibitors or ARB, or another drug can be CCB or diuretics. Consider monotherapy in very low risk grade 1 hypertension, means systolic blood pressure less than 150 mm of mercury, or in the people, those who are very fragile and very old may go into the hypotension very commonly. Then you can add another drug if you don't find that blood pressure is getting control as a drug to be added which has not been used in the previous combination. Step 3 may be the resistant hypertension. Once you are using the 3 drugs, still the patient is not getting good control of the blood pressure less than 130/80 target, then it's a time you should think about adding the spironolactone 25 to 50 milligram once a day, or other diuretic, alpha blocker or beta blocker. For the beta blocker, there is a clear-cut guideline. Consider beta blockers at any treatment step when there is a specific indication for their use, like heart failure, angina, post-MI, arterial fibrillation, or atrial fibrillation, or younger women with pregnancy, or they are planning pregnancy. The core drug treatment strategy for hypertension algorithm seems to be very appropriate for most patients with hypertension, mediated organ damage, diabetes mellitus, cerebrovascular disease, and peripheral artery disease. So this is the way through which we added up our knowledge and reduced the blood pressure target threshold. It was the GNC 4 and 5 which has given us the target of 160 mm of mercury for the blood pressure lowering. Now it is 130 is given by almost all organizations, may it be the ACC, may it be the European Society of Hypertension or Cardiology, or the International Society of Hypertension. So simplifying the combination therapy is the ARB, diuretic, and calcium channel blocker. Optimal combination therapy for hypertension is ARB and CCB. So what is the take-home message? Lower the better, faster the better, better quality of the blood pressure control. Initiate treatment with the 2 drugs, not single effective. Use single pill combination only to improve the adherence. Use single pill combination only in the patient, those who are very much frail, or those who are the older patient, vulnerable patient. Follow an evidence-based simplified treatment algorithm. Thank you very much for your kind listening.
Thank you very much for the nice elaboration. So in the diabetes, as we need to control the HbA1c less than 7, the only 15-20% patients or 25% population is below HbA1c 7. So like that, blood pressure is also only 15% population is less than 130/80. So you have nicely elaborated all the things, sir. Any questions from the audience or any comments?
No, sir, I just want to, yes, Suri, sir, please go ahead, please. Sir, unmute yourself, please.
Kindly unmute yourself, Sandeep.
Yes, sir. Sir, excellent talk. Congratulations for you.
Thank you.
So how, what's your personal opinion regarding beta blockers? We are throwing them most of the time. We are looking at the specific indications. Routinely, we end up adding something like bisoprolol, nebivolol most of the time. And we find that these are very important because baseline heart rate is very high in our Indian scenario. And it has been proved in India heart study also. So what is your opinion? Where you use, specifically you focus on the indications of beta blockers, like you were looking at the angina, heart failure, post-MI, AF, or you use it as a routinely?
Yeah, I'm getting your indication towards what you are saying, that that is that is a autonomic dysfunction kind of the situation where we can see that sympathetic overdrive and sympathetic overdrive. So these are the two very different positions, different conditions, which are the extremes of that. Autonomic dysfunction we see in the patient, those who are having the diabetes, those who are having the CKD, those who are very much vulnerable for, or those who are keeping their diabetes uncontrolled for a longer time. But other part of that is a sympathetic overdrive. Sympathetic overdrive we see in our youngsters. We see the young kids, those who are entering into the medical college. On the first day of the medical college, most of the people are found hypertensive.
Yes.
Why? It's not, they are not hypertensive. Their blood pressure is found raised, but it does not mean they are hypertensive. It is their sympathetic overdrive, it is their anxiety, it is their fear which is making them. So we should always differentiate what is the simply a reaction of the situation in which is reflecting in the form of the blood pressure raised, or what is the disease. Just for differentiating these two diseases, the rule of doing home blood pressure monitoring at least for 7 days, twice a day, once in the morning or once in the evening before the sleep, and every time whenever you measure the blood pressure, it should be 3 readings at 1 minute interval should be done. Until unless you don't find your patient is being placed in that category, it is not really an indication of using any antihypertensive medication. Apart from this, one thing I would also like, even if you find your patient in this category, always think that your patient is youngster, your patient is having high IR, your patient is having late night sleeping, as Dina has already explained us. These things are there which we can improve. It's not necessary we should start treating with the medication. Yeah. We should start giving the pharmacological therapy. We can always say them. Of course, what we cannot change, that is the long-standing diabetic patient having the hypertension. We cannot take them back towards the situation when it can be reversed. So these are the patients who should definitely be given the pharmacological support. But it has to be seen. When I see that Indian population is having 33% prevalence of the hypertension. Our Indian population is having 72% population is less than 40 years of the age. If we say anytime that 33% population is having hypertension, from where this hypertension is coming? This hypertension is coming from those vulnerable population who is less than 40 years of the age. Less than 40 years of the age, we must ensure that whether this is the hypertension, this is the blood pressure, raised blood pressure, which is you measured and you found that hypertensive, and it happened that you labeled him as the hypertension. So these things should always be taken care. And if you find that your patient is having the sympathetic overdrive, high heart rate, high blood pressure, obviously beta without any hesitation.
Thank you, sir. Thank you.
Anand sir, my simple question is just to know how we can improve the situation regarding the undetected hypertension, because this is becoming a very common phenomena to find patient being hypertensive while they are unaware regarding it, while we are detecting them with the advent now with actually with complications.
We have to do the same thing what we have done for the diabetes. Yes. Sensitization and sensitization. Nothing else we can do. Only we need to make the population. Is that for the diabetes, a lot of pharmaceutical companies were with us, but when we talk about the hypertension, very little or very less, or sometimes even no pharmaceutical company will be there to put their money, because in last 10 or 20 years, no new molecule has come in the market for the hypertension management. We are still working with the older therapy. Older therapy is doing good, it is enough. But this is the problem which is related to the funding, which is related to the getting the sponsors. So obviously, people go more towards where more sponsors are there, where more lucrative things are being seen. But as a doctor, as an organization, we may not run away from our responsibility to make the people aware about the blood pressure and its adverse effects instead of keeping silent.
Dr. Anuj, may I ask one question?
Yes, sir.
Yeah. How often you come across postural hypotension according to the blood pressure categories, say for example, more than 140/90, then 130/80. Is there any data at what level more postural hypotension is there, or at this point of time there is no postural hypotension? So if that can help, because if we are tightly controlling the blood pressure, then postural hypotension is a big issue, specifically in
What I
long-standing
understand, sir,
diabetes.
postural hypotension is mostly seen in uncontrolled hypertensive patient than tightly controlled hypertensive patient. The people, those who are not so well controlled, they are not taking the medication at right time. Sometimes they are forgetting the medication. They usually develop in their postural hypotension is the simply indication or simply a reflection of autonomic dysfunction.
Okay.
And autonomic dysfunction will arise when your blood pressure is uncontrolled for a longer time. As well as autonomic dysfunction will also arise if you are keeping your diabetes uncontrolled for a longer time. You are keeping more variability in a diabetes. And a very low the same things will be in the hypertension also. Although hypertension is having the natural variability, but most of the time with our disturbed routine, we change the natural variability into the pathological variability. And that causes these kinds of the things what you see. Suppose a patient is having the blood pressure variability in which normally what we have, the 10% of our blood pressure goes down in the night time. If a person does not sleep in the night and sleep in the morning 4 a.m. or 5 a.m., his biological clock will change and he will start getting his blood pressure dip at the 6 a.m. or 7 a.m. And when he will get up at the 6 a.m. or 7 a.m., then what will happen? He will be having the he may be having the postural hypotension kind of the situation. It's not a postural hypotension. This is the natural hypotension which he was supposed to have, because it should have been the sleeping time. It should have been in the sleeping time between 1 to 3 and in the morning. So it has been shifted because people are not sleeping. People, those who are working in the call centers, they are getting their blood pressure in the morning rise. Most of the time we see their morning blood pressure high. That may be the reason. Dina, would you like to say something?
Yes. Just a short, sweet question. Inspired by that chart that they gave us, that you use that or a diuretic. Stage 2, you use that and a diuretic, and in the end, stage 3, if things don't work, you use a spironolactone. So what I have started doing, and I just wanted your expert opinion on it, is that because in the first it's or diuretic. So I started using spironolactone in the beginning because as a diuretic of choice, so I don't have to wait till the last. So do you have any personal opinion about it, and have you met patients with, is there a side effect, or is there something that
I think GNC 7 or less than GNC 7 era was that, when we were using the diuretic in the first medication. When we were doing our MD, or at that time we have been taught to start the treatment of hypertension with the diuretic. Sandeep must be remembering that.
Yeah.
So that was the time, and at that time also we were doing good, and our control patients were having a good control. But now these guidelines which have been developed after a long research, after a long data keeping, and those data has been analyzed, and we could come individual opinion and individual experiences may always be different than the guidelines. I never say, and in fact, I do not find these guidelines ever appropriate for the Asian perspective also. We don't have any Asian guidelines. We all are following the guidelines which have been made for the Western population, Caucasian population, those who are not only genetically different, but also they are having the different in their lifestyle also. They eat differently, they work differently, their phenotype is different, their genotype is different, everything is different. But we are following the guidelines which have been made for them. So that is the biggest problem with us. So unless we do not develop the guidelines which could be only for the Asian people and which have been backed by the Asian data, this this question cannot be answered. And probably we may get those out of those guidelines, we may get the same thing what you are doing. So that may be one of the things, for the Caucasian population, maybe the ACE inhibitors or ARBs are good, but for the Asian population, although I keep my finger crossed, and this may not happen probably, but there may be some study which may say that diuretics should be given as an initial treatment. But many a times we have seen that most of the patients usually don't take their treatment of hypertension if you start the treatment with the diuretics.
Okay. Yeah. Thank you so much.
Thank you, Anuj sir, for a wonderful enlightening talk.
Thank you. Thank you for giving me this opportunity.
Thank you, sir. Thank you.
Thank you all for remaining very much available for questioning and discussion all the time. A special thanks to Dina, keeping connected from Nepal.
Thank you, sir. So can we hand it over to Dr. Hena for the next session?
Yes, sir. Yes, sir. I'll introduce the first chairperson, Dr. Rajesh Agrawal, MD Medicine, DAVV, PGI Chandigarh, Senior Consultant at Diabetes Overweight Thyroid Clinic, Indore. The second speaker we have is, second chairperson we have is Dr. Mahua Sidkar, MD Medicine, D-Diabet, F-Diabet from Dr. Mohans, and consultant diabetologist at Polyclinic Suraksha Polyclinic Diabetes, Chennai, Chennai Diabetic Clinic, Bardhaman, and Apollo Clinic, New Town, Kolkata. Over to you, Dr. Rajesh Agrawal.
Rajesh sir, sorry to interrupt you, but Dr. Madhat Al-Arbi is in flight and his flight is delayed. So he will not be able to join us today. He will join us tomorrow. And we have Dr. Ravi Kamapalli sir with us. So please introduce Dr. Ravi sir.
Right. Thank you, Bharat. It's a great academic feast. And I must thank and congratulate Dr. Bharat. Today we have a very eminent speaker, Dr. Ravi Kamapalli, who is a board certified infectious disease physician, certified wound specialist physician, and a diplomat of American Board of Obesity Medicine is starting. And he is having medical degree from Guntur Medical College, Andhra Pradesh. He is residency at Bikoff Height Medical Center, infectious disease fellowship at St. Vincent Catholic Medical Center, and clinical assistant professor in Department of Internal Medicine, Infectious Disease at the University of Toledo College of Medicine. He is past medical director of Hyperbaric Clinic and Chief Division of Infectious Disease. So he is basically dealing with infectious diseases, and he has multiple publication and reputed and national and international speaker, and with infectious disease, wound care, and obesity medicine, with significant clinical research experience, having done 72 clinical trials. And he will be speaking on the new medical nutrition approach for the management of metabolic obesity. And if we go by the data that most of the Asians are metabolically obese. And this is a new nutritional approach. How I am very sure that we will be more knowledgeable after his talk. And the area which I represent, central part of the India, where public or patients are more interested in non-medical treatment and always in favor of dietary management, though they don't follow. So we will be, it is a pleasure to have Dr. Ravi Kamapalli and learn new nutritional approach in the management of metabolic obesity. Over to you, Dr. Ravi Kamapalli.
Thank you, Dr. Agrawal. Can I share my screen now?
Yeah, please.
Okay. So I'll start the presentation because of the time. Basically, I have around 50 or 60 slides, but let me go through them, but also talk about how we can work on a proper human nutritional lifestyle. So the topic given to me was metabolic obesity treatment, a new therapeutic nutritional approach for cardiometabolic disease reduction. I practice in Georgia, USA, but I have many friends in India and I have multiple connections across the country. And my goal and conflicts are removing barriers to healing. And obviously, I have a bias. I'm more for low carb nutrition, but I also have a significant target of the tsunami of chronic diseases that I want to change. Now, the topic, they get new, but I don't think it is new. There is nothing new in nutritional approach. We have been known to follow low carb approach in the past, but somehow we got distracted. So metabolic risk, metabolic disease is a major, if not the most important cause for cardiovascular disease. The objectives of today's talk would be metabolic disease, would be basically to look at metabolic disease and cardiovascular risk, and therapeutic carbohydrate restriction. I try to avoid the name keto. I call it therapeutic carbohydrate restriction as the best lifestyle intervention. And obviously that targets insulin resistance as an evidence for diabetes reversal. We'll talk about how much the therapeutic carbohydrates has evidence for that. And we're talking about how we are going to be decreasing inflammation, reducing hepatic fat, and also serum fat changes. And we'll talk about a little about time and range and why is slowly but steadily ADA changing their guidelines. But more important, at the end, I want to stress, I'll give some practical tips, and I also try to discuss what is holding us back. Like the middle part of India, you said that there was some problems, people not accepting, but I think there is a problem with us doctors being able to deliver that solution for our patients. So let's dive in. The prevalence of diabetes is huge. As you know, in US, it is 42% of Americans have diabetes or pre-diabetes, whereas 84 million have pre-diabetes now. Globally, it is 415 million. I think the number is more with the latest numbers, which is expected to go to 642 million in 2040. China and India are kind of leading the thing, but obviously US and the rest of these 5 countries, Brazil and Russia, are following. So I want to bring about the data for the obesity part too. If you see in obesity, 8 in 10 adults are obese, but 8.5 of 11 kids are obese too. The same with Russia, you see that 7 and 4, 7 out of 10, 6 out of 10 for China. But what is the difference in India? This is what I thought was significant. As in childhood, obesity in India is 4 out of 11, but as they grow, I guess most of us turn becoming obese. So metabolically, we are kind of in trouble in India. The impact of diabetes in India is significant, something that I thought we should really look at. The productivity, this is the NEJM study, wherein they said that of the people with diabetes in India, the follow-up until they followed up with death and retirement, it was found that there were almost 8.5 million excess deaths when compared to normal people, but also productive years lost, 89 million productive years lost, and equivalent to US $2.6 trillion US dollars of lost GDP. But more so, I want to stress this, there is a 50 years, at age of 50 years, diabetes is causing problems with 6 years earlier death than a survival problem. So even in US, it is shown that the chronic diseases are causing more problems, metabolic dysfunction. Most of US patients, or 88% of US population is metabolically challenged, according to the study in 2016 that was published. But most of the recommendations for dietary recommendations in US are, say, for metabolically normal people. And the death rate also, after decades of robust growth, the raise in US life expectancy stalled. And now they're talking about, it is not about the drug overdose deaths, but it's more so the cardiovascular diseases that are the main culprit. And basically those have to be targeted. Even when comes to the cardiac problems, if you see, cardiologists are having a tough time And for say it becomes more complex for the rest of us, and it gets more confusing because now they're saying that in this NEJM study, they followed a stable coronary artery disease with moderate to severe ischemia, 5,179 patients. In that, they found that even this, they did not find evidence that there is initial intervention strategy is any difference at the 3.2 years. So basically, they're talking about medical therapy being good as interventional therapy. But also, this is another Danish study where they followed the 23,759 symptomatic patients, where they talk about atherosclerotic plaque burden that is more predictor than the stenosis. So what is the main issue? Why are we facing so much trouble? And this is like a analytical tool. They call this Archimedes model. They came up with this Archimedes model, which is an analytical tool to improve the quality and efficiency of healthcare. So basically, by this tool, they came up with the conclusion that prevention of insulin resistance would prevent 42% of myocardial infarctions, and also it would for hypertension it is 36% prevention, and for HDL improvement, and also basically LDL cholesterol is only 16%. So the conclusion is insulin resistance is the most important single cause of coronary artery disease, and we need to better understand this. So in this ADA study, this was a study effect of insulin resistance on expected rate of fatal and non-fatal myocardial infarction. So in insulin-resistant people who are treated, basically the solid line, there is not much change. But if they are not insulin resistant, their time in years, expected time of MI is reduced. So also, this is another study wherein they said if in China, 14,231 participants, this is a pre-diabetes study, wherein in pre-diabetes, if you see when they normalize the pre-diabetes, the cardiovascular, the red line, and when it normalizes, then myocardial outcomes improve, the stroke improve, all-cause mortality improves. And basically, also, we have to understand that insulin resistance, even in non-diabetics, so is very important. There can be compensatory hyperinsulinemia causing them metabolic syndrome, but sometimes they turn out they become diabetic. But insulin resistance and hyperinsulinemia can occur in non-diabetics too. And that causes, that work is through dysglycemia, dyslipidemia, and elevated blood sugar or procoagulant state, endothelial dysfunction, hyperuricemia. All these factors contribute even in non-diabetic individuals, and insulin resistance is where the focus has to be. So in targeting cardiovascular risk factors and dietary adaptations, there are many techniques or processes. Normally, till now, we have been pushing caloric restriction. But when we do the caloric restriction, the metabolites and hormones changes are different. But when we are doing intermittent fasting and alternate day fasting, the improvements are remarkable. So obviously, targeting cardiovascular risk factor through the dietary approach has to be the major way in which we have to change healthcare delivery process. Medications are fine, but nutrition has to predispose all those other medication approaches. So obviously, we understand the metabolic syndrome, but we're not clear about what is insulin resistance, and we still don't understand it. So we can have obesity, we can have all the factors, which could be high calorie diet or high carbohydrate, high sugar diet, sedentary lifestyle, stress, Cushing syndrome. But what is the common factor is high insulin circulating in the blood, excessive fat storage, and inflammation. So insulin resistance, hyperinsulinemia, is the central factor, the unifying theory of chronic disease. That's what we have to understand. All these chronic diseases, complications, and these insulin resistance causing mostly chronic disease reasons, including diabetes, heart disease, cancer, and stroke, and causes 3/4 deaths in the health system. So we have to focus on that. Now let's define insulin resistance. It's nothing simple, a subnormal glucose response to endogenous or exogenous insulin. The causes are obesity associated, nutritionally driven, stress, medications, even some HIV medications do cause that, of course, steroids, and pregnancy and puberty are two natural insulin resistance states. Without in those two normal physiological insulin resistance states, humanity cannot survive. Obviously, other insulin resistant states, including insulin problems with the genetic autoantibody, insulin antibodies. So basically, we're talking about the spectrum where the metabolic health, where the people are insulin resistant or insulin sensitive, and everything seems to be depending upon this spectrum wherein it is either carbohydrate, quality, sleep, stress, all of these. But how often are we measuring insulin in the blood for our patients? This is my question to the folks who are listening to this talk. So why should we measure insulin? Because number one, once we eat, our carbohydrate spikes with 100%, protein with 40%, fat 4 to 5%. So with this spike of insulin, with this spike of the macronutrient when intake of the blood sugar when compared to different macronutrients, that kind of stimulates the insulin and causes the impact on the metabolic syndrome. The path to diabetes, it's European Heart Journal. I like this. It was, I think, a few years ago, wherein we're talking about impaired glucose tolerance 10 years ahead. And the fact diabetes happens later. And obviously, the microvascular and macrovascular complications continue. So this diabetes is a predisposing, the complications of diabetes are predisposing mostly 10 years before. I want to show this study, and we're going to shift into discussing about low carb therapeutic carbohydrate restriction. This was a study done by Dr. Jeff Wolick. Carbohydrate restriction has a favorable impact on metabolic syndrome, wherein we're talking about improvement of all the good metabolic factors. But I mean, there is a slight changes wherein sometimes the low carb diet can cause LDL elevation. That's where most of the problems come. But also, there is this is a meta-analysis wherein they reveal that there's significant overall improvement with type 2 diabetes for hemoglobin A1C with ketogenic diet. And obviously, people are skeptical about therapeutic carbohydrate nutrition. So there is significant evidence showing that and systemic reviews. But also, if you guys want to note that, take a screenshot of this slide. The Public Health Collaborative has more number of clinical trials and RCTs for more amount of duration that is available. So evidence is overwhelming that we have to follow and understand therapeutic carbohydrate restriction and guide our patients. So this is another systematic review published in BMJ, which talks about almost 23 studies they reviewed, and 18 of the 23 had low-fat diets. And this showed the remission of diabetes with hemoglobin A1C less than 6.5 in the studies. So why does all this happen? Because number one, the real issue is adipose accumulation, and this leading to dysfunctional adipose tissue with free fatty acid in the liver that promotes triglyceride accumulation and also inflammation, eventually disease progression. Obviously, that happens with fibrosis, and sometimes leads to NASH and fibrosis and cirrhosis. But through that, we are having problems with dyslipidemia, subclinical inflammation, and cardiovascular and atherosclerotic changes and heart disease. Now, inflammation of the accumulated fat is very important in type 2 diabetes and also in obesity. As per these studies, inflammation seems to be the root cause. But how can we change this is by harnessing our body fat to become the anti-inflammatory mechanism. How do we do that? By making sure that our bodies burn out and produce beta-hydroxybutyrate, which is one of the ketone molecule, acetone, acetoacetate, and beta-hydroxybutyrate. beta hydroxybutyric is very important. It suppresses the oxidative stress. There is by inhibiting histone deacetylase inhibitor. When you treat about cancer, when you talk about cancer, people who are treating cancer are trying to see if they can inhibit histone deacetylase. The drugs for cancer inhibit histone deacetylase. So now how does that happen is HDAC, histone acetylase, basically beta hydroxybutyric is working at the epigenetic level. So genes are there, epigenes are there. So this epigenetic level, the beta hydroxybutyric is causing histone deacetylase inhibitor. Whereas when it comes to the NLRP3 inflammasome, so people who have rheumatoid arthritis or any arthritis, there is inflammation. That's where that's happening at NLRP3 inflammasome, and beta hydroxybutyric blocks that. So that is an amazing next understanding we should have. So the beneficial effects of a Mediterranean diet are having stress, but I say I have more than Mediterranean diet we can talk about. But this is an 18-month study of 278 participants, wherein they found that the aim was to make sure that there is reduced hepatic fat content. So basically, there is decreased hepatic fat that are independently associated with improved parameters. So we say we don't eat Mediterranean diet in India, I guess. But so we had to find alternatives to how we can do that. And we'll talk a little bit about it too. So dietary carbohydrate restriction improves the metabolic syndrome. This is another study talking about benefits of metabolic syndrome with low carb nutrition. In this study, what they did was they also improved. This study showed that with low carb approach and high carb approach, and basically what, if you can see that here, there is something called as palmitoleic acid. So when there is in the low carb approach, the palmitoleic acid levels reduce. If you see this, and also triglycerides reduce, and if you see here the significant improvement with low carb approach when compared to the high carb approach. So despite being higher in saturated fat intake, carbohydrate restricted diets decrease the total saturated fatty acids. So the fat that you eat is not the fat that is in the blood. That's what the take home point from this study is. So also we have to understand that this is nuanced, a little bit nuanced. Dietary fat restriction is often accompanied by increased carbohydrate intake. Suppose if we are going to do carbohydrate intake, say we say low calorie diet, so don't eat fat. If you tell our patients, what's going to happen is obviously they're going to eat more carbohydrates. Now there is a hormone called steroid coenzyme A desaturase. This is converting the saturated fat into monomorphs that are elevated by carbohydrate intake. And as we know, the bonds are not tight with the MUFAs, and that's where the problem starts again. So we're going to talk about time in range here. This was a study with the hazard ratio for all-cause mortality in people who have time in range. So there is a lot of discussion about CGMs now. Association of time in range is as an increased all-cause cardiovascular mortality among diabetes mellitus type 2, validating that time in range has to be the surrogate marker for adverse clinical outcomes. But here is a kicker. I'll show you something here. So this just came out recently in Diabetes Care. They're talking about postprandial glucose response by targeting diet versus Mediterranean diet. So earlier we told that Mediterranean diet is important, good, but now we're targeting how can we do better than Mediterranean diet. We have to target the diet. So how can we do this? This study they did again, N of 225 patients, wherein postprandial glucose response, like a PPT diet, wherein they personalized the diet for the patient, and the PPT diet improved glycemic control. So they put a continuous glucose monitor on this patient, and they compared that to the Mediterranean diet and guide them. So I mean, like this is so easy to do if we if we can come up with a solution. And the problem is not the patients in the middle of India. The problem is the doctors everywhere in India and across the world. We have to learn better. So why and how we can improve has been shown, like you see this almost 2005, effect of low carb diet on appetite. So this was, if you see, we don't need CGMs. This is fancy and dandy. This is great. We can do this kind of dietary treatment, but we don't need all those. In 2000, even in 2005, just by doing low carb, the glucose levels, the markers, everything improved. So we don't even need CGM, to tell you the truth, if we can teach our patients how to eat better. Now, we talk about different, I'm an obesity medicine doctor, and the clinical obesity treatment modalities could be self-directed management, intensive behavioral therapy, structural medical monitor diets, pharmacotherapy, medical devices, and surgical, and other promises. Obviously, we do have to use some drugs in some patients. And there is phentermine, the phentermine topiramate, and now the GLP-1 agonists are there. So basically, but there is also surgery. Surgery does help in severe people. I mean, metabolic bariatric surgery does work, but obviously that sometimes could be mutilating and it has its own consequences, but there is data. Now, should we do data or should we personalize data? That's what, as doctors, we have to decide. We have to get away from mass medicine mindset. Yes, surgery helps. There's decreased death, decreased heart failure, decreased stroke, decreased complications, but what complications does this generate? I mean, obviously, I do support my surgeons who do bariatric surgery, but this is evidence that there is data. But are we getting better than that? So can insulin resistance be reduced or reversed? Yes. By what are the approaches? There could be a therapeutic carbohydrate nutrition, low carb, low calorie diet, weight, metabolic surgery, diet and exercise, or short-term intense lifestyle. So basically, the degree to which this can be improved remains upon individual factors. So it just comes down to how we individualize the solution so that we can monitor the biomarkers and handhold them through this change. So again, there is more studies showing that that very low calorie ketogenic diet is safe and a valuable tool for long-term glycemic approach and improving the BMI, improving all the markers. So I can keep going on this, but like approach could be many human studies that could be calorie restriction, body fat reduction, and carbohydrate reduction, and ketone production. So basically, therapeutic carbohydrate restriction has a potential to reverse insulin diabetes, and basically, it is currently at this point there is no gold standard for dietary treatment for insulin resistance. But obviously, these four things could be done. But what we can do is how can we personalize the solution and how to minimize insulin resistance. We can approach all this intermittent fasting, no processed carbs, industrial oils, building muscle and helping with exercise, and maximizing nutrient density, minimizing glycemic impact, keeping insulin pulsatile. We need insulin to survive. We need insulin. It's a growth hormone, but it has to be pulsatile and it has to be nutritionally driven. So specific diets to increase protein intake has to be there, fiber has to be there, and dietary fat intake is that is what has to be monitored too, depending upon, because if you have to burn our fat, we have to reduce possibly the fat after we prime the person, not starting right away. So this is a new consensus report on definition of remission. Obviously, you guys have seen this, wherein remission is 6.5% over taking off the medication and at 3-month period. So basically, it can be initially we can do pharmacotherapy, but they have to be at least off pharmacotherapy. They can have surgery, but it will be 3 months after the procedure, and lifestyle at least 6 months after the beginning of the intervention of this procedure. So obviously remission, a lot of data here, a lot of studies. I don't have time to go over that, but we have to understand that we have to come up with the prescribing process wherein we have to review, assess, and plan, communicate, monitor, and change. Now, how can we develop this process? And I am trying to work on doing it. And by 2022, we'll, middle of next year, we will have the solution and we will have it available for everybody, most of our doctors to do that in India. So, but ADA is slowly changing its tune. You see that in 2019, it said may result in improved glycemia. And now it's saying most evidence for improved glycemia. Now 2021, most evidence for improved glycemia for individuals with type 2 diabetes. Insulin and other medication may need to be adjusted. So obviously, when we are giving them, we should not scare patients when they are doing low carb. We have to help them. So we have to be careful and guide them through their personalized journey in the middle of India, across the world. So now, is it therapeutic carbohydrates something new? No. In 1863, William Banting wrote this book, Corpulence. There is a dietary cookbook in 1917. And basically, even New York Times headline had fat as a cure for obesity in 1884. So we're talking about something that is not new. So there are all these toolbox in our toolkit are multiple. DASH diet, I mean, this is crap diet, to tell you the truth, if anybody says that. So for me, I'm sorry I say that, but that's what I think about it. Whereas there's other things. We have to personalize. If somebody wants to do it, we have to figure out how to help them do it. You know, they could be ketogenic, carnivore, fasting. We don't promote fasting. We have to promote fasting. The benefits of carbohydrates, controlling carbs would be more than weight loss. It is not weight loss we are after. We are after metabolic health, where we are improving metabolic markers, improving mood, improving stress, decreasing need for all the anti-inflammatory and less headaches, all the non-weight achieving parameters. You know, how to do that? Simple is waist to height ratio. Target a waist to height ratio of 0.5. It could be in centimeters, it could be in inches. Take a measurement of your waist size and height size, and divide waist to height ratio 0.5 or less. That's what we have to target. So simple is barriers. There are barriers to most barriers. What I see is inadequate training to the doctors, lack of adequate mentors and clinical support team, and thinking that they are not convinced and don't agree, conflicts with whatever interest they have. And I mean, we all diets are there in the toolbox, but how can we have an interdisciplinary approach? And basically simple. It is low carb diet. You know, there is advantages. If you want to go less than 20 carbs, that is strict keto. Then moderate 20 to 50, liberal 50 to 100. So if you want to start at one extreme, go at one extreme. But the question is, you can slowly meet them at where they are ready to start. Finding the right balance is the key to low carb success. You know, there isn't even any ideal level of carb level for everyone. So it has to be personalized. And also, anybody who talks about low carb studies, you have to make sure that anything less than 25% anything over 25% is not a low carb diet. So basically, anything we have to keep that in mind. So finally, we're putting all this together is simply this is what I teach my patients. Please feel free to take a screenshot of it. So reverse diabetes and hypertension. Keep carbs low. Avoid processed vegetable oils and foods. And in the foods, when I say processed foods is very important. So what I say is, if there is a label on a food, it is a warning label. You need to avoid anything that has a barcode that has 4 to 5 contents on it. And obviously, I give them a vegetable oil list that I try to avoid, tell them to avoid. You tell them to avoid a real food. You have real food, but avoid anything that has sugar or fruit juices. By the way, fruit is candy. And I want you to understand that we need to understand what, when, and how. That means, what are you eating? Cut carbs, prioritize protein, fill with fat. When are you eating? Fast, and it's about fasting and intermittent fasting. It's more so about satiety than calorie counting. But what we have to add is why. Why are you eating? What is making you eat? And that's what the patient has to answer themselves. Obviously, there's hydration and all that. and insulin resistance is a widespread problem, and all these things we can talk about. So on rare occasions, yes, we can eat, we can have some fun, but it has to be rare. So we have to, like I say, auditing the environment. We have to not have all the sweets in the refrigerator, and we have to audit the environment, because at the end of the day, it is all about addiction. It is all about addiction. This addiction is kind of a problem. And the future of solutions is enough one solution. We have to have targeted nutrition therapy support in wound healing. There is different approaches, including testing for insulin response, along with glucose response, early detection, CGM, app-based technology. Obviously, I do wound care, so personalized wound care. So this is what I talk about. Every time I do this, I keep hammering this chronic disease. This is a huge problem. So anyhow, when we come, no discussion is going to end without COVID discussion. If you see this, they talk about COVID, physical barriers, distance, hygiene. I'm an infectious disease doctor talking like this, wherein I'm saying that why can't we build a metabolic fitness barrier here? That has to be the Swiss cheese model of no harm for COVID. Has to be a metabolic fitness model, and we cannot fix healthcare unless we fix health, and we cannot fix health unless we fix nutrition, and that starts with each one of us. And we need to do root cause thinking. We need to avoid this fragmented approach to healthcare and head in the sand ostrich approach. The key takeaways are remission of chronic disease is possible. Dietary approach is to be safe and have safe, and it has to be the right approach. And obviously, education of physicians is important. Whole food diet is very important. And we have to have an approach wherein we take nutrition, but addiction is also very important. And non-communicable diseases are the real pandemic. And we have to make sure that outcomes of infectious disease are avoided because of the non-communicable diseases. Obviously, there is no magic pill. We have to avoid mass medicine mindset, develop N:1 medicine. All we have to do is follow Nike. They said, just do it. We just have to do it for each patient at a time, but monitor and taper treatment. And obviously, all medicine is personal. Every patient is a puzzle, and we have to move away from that. That's one of my things I keep pushing. But anyhow, proper nutritional lifestyle is where we have to be, and research is to see where everybody else has seen, and to think what nobody else thought is what we have to do. So I'll stop there and see what we have to do, and I have a few references. And therapeutic carbohydrate restriction, I have to say, is evidence-based, and there is nothing that should stop us from helping our patients in a personalized approach. And I'm working on that and hoping that by next year I will have some significant solutions that I will bring to this forum, and through the team here, we'll be able to help. Good. Thank you.
Thank you, Dr. Ravi, for your excellent deliberation. What we have learned about today, we are talking about precise medicine. So you have talked about precise nutrition. So I think that is very important message from your talk, that precise nutrition is very important part, and which just does not all over the India. We used to, in various religions, we used to fast, intermittent fasting for 6 hours or 12 hours or 24 hours. But the thing is, and in which carbohydrates are reduced, and other things are taken in a bigger quantities, like fruits and some more fat and less carbohydrate. But it was usually misused and taken more calories and more calories. So what I want to understand from you, low calories is more important or low carb is more important?
So calories thinking is kind of, we have to stop. Number one, the reason for that is calories are important at the end, but not in the beginning. So because it is the hormones. What our food does. So food is medicine. What our food does to our hormones. It is not what, it is not what we eat that is important. It is what our body does to what we eat. So what is the hormonal response of the food that we have eaten is what makes or breaks a system. It is not, so say last 6 weeks ago, I came to India and basically I let everything go and started eating all the things that I ate before because, I just wanted to try it. But then I did not have the same happiness that I had before. But then I gained around 10 pounds. So it is so easy to gain weight. And my fasting insulin level when I was before I went low carb in 2015 was around 18. And it came down to 6 or 7 when I'm in low carb. And when I fast for 5 days, my fasting insulin goes down to 1. And basically, when I went to India and came back and did my blood test, my fasting insulin level was 15.
50.
15, 1-5.
1-5, okay.
So it was almost back to where it was. In 2015, I was 225 pounds. And basically, it takes see, chronic disease is chronic because it is chronic. Because it is like, think about this, Hiroshima, Nagasaki, we had a bomb, the bomb go off there, but we don't have many cancers there right now. So the question is, any acute event, fine. You can, as long as you can find your way back. If you're chronically causing the same trouble, say if you're talking about fruits, if you're eating fruits and grains, whole grains and vegetables, what happens is, fruits have a lot of fructose. And in our body, whenever we are eating food, glucose is metabolized by every cell of the body, whereas only fructose is metabolized in the liver. And we give our kids fruit juices so much. I mean, I grew up on fruit juices. I mean, like, you will end up having fatty liver. So, like accumulation of fatty liver and problems associated with pancreatic fat, I think it has to be the focus of diabetes and chronic disease improvement. So obviously calories do matter, but what the food intake causes to the hormones is more important.
Right. So very nice message, Dr. Ravi. Yeah, Dr. Hina, you want to say something?
Yes, sir. Yes, sir. I want to ask Dr. Ravi, in India, as we practice here, we know that most of the people here are vegetarians. They are not vegan, but they are vegetarians. And we don't take more of a protein, and we have more of a carbohydrate diet. So in practicality, the lecture was wonderful. I came to know across many things new as far as fat is concerned and protein is concerned. But we need a baseline solution for the substitute of carbohydrate here, because carbohydrate is a filler.
Yeah.
Patient does not get satisfaction without carbohydrate.
Dr. Hina, this was also my question. This was
yes,
also.
Sir. Yes, sir.
Yeah,
so in practicality, yes, we
good.
doctors also, we are also human being. We follow the same pattern of diet. I mean, I was initially taking 4 rotis. I was not gaining weight. When the age increases, my metabolism went slow. I reduced the chapatis, and I'm having 2, but my weight is not reducing. So this is what I'm experiencing. So I'm decreasing the carbohydrate. I'm doing things on myself first and observing things. And so this is the metabolic thing which we as Indians are living with, and we have to die with it. So the practicality is what should be the carbohydrate, because we cannot survive without a carbohydrate. We are substituting with multigrains. We are prescribing you should have multigrain atta and you should have brown rice. But practicality, it's not the scenario. We are also we learned people are also facing difficulty in changing our own self. So it's very difficult for us that you rightly said that we have to change first, and only then we can help our patient to change.
Yeah.
So
basically, I was in your board in 2015. So, I mean, obviously I have a little advantage because of where I am. But what I just did when you were talking is I just Googled, okay? And I'm just showing you something. So I just Google keto chapati. Okay. So well, basically, say now you're talking about keto, Indian keto or keto recipes. Simply go there. See recipes vegetarian. So simple. See this. You know the question just. See, this is what this is what I teach my patients. Okay. So I right now I'll show you something. Bharat, is it okay if I do this?
Yes, sir. Sure, please.
So basically, what I do is I have this platform, which I was a founding member of before, but I'm not promoting it. But because I have a different mentality than the team that I found with. So I go to this, I go say, look at this. I will show my thing. I will show you my thing, and I will show one of my patients' thing. And I want you to see later. You guys can go to my website, nobadbugs.com, and I have a YouTube channel. And I talk about this like a crazy guy. So this is what I do. I eat whatever I eat. I mean, whenever I ate before, I track what I eat, and I have a ketone breath analyzer and all. But I don't want you to think about ketone breath analyzer. In the space of it, think about CGM or something like that. Or so at the end of the day, it just comes down to how we kind of use technology and help our patients. But also before we use technology, we have to figure out how we can help our patients and ourselves first. So I'm showing you a patient picture here. So basically, I teach the patient how to take her food, and she has a severe hypoglycemia, and nobody is helping her. She kind of has some issues. So I'm trying to work her out. I mean, I'm not a frigging endocrinologist. I'm trying to help her with my and the other endocrinologist friend who is on the board. You see that? She got this hypoglycemia spike. Like I'm trying to scratch my head. We are doing the ACTH stimulation test, and she had this insulin level. And then when she eats any carbs, she spikes. See this? She almost went down to whatever this 48 or something like that. So the question is, once I did fasting insulin level, so I did insulin baseline and did a glucose tolerance test. Her fasting insulin was normal, like 7 or 10 or something like that. It went to 275.
So was it reactive hypoglycemia?
I think so. So basically, what I'm trying to figure out with people like this is how I can change their paradigm. You know, like this one. This is the same case. I should have shown you this one. So this is like 49-year-old female, and if sugar knocks her out, and she came to me because of vasculitis. See this one here? Okay. I have a friend who is a cardiovascular guy, and in his office I do share some space, and he sent me this patient saying that he put angiograms and all, nothing is happening, but she has this this blanching sensation, and boom, I put a CGM and this one. Then she says, wow, that's why I don't feel good. But when she becomes hypoglycemic though, when she's now eating low carb, she's feeling fine. So there is many things. I mean, like I'm talking about this whole process because, number one, it is so easy to deliver this. Now, sometimes we are scared. Okay, the reason why I'm able to do this is because I have this tool. I say, I'm not scared to give you all the different things because I'm giving them a tool to help them contact me. So it's like I do something like keto wound care. I mean, I'm just playing. You see this? He's a like guy is a 428, and then his wounds by 10-6 they're healed, and we had angioplasty done, yes. But if you see the leg here, how swollen it is, and now how it is here, and the dorsal. So the guy, I just yes, and then problem is his creatinine was high, and even then I told him that, I monitored him. So the question just comes down to say, you are in India, you're blessed with number of like people to help you. So you just have to come up with tools, techniques, processes. You cannot say, first of all, forget about the patient, forget about the family. It's you. It's you and you and you. How you understand your baseline. I have on my YouTube channel, I have a personalized nutritional thing that I put my journey out there. So because it comes down to you understanding you. Now, then the family kind of gets riled up. And initially, my family was fighting me like crazy. And now everybody's talking, at least doing a little bit of it. So it just comes down to how you understand you, then help your family and slowly expand. And once you see the results, it's like once you see the truth will not leave you. I'm telling you. So it's like one thing what you could do practically is, cut off and institute fasting and cut off anything. See, at the end of the day, we talk all this low carb and all that. The beauty of this whole thing is this is not low carb. It is addiction.
Agreed.
We are food addicts. Everybody, including me. I'm a food addict. And like say it's 10 o'clock in the morning in US right now. I did not eat anything. I'm going to not eat until as long as possible, like maybe until 2 o'clock or whatever, and then I will kill it. But when I do that, I try to do low carb and say if you're not a meat eater, maybe an egg eater, throw some eggs in it and say if you're eating still carbs, maybe do some muscle building exercises. Okay. And then you do the muscle building exercises, even if you're doing carbs, you will do better, and throw a CGM on yourself.
Agreed.
Pay for it, track it. And once you understand it, it's like we should not be the blind leading the blind. It's like that's what the country has become in India. And you see, the model has to be, nutrition first. But how are we doing nutrition first? We are listening and waiting for a drug company to develop a damn drug and help pay a doctor like me to go and give lecture about the drug. But, I do that. But the question is, I do that because, I have to do that. Number one. Number two, but then also, what am I really promoting when I'm doing that is trying to understand the drug and the mechanism, but then go twist it and add what my thing is, So, I mean, it's fun. Let me tell you. I mean, you can see that in my face. I mean, it's fun of medicine. I'm enjoying every bit of it. The reason I enjoy it now more than ever is like it's after 20 years of graduation that happened. I mean, so I'm happy whoever is here is able to listen to this. Please feel free to ask me any more questions, or you can contact me on my Twitter handle at Wound Physician, or you can check my YouTube channel, and I'm on LinkedIn. Bharat knows how to get to me. So,
sure, sir. It will be.
May I ask one more question?
Yeah.
Yeah. Dr. Ravi, did you find any correlation with any of the inflammatory marker, and why I am asking this question? So is there any role of anti-inflammatory drugs like hydroxychloroquine and these, because you have said that these diet may cause insulin resistance, may cause inflammation or subclinical inflammation. So is there any role of anti-inflammatory drugs, and is there any correlation with any of the inflammatory markers like CRP and interleukin and measurable link, measurable correlation?
So with I mean, obviously, yes, there is. That was what I was sharing in the talk. With low carb nutrition, see, here is the thing. We have to understand that carbohydrate, glucose, all carbohydrates are glucose, converted into glucose, okay? Fiber part might not. So carbohydrate is a stiff molecule. It is a stiff molecule. And when it is stiff molecule, it goes and lines the protein and the tendons. And basically, it is if most of the carbohydrates are, say, you see frozen shoulder, don't you?
Yeah.
You see a lot of frozen shoulder. Basically, that is nothing but inflammation because of lining. It's because of glycation, I should say. So any patient of yours who has frozen shoulder, just please check them for diabetes. And the question just comes down to this stiff molecule of glucose is lining wherever it goes, arthritis, inflammation. Obviously, once you take off what is bad, then good happens. Our human body knows what to do. I mean, like it is so primed to do good for us. Our genes are like loaded guns. If we do a good lifestyle, we'll do good. Now, it could be a good lifestyle of vegetarian low carb, or it could be low calorie if people are married to this low calorie. But the problem with low calorie is it is not satiating.
Agreed.
So I could right now, you could put bagels or whatever in front of me, I will not have the urge to eat. So if you say if a nice big piece of chicken or whatever is there and you eat so much, then you can only eat so much. And after that, say yesterday I had lamb chops and some chicken salad and chicken kebab salad and little hummus. And my ketone levels you saw was 0.6, 0.7, 0.8. So the question is, I'm in the low ketone range, but you don't have to be ketogenic. It is all about what I call it as a state of metabolic flexibility. So unless you become metabolically flexible, it is not good. And if you are in a state of nutritional ketosis, your genes express the best. So inflammation, yes, food causes inflammation, and anti-inflammatory drugs are crap. Don't use them because number one, yes, it helps you improve or quickly turn around, but you have to use them quickly, short term, and get off them. And obviously, I mean, like if we are born with our genes, then this is what kind of, you see, when we're talking about drugs and when we're talking about studies, I do clinical trials. I've done 72 clinical trials. What I'm trying to say is that we think about population health. Population is health at one level, but personalizing that solution is what is more important. So we have to avoid mass medicine mindset and come to a level wherein every person is unique. Every person is unique. What works for you might not work for your sister.
Agreed.
So we should conclude, Dr. Bharat. We should conclude now.
Yes, sir. We can conclude the session for today. Tomorrow we will be meeting. If there is no other question, so we can conclude the session for today. Tomorrow we will be meeting at 10 a.m. sharp. We will begin at 10 a.m. tomorrow.
Right. So, Dr. Ravi, excellent talk and congratulations for making us more intelligent and giving the message that initially low carb is important, then low calories, and afterwards inflammation should also be taken care of. If you give just a clinical tip to increase the protein content of vegetarian diet in Indian scenario, if you can.
So basically,
just a simple tip.
Yeah, basically, I guess what is that? pea protein is what is being promoted mostly, but also there is a vegetable, there is a substitute, protein substitute that comes. We can add, like whey protein. But whey protein is also known to stimulate insulin. So, but all the cheese. What is that? What is the cheese that Indians make? The cubes.
Cottage, paneer.
Paneer has a lot of protein. So I mean, like, yes, it's simple, but idea is skip breakfast first. Skip breakfast.
Okay.
Skip breakfast because breakfast is the worst meal of the day. So I'm kind of riling you guys up.
Actually.
Okay.
Because once it was said that breakfast is an important meal.
Yeah, that is marketing people telling you.
Okay.
Kellogg's people telling you.
Kellogg's.
Kellogg's
Ravi
people.
sir is actually a lighthouse. Actually, the more you talk to Ravi sir, the more your I would say concepts regarding diet and metabolic health become clearer. Thank you, Ravi sir, for
Thank you, Ravi sir. Thank you, sir.
I'm doing everyday fellowship. That's why.
Yes.
Every moment is fellowship.
Yes. Thank you.
Thank you, sir. Thank you, sir. Love talking to you, sir.
Thank you. Take care.
And Dr. Hina, kindly thank everyone who is present and please close the session and kindly invite them for tomorrow morning.
Yes, sir. Yes, sir. Sure, sir. So thank you everyone for enjoying this awesome interactive sessions since afternoon, and we'll be more than happy to join tomorrow morning. Everybody is welcome, and we love everyone to join and satiate the knowledge of appetite of knowledge. Thank you everyone. Thank you.
Thank you, Rajesh sir.
Thank you, Rajesh sir. Thank you, Surajit sir.
Thank you, Surajit.
Yes, sir. Yes, sir.
RX team, Dr. Naseem.
Yes, sir. Thank you, Ravi sir. RX team, yeah.
We will meet tomorrow morning, 10 a.m. sharp. We will begin sharp at 10.
Sure, sir.
And we have a very interesting talk of Dr. Undi Krishnan at 10 a.m. tomorrow morning.
Yes, sir.